y tibia. programa estructurado de seguimiento. Doctora Mónica, ¿usted qué opina?
Lo que pasa es que ocurren con alguna infrecuencia, no frecuencia, pero con alguna infrecuencia, grupos que aparecen como brotes.
Exacto.
Pero es porque genéticamente en el grupo humano que puebla esa ciudad se juntaron personas que hacen que esta enfermedad aparezca. Ahí lo importante sería y hace el estudio y se pone más puntudo. Es como al revés, porque como es una enfermedad muy infrecuente, si merecen diagnóstico. O sea, lo que tenemos que, claro, lo que tenemos que hacer es generar un seguimiento para aquellos niños que no son prematuros, pero que son síndromes genéticos, polimalformados. Esos van por otra línea,
exacto,
aunque ocupes el techo canguro, que es de excelencia.
Exactamente. Sí, señor. Muchas gracias, doctora. Hasta luego.
El siguiente trabajo lo presenta Estefanía Allende y el color allí es crédito radiológico en seguimiento del prematuro. Adelante.
Buenos días. Es un honor para mí estar hoy día en Medellín y poder presentarles determinación del crédito radiológico en el seguimiento de prematuros, resultados preliminares del proyecto RADAR, radiación acumulada y determinantes asociados al riesgo. Mi nombre es Estefanía Allende y en conjunto con mi equipo pertenecemos al Servicio de Neonatología del Hospital San Camilo y a la Universidad de Valparaíso, San Felipe, Chile.
De parálisis cerebral. El Registro Colombiano de Parálisis Cerebral es una unión de voluntades. Es una unión de voluntades y de instituciones con base en Medellín, el Comité de Rehabilitación, la Universidad de Antioquia y el Grupo de Rehabilitación en Salud y la Asociación Colombiana de Medicina Física y Rehabilitación. Un registro de parálisis cerebral es más que una sola base de datos. Podríamos decir que es casi un organismo vivo porque cada día hay un nuevo niño que se registra y que viene a cambiar los paradigmas y toda la información que teníamos previa de cómo se está comportando la calidad de vida, el funcionamiento y todos nuestros niños en un país definido. Actualmente en los países de bajos y medios ingresos o no contamos con datos o los datos son incompletos, entonces esta es la importancia de tener registros apropiados. El Registro Colombiano de Parálisis Cerebral está dentro del Registro Global de Parálisis Cerebral para países de bajos y medios recursos y hacemos parte también del Registro Latinoamericano de Parálisis Cerebral. ¿Por qué es importante entonces el registro? Porque nos ayuda a entender la epidemiología de esta condición de salud en nuestro país Colombia y en los países que nos acompañan, que son de bajos y medios recursos. Este estudio entonces es un estudio descriptivo de las características de la población del Registro Colombiano de Parálisis Cerebral, incluidas hasta la fecha de corte. Analizamos los datos socioeconómicos clínicos de las personas registradas en el registro que fueron recolectados mediante un formulario previamente validado en entrevistas a los padres de familia, a tutores o a las personas adultas con parálisis cerebral en instituciones privadas de rehabilitación pediátrica de Medellín. El registro cuenta con aval ético institucional de la Universidad de Antioquia y consentimiento informado de los padres, tutores y participantes. A enero del 2026 contábamos con 204 pacientes registrados. Estos registros se hicieron en centros de rehabilitación pediátrica de la ciudad de Medellín. El 80% de estos pacientes pertenecían a una misma EPS. Las EPS son las aseguradoras que se encargan de la gestión de la salud de todos los colombianos. El 80% pertenecen a una misma de estas empresas y el registro está diseñado para iniciarse en los centros de rehabilitación pediátrica por la logística que implica, pero queremos avanzar más allá, avanzar a instituciones de salud y más adelante a contextos comunitarios porque sabemos que no todos los niños acceden a servicios de rehabilitación y a servicios de salud. ¿Cuáles son nuestros hallazgos entonces? El 56% son hombres, el 51.5% están entre los 0 y los 9 años de edad, el 72% pertenecen al régimen contributivo de salud. En Colombia tenemos, mediante el aseguramiento, un régimen contributivo al que pertenecen las personas que generan pagos al sistema de salud. Ese se llama régimen contributivo y, pues, como les decía, el 72% pertenecen a este régimen. El 85.6% residen en zona urbana. El 97.7% de los niños nacieron en contextos hospitalarios. El 92.4% nos reportaron un control prenatal completo, que para nosotros es haber hecho mínimo 5 visitas prenatales. El 48.5% nació por cesáreas no programadas y el 65.9% reportó complicaciones durante el parto. Respecto a las situaciones al nacer, tenemos un 50% de niños que nacieron con edades gestacionales iguales o mayores a 38 semanas, un 22.7% que nacieron entre la semana 32 y 37, el 20.5% nació de la semana 29 a la 32 y el 6.8% nació antes de la semana 28. El momento en el que probablemente se generó el evento que ocasionó la parálisis cerebral ocurrió durante el embarazo y hasta los 28 días de vida en el 76% de nuestros pacientes. Y respecto a otras situaciones, en el 73% de los niños se reportó un periodo de hospitalización posterior al nacimiento, asfixia en el 55% de los pacientes, 8.3 recibieron tratamiento con hipotermia y en el 61% de la población se comprobó el diagnóstico, o sea, la ayuda diagnóstica con resonancia. Respecto al diagnóstico y a la rehabilitación, tenemos que el 69% de los niños tuvieron un diagnóstico durante el primer año, con un promedio de 9.5 meses. El 57% de los niños iniciaron la rehabilitación antes del primer año de vida. En el momento del registro, el 79.5% de los niños continuaba recibiendo procesos de rehabilitación y el 66.7% de los niños cuenta con productos de apoyo para la movilidad. Respecto a las características del diagnóstico, tenemos que el compromiso motor predominante es la espasticidad con un 57.5%, la topografía de signos predominante es la cuadriplejía, seguida por la hemiplegia y la diplejía, la cuadriplejía con un 42.4%. Y respecto a las características funcionales, entonces tenemos que el nivel de la función motora gruesa, tenemos sus niveles 4 y 5 en la mayoría, los niveles de mayor severidad, para un 21% nivel 4 y para un 40% en nivel 5. El MAX, que es la escala para evaluar el funcionamiento de la mano, es un poco más homogéneo, teniendo entonces aproximadamente un 50% con los niveles más severos y un 50% en los niveles más leves de funcionamiento de la mano. El EDAX, que es la clasificación para el funcionamiento de la alimentación, tenemos que hubo un mayor porcentaje con un mejor funcionamiento para la alimentación sin necesidad de métodos alternativos para la alimentación como es la gastrostomía. Este solamente se encuentra en un 16%, que es el nivel 5. Y para el CFCS, que es la clasificación de la comunicación, tenemos que en los niveles 4 y 5, que son las mayores dificultades para la comunicación, un 50%, y los niveles 1, 2 y 3 tenemos otro 50%, que es un mejor funcionamiento para comunicarse de manera independiente. Respecto a la escolarización, tenemos solamente un 40% de niños que asisten al colegio activamente y un 28% de niños o personas adultas que nunca asistió. Para concluir entonces, tenemos que la población registrada presenta una alta carga de factores de riesgo perinatales, con predominio de complicaciones durante el parto y signos de asfixia. La parálisis cerebral es la forma más frecuente en este grupo poblacional que reportamos, con una gran proporción de necesidades para la movilidad y el funcionamiento, y que, pues, a pesar de que la mayoría acceden tempranamente a la rehabilitación, tenemos grandes barreras para acceder a los productos de apoyo y a la educación. Estos hallazgos posiblemente no representan toda la población colombiana porque es un pequeño segmento, como les conté al inicio, tiene limitantes porque estamos en Medellín, estamos en una población limitada en un centro de rehabilitación y buscamos que cada vez tengamos más datos y que podamos incluir probablemente estos niños que no se están registrando con compromiso menor unilateral y menor compromiso funcional. Cada niño que ingresa al registro amplía nuestra comprensión de la parálisis cerebral y cada dato nos acerca a decisiones más justas, más humanas y basadas en la realidad. Los datos cambian estadísticas, pero cuando los unimos y nos unimos todos nosotros, podemos cambiar vidas. Muchas gracias.
No hay tiempo para preguntas. Pasamos al siguiente trabajo, por favor. ¿Me pone el que sigue, por favor? Bueno, el siguiente trabajo es BCR en la primera semana de vida, más allá de la prematurez, carga de enfermedad para una corte neonatal colombiana. Presenta a Andrea Jaramillo Cerezo.
Bueno, muy buenos días para todos. El día de hoy entonces vamos a hablar un poco sobre el impacto que tiene el sincitial en la población neonatal, un tema que es poco estudiado y poco indagado. Todos sabemos aquí los presentes la carga importante que tiene la infección por sincitial al ser la primera causa de hospitalización y de infección respiratoria baja en los lactantes. Representa 1 de cada 50 muertes que ocurren en los niños menores de 5 años y representa más o menos el 25% de las hospitalizaciones. Este año, a principios del año, aparece una publicación de Lancet donde nos permite aclarar un poco más qué sucede semana a semana con este virus en la población y nos da un dato muy interesante y nos habla del periodo de mayor riesgo que son las primeras 8 semanas de vida, donde nos hablan que existe el 20% de la mortalidad intrahospitalaria en estos pacientes y el 23% de los ingresos y de las necesidades de la mortalidad hospitalaria y el 20% de los ingresos a UCI. Hablar de sincitial no es solo hablar de la infección aguda, del ingreso a UCI, del requerimiento de ventilación. Y ya el doctor Cristian Rosas en su corte Inspired nos habla de cómo prevenir la infección grave en el primer año de vida. Nos reduce hasta en un 26% el riesgo de asma a los 5 años en estos niños. Y pues adicionalmente tenemos un grupo poblacional en donde tenemos un alto riesgo, tenemos un sistema inmune que está supremamente inmaduro con un déficit en la respuesta a interferón y tenemos una respuesta TH2 desregulada y adicionalmente en la población que es prematura vamos a tener entonces un desbalance y un IFI 27 que nos predispone a mayor severidad, mayor ingreso y mayor requerimiento de ventilación mecánica. Con todo esto ya dicho, entonces tenemos que son niños que están vulnerables, que tienen adicionalmente en su sistema inmune algo que los predispone a enfermedad severa, pero tenemos una población como lo son los neonatos en la que no se ha explorado cómo se comporta este virus. Es por eso que quisimos caracterizar las características clínicas, valga la redundancia, y los desenlaces en esta población, y no solo eso, sino compararlo con la infección no sincitial en esta misma población neonatal. Para esto entonces diseñamos un estudio observacional de cohorte retrospectivo. Incluimos pacientes atendidos en 2 instituciones de referencia aquí en la ciudad de Medellín entre 2017 y 2018 y 2022 y 2024, todos aprobados por comité de ética. 520 pacientes fueron elegibles finalmente tras correr los criterios de elegibilidad y exclusión, 372 fueron incluidos y 30% de estos pacientes cumplieron el diagnóstico de sincitial confirmado. Dentro de las características principales quiero que nos llevemos a la casa varios puntos importantes. El primero, la edad mediana de ingreso fue de 16 días de vida, diferente a lo que vamos a ver en el resto de las cohortes más adelante. Lo segundo es que la gran mayoría de neonatos no tenían ningún antecedente de comorbilidades o antecedentes perinatales relevantes, solo el 8% comparado con lo que nos ha dicho la literatura fueron prematuros. Las características clínicas de ingreso principalmente fueron la taquipnea, la hipoxemia, la dificultad respiratoria. La principal complicación fueron las atelectasias en esta cohorte fue de 0 pacientes, el 25% de los pacientes requirieron uso de cánula nasal de alto flujo y casi la mitad requirieron ingreso a la unidad de cuidado intensivo. Hablando un poquito de microbiología, tenemos unas instituciones que todavía están usando y tienen muy a la mano el estudio antigénico para infección respiratoria viral, y esto nos limita un poco en saber la ecología del comportamiento de los demás virus respiratorios. Sin embargo, algunos tuvieron diagnóstico por prueba molecular y nos permitió establecer el rinovirus como el principal agente en coinfección. Cuando comparamos entonces ambos grupos, tenemos que el niño con infección por sincitial tiene más dificultad respiratoria, falla respiratoria, taquipnea, hipoxemia, ingresa más a la unidad de cuidado intensivo e requiere más soporte respiratorio no invasivo. A diferencia de lo otro, tiene estadísticamente significativo menor frecuencia de fiebre al momento de la consulta. Y para nosotros ha sido todo un reto, y esto representa lo que es la estrategia viral en la ciudad, y es comparar esta población con el resto de poblaciones en el mundo. Solo existe un reporte en el mundo en el 2013 en Corea, donde compara la infección sincitial con no sincitial, y están de acuerdo, aunque ellos excluyeron pacientes con algunas comorbilidades, en que los pacientes con infección con sincitial tienen mayor severidad y mayor ingreso a las unidades. Los datos que van a ver que comparan nuestra población con el resto de las poblaciones son datos extrapolados de cohortes más pequeñas, y en donde sincitial sigue siendo la principal causa de ingreso. Tenemos alta tasa de registro en nuestra cohorte, sin embargo ya hablamos de la importancia de hacer pruebas moleculares. La coinfección concuerda con nuestra coinfección, que fue rinovirus, y en nuestra cohorte tenemos edades de ingreso más recientes, más precoces y comorbilidades menos frecuentes. La frecuencia de las manifestaciones clínicas, digamos, se comportó de manera muy similar en las cohortes. La gravedad de nuestra cohorte fue mayor comparada con las cohortes internacionales, y nuestra mortalidad se parece mucho a la mortalidad en países de altos ingresos. Para llevarnos a casa 3 datos importantes. El primero es que sincitial sigue, y esperemos que no por mucho tiempo, será el principal agente implicado en la infección respiratoria neonatal. La infección respiratoria ya no está solo comprometiendo pacientes de alto riesgo, prematuros, de bajo peso, sino pacientes sanos, sin ningún tipo de antecedente. Y la última es una invitación para que entre todos sigamos construyendo datos en Latinoamérica que nos permitan construir estrategias de prevención, no solo en poblaciones de alto riesgo, sino también desde la gestación y durante el primer periodo neonatal inmediato. Muchas gracias.
¿Tenemos tiempo para una pregunta concreta o una puntuación?
Muy bien, hay poquito tiempo, pero felicitaciones. Y con estos datos de Medellín se puede pelear con las autoridades el uso de nirsevimab. Es altamente costo efectivo, y todos los niños que nacen, no solamente los de riesgo, sino todos los que nacen, pueden ser protegidos. Muy bien, felicitaciones.
Muchas gracias, doctora.
Muy buenos días para todos. Sean bienvenidos a la segunda jornada académica del quinto Congreso Internacional de ASEPNEO. Muchas gracias a los autores y coordinadores de la sesión de trabajos científicos por fortalecer. ¿Falta uno? Ah, no sabía. Listo.
El abordaje de la lactancia en el primer escalón del seguimiento. Victoria Rizzo.
Bien. Buenos días. Gracias al ASEPNEO por la posibilidad de presentación. Mi nombre es Victoria Rizzo, trabajo en el Hospital Zonal Especializado Materno-Infantil Argentina Diego de Azul, República Argentina. Mi trabajo se llama Abordaje de la lactancia desde neonatología, primer escalón del seguimiento. Bueno, la situación en nuestro país, según la encuesta nacional de lactancia del 2022, es que más del 90% de los niños y niñas inician lactancia, solo alrededor del 53% la realizan de forma exclusiva en los primeros meses, y el porcentaje desciende a 45% a los 6 meses. hay una brecha importante, como ven, entre el inicio y la continuidad. En los niños de alto riesgo, esta situación se complica aún más y hay diferentes factores que pueden jugar en contra de la lactancia, como ser la internación prolongada, la separación madre-hijo y la mayor intervención médica, que esto dificulta el establecimiento de la lactancia, aumentando el riesgo de abandono precoz. Nuestro objetivo en el trabajo fue relevar el tipo de alimentación al egreso neonatal, identificar oportunidades de mejora e implementar estrategias que fortalezcan la lactancia desde esta etapa. ¿Qué utilizamos? Utilizamos la base de datos de ASEPNEO, que la utilizamos para los niños que ingresan al seguimiento de alto riesgo, donde podemos especificar la alimentación y ahí podemos ver cuántos niños egresaron de alto riesgo con leche materna exclusiva. Nuestros resultados: de un total de 63 niños y niñas evaluados, el 13% egresan solamente con lactancia exclusiva, el 87% con otra alimentación. Este dato refleja no solo una dificultad, sino una clara oportunidad para intervenir. ¿Cómo intervenimos? Diseñamos un proyecto junto al consultorio de lactancia, que pertenece a nuestro servicio de obstetricia, para fortalecer la lactancia durante la internación. Se implementaron estrategias de promoción, de capacitación del equipo y acompañamiento de las familias. El objetivo general fue promover y sostener la lactancia materna en los bebés internados en el servicio de neonatología, favoreciendo que al alta logren lactancia exclusiva o predominante. Los objetivos específicos: brindar acompañamiento especializado a madres y familias durante la internación, fomentando la lactancia materna y el vínculo madre-hijo; capacitar y asesorar al personal de enfermería y residentes médicos sobre técnicas de apoyo a la lactancia; identificar precozmente dificultades y coordinar el seguimiento post-alta desde el consultorio de lactancia, además de generar registros y estadísticas. Las actividades propuestas fueron visitas diarias al servicio de neonatología, estar presente en el momento de la primera toma o extracción de la leche, coordinar con el consultorio externo para el seguimiento, registrar casos y evolución, realizar diferentes tipos de talleres de contacto piel a piel, favorecer la lactancia materna, hablar con mamás y papás dentro de la neo sobre la importancia de la lactancia, talleres de masaje, de sueño seguro, entre otros. Además, se generaron espacios breves de capacitación al personal. Esta intervención se enriqueció porque se realizó de manera interdisciplinaria con obstetras, enfermeras, médicos, pediatras, neonatólogos y siempre en el centro la familia y el paciente. El impacto permitió una mayor sensibilización del equipo de salud y una mejora en el acompañamiento a las familias, instalando la lactancia como un eje central del cuidado neonatal. Nuestras conclusiones fueron que las tasas de lactancia en la población de alto riesgo son bajas, pero pueden mejorarse mediante estrategias simples, sostenidas y con un enfoque interdisciplinario. El propósito: estimular a otros equipos de salud a relevar sus propios datos y utilizar esta información como herramientas para generar intervenciones concretas de bajo costo y de alto impacto. Como 3 ideas pilares que sostuvieron y sostienen este trabajo es que el seguimiento de estos niños no comienza en el consultorio, sino antes del alta neonatal, que la base de datos de ASEPNEO nos permitió traducir información en acciones concretas y lo que no se inicia en neonatología difícilmente se recupere después. Muchísimas gracias.
Por orden de tiempo vamos a terminar aquí. Adelante, Nati.
Agradecemos a los autores y coordinadores de la sesión de trabajos científicos por fortalecer la construcción de evidencia regional y seguir conociendo la realidad y el seguimiento pediátrico y neonatal en América Latina. Vamos a continuar con una mesa de gran relevancia para la salud de nuestra región: inmunizaciones en Latinoamérica, calendarios y programas exitosos. Coordina la doctora Lidia Gudici, pediatra neonatóloga, ex coordinadora del Programa Interdisciplinario de Seguimiento del Recién Nacido de Alto Riesgo del Hospital General de Niños Pedro Elizalde de Buenos Aires, Argentina, directora de la carrera de especialización en desarrollo infantil de la Facultad de Medicina de la Universidad de Buenos Aires, miembro fundador y directora académica de ASEPNEO. Y el doctor Alejandro Macarrone, médico pediatra neonatólogo, subjefe del Servicio de Neonatología del Hospital Centenario de Rosario, profesor adjunto de la primera cátedra de pediatría
of the Pediatrics of Universidad Nacional del Rosario. It's associate of the Universidad Abierta Dominicana founding member and the secretary of ASEPNEO. Please be welcome to this second day of the fifth International Conference of ASEPNEO, and I hope that this is as a wonderful session as the one we had yesterday. Good morning, everybody. Thank you. Okay, first of all, I'm going to have Dr. Fernando Burgos, who is a pediatrician. He's an expert in Down syndrome. He's a member of the scientific department of Fundación Vacunar on the second place. We will have Doctora Martinez Celia. She is a pediatrician, infectologist. She has a master in immunology science. She's an adjunct professor of pediatrics and a coordinator of the pediatric infectology postgrad of the Universidad Nacional de Asunción. She's also a member of the vaccine committee of SLIPE. And also we're going to have Dr. Beltran, who is an infectologist pediatrist of Clínica del Rosario, Clínica del Breda, and she's the coordinator of the infectology and vaccine committee from the, and now Dr. Burgos will be online. Whilst we try to get Dr. Burgos' connection, who we deeply thank because he wasn't unable to fly and be here with us with some comments about this discussion. We already know that the vaccine coverage, it's descending. Vaccine coverages are descending, especially after the pandemics, and we also know that there are so many groups that provide misinformation and that don't avoid for an adequate vaccine coverage between amongst many other causes. That's why I think that this is a very necessary space to be able to have very clear tools to combat this descent in vaccine rates that we do know that affects the populational coverage. Fernando, are you there? Can you hear me well? And therefore, I'm sorry, I have some personal issues, and that's why my talk it's recorded, and it's okay. My talk it's recorded, so and I'm gonna be available for Q&A so that we can improve vaccine coverage in the region. What's in pediatrics, I work in outpatient pediatrics of the hospital in Buenos Aires, sleep in. I'm a member of the scientific member of Vacunar, and I coordinate a clinic with children with Down syndrome for more than 20 years. When we talk about communication and when we talk about vaccine safety, and also when we talk about community and we talk about security, I think we need to talk about vaccines and safety, because towards through communication we transmit the message. There's some issue with the recording. Okay, without what we can say, okay, there are some issues with the recording. Accept the vaccines. We can say that we have the anti-vaccine group, and especially we're a very basic vaccine and not evidence-based, and there are also the groups that are unwilling. This okay, we reinitiated the recording. I wasn't able to be in Medellín because of personal issues. I'm so grateful for the invitation. We are going to talk about a very interesting topic because it's a topic that sets us in a competition as neonatologists and for all kinds of specialists that it's trying to do a humanized and humanized medicine based on the safety and the security of immunizations. I'm a pediatrician. I'm the president of I'm the chief of the outpatient pediatrics of Universidad Clinic, and I'm the owner. I'm a member of SLEEP, a member of the scientific committee of Vacunar, and I coordinate a clinic of children with Down syndrome for more than 20 years. When we talk about communication, and safety, or when maybe we should be talking about communication and safety, because through communication we transmit the message that although it has to be very plain for the communities and for the patient, when we talk about trust, communication, and immunization is key for the acceptation, for the acceptance. And those that don't accept, we can talk that they are the anti-vaccines, and maybe maybe they have a perspective that is not based in real evidence. And then we have the groups that maybe because they are afraid, or because two terms that we have learned in the last years, and that many times social media or the amount of channels in the communication confuses the patient, the mother, and the father, knowing that the vaccines, either if it's the pregnant woman, neonate, or youngsters, and even we can use it for adults. The problem of the lack of information and the lack of trust affect the coverage up to the point that if we think at a global level, we are below 70%, as it happens in Argentina and other countries in the world, below 80%, where the target population has to be above 85 and 90% to be able to achieve the effectiveness of the vaccines. And as examples, I can say in my own country, the VPH vaccines, we are below 52% for kids, and as happens with the third dosage, when we have a drop for the triple cellular bacteria. And as you can see, we also have the problems of the VCG vaccines for the ones that use these vaccines for TB, and also the parents don't want the hepatitis B vaccine, that we know that it's a very good way to avoid vertical contagion. So that's why the misinformation and the lack of trust are key, and it's how we are based on in hard data. This work and published in Lancet talks about the 50 years of the expanded immunization plans, where we know that 144 million deaths were avoided with vaccines, and 146 millions in people under 5, and 40% was the reduction in child mortality worldwide, basically because of the vaccines. This global impact, it's very important because we do know that vaccination is not an individual act, but it's a collective act. The higher the amount of people vaccinated, we're going to have a herd effect, and this herd effect or these community vaccination effect allows all the vaccines to be effective. But we also live in countries where the inequality, you know that inequality, it's defined as this lack of resources, in this case health resources, as an immunization or a vaccine can be for someone that needs it. And this is also associated to the access to health. And countries that are the low and middle income countries have a lot of inequality, the lack of the cellular triple bacteria, or also they don't apply the VPH vaccine. And what's the reality that we have? It's the drop in coverage, the digital infodemia, that it's covered by opinions and not by experts and by non-scientific sources, or even a topic to cover that it's colleagues that because they do natural medicine, they don't prescribe vaccines. There's an expanded role of the doctor, where you know that they're not just they are communicators, and also the need of all us of us of us knowing what are the communicational skills. All in some moment can talk and even share information that it's not real. We can say that technology, it's very easy to share with a single click, but they can become in the clicks of death. In the case of fake information about vaccines, regularly in moments of crisis, we also have half truths, or according to how you tell the story. If there's a lot of emotion to the narrative of an acting vacciner, this can transmit a very simplistic perspective of a very complex reality. Studies of PAHO show the lack of trust in some vaccines, even as we say by some of the health workers, and the setback of if we have someone, either these people needs to trust the vaccine so that both so that everything follows through. We even have the misaccreditation of the biologics that comply with quality standards. We know that biologics fulfill quality standards and phase 3, phase 4 clinical trials, and we know that there is a lot of safety, and also the surveillance and the safety surveillance to be able to show how safe a vaccine is. All of this increases the resistance towards vaccines. Which of the coming factors contribute to the lack of trust to vaccines? Think about the wrong information in social media, the increase in ineffective vaccines, the implementations of education programs. We also need the better healthcare and professionals. And what is the real response? Is the real response? It's the dissemination of fake news. It's something that generates a conflict. What it and leads to misinformation and low vaccine coverage. There's an important point, which is trust, and trust needs to be something very important, because remember, the trust in the health system, it's not something that it's built. And that's why it's the opportunity of being with a patient, or to be with a patient that it's admitted, or when many of you that are neonatologists have a patient that is being discharged, that it's the only moment when we can pay with the caregiver, with the mother, to be able to comply with the vaccines. You know that in prematures are very sensitive populations, premature with premature babies, according to the chronological age they can receive They're the monoclonal antibodies in those that have been born prematurely and have no coverage of the maternal vaccine for VCA. The relevance of the trust depends on also the safety perception, but also the perception of the disease. When we don't see the disease, it's when we where trust is lost. Remember that when there's a pandemic and the epidemia, the perception of the disease increases, and that's why the vaccine coverage increases. And now there's a drop because we start losing the perception. And when there is an outbreak, when we have an outbreak of chickenpox, we started to perceive, and sometimes we can improve the coverage. But this is associated how we communicate this. That's why the credibility are you. There, it's we did well, there was a work done at a children's hospital before the pandemic where 92.3 that were surveyed regarding how if they trusted vaccines, they would trust what the doctor says. How do we tell them and how they would say them? Remember that there is a systematics of communications that is associated to the presumptive and persuasive method. When we talk about a specific vaccine, the attitude of the physician has a lot of influence, and that the parents that receive information from the doctors have less concerns that comes from friends, and always the information of the doctor. It's the main reason why the parents that were thinking of rejecting a vaccine, they changed their opinion based on an active talk with the doctors regarding the barriers and communications. Of course, we already talked about lack of trust. The lack of trust, it's something that it's part of the human beings, but a lot of that lack of trust has to be supported by by the scientific source. What is the support that the person that is giving an indication has the influence of misinformation, the lack of training in communications for healthcare professionals, and we also have cultural, political elements that affect. You know about religious, cultural situations can affect public health, and public health it's one. We have a free public health that one receives in a public hospital or in the private institution because the health of that person is unique, and that's public health. There are religious contexts. There's a very classic example that the smallpox that was done by aborted embryos, and then we can see that we did it that way. Those cells were cultured. They're called immortal cells, and that's why we do this. The vaccines, and there are many beliefs taking into account that these were cells of aborted embryos. That doesn't have an effect. For example, in the Vatican Concilium, we're able to establish that these immortal cells are essential for vaccines that improves the public health of people. Heidi Larson, that is an anthropologist of UK, for a long time, even before the pandemic, did something that was called the Trust in Vaccines. This is a project called Trust in Vaccines, and she said before the pandemic that the next cold flu outbreak, it's not because of preventive methodology. However, the emotional contagions, it could affect the trust of vaccines to nowadays. The vaccines are not something that can't be arguable. There are many vaccination programs. Even some vaccination problems create lack of trust of the population regarding vaccines and immunizations. Are this amount of wrong information in social media can be considered to a global threat towards public health. The impact of misinformation in social media creates anti-vaccine movements and the myths that are associated to vaccines that are not real. According to several studies about which of the following statements do you believe it's right? Most of the people prefer information about vaccines that come from self-help books than doctors. The patients that receive information about vaccines from the doctors tend to have more concerns regarding vaccinations. The attitude of healthcare professional has the information about vaccines has a higher significance than the ones of doctors. Obviously, the answers is what's the answer? It's C, because the attitude of healthcare professional has a huge influence. But that attitude needs to have a very straightforward communication and scientific based and also very clear. What are the strategies to improve the use of a clear and accessible language, active and empathic listening with the patients to combat myths with scientific evidence, and also to use the statements from doctors and that use of the narrative. You as healthcare professionals are the most reliable source of information. That's why we need to develop it using any communication channel, either in the office next to the incubator, along with the nurse when we have a high risk or a follow up risk conversation. Whenever we can say that we need to talk about immunization. Immunizations are part of the common visit. It's clear that we need to promote the vaccines as it happened on May 25th, the immunization weeks, to be able to promote vaccines. And when we talk about networks and social media, in this case, I am part of Fundación Vacunar, where I'm responsible of the communication department, and also my social media, where we have an increase of many doctors that show the most important aspect of what's the health promotion. And also with many neonatologists that talk about, and therefore, if we add vitamins, and if we could talk about microbiota, and we need to leave a space for the emotions. You need to be, because you need to appear human, because a lot of people follow you if you, but you need to be very emotional, but with scientific sources. We need to monitor the strategies. We need to use influencers, and we need to have educational campaigns. There's a very interesting document of PAHO that says that understanding the anti-vaxxers is hard, because many of them have philosophical or religious drivers, and this generates social resentment and mistrust. How to act? We needed to acknowledge the emotions in the experience without being condescending. We don't need to make fun of them or no, because being despicable increases marginalization. The idea is to have clear arguments, which we do to collaborate with parents and colleagues that are not anti-vaxxers. It's good. This misinformation, well, can come from fake news, where that act, that affects the trust in immunization programs, and the business of influencers that make millions selling supplements, business, books that are associated, epigenetic tests that improves your microbiota and your immunity, creates information gaps. They use emotions, and that's why we need to overcome that misinformation techniques, like the death of a baby. A baby dies after being vaccinated. Imagine what this causes in people. Or the virus of pharmaceutical industries to create more vaccines, to create fake accounts in social media. It's a way to do this and to deliver these messages, like a study by Dr. Whatever shows that child vaccination reduced the IQ by 10 points. Imagine if this information is replicated, and this also creates lack of trust. If the vaccine is not efficient if it shouldn't be used, we need to trust nature and the natural immunity. Of course, someone that says this and had never had a baby that died, or didn't have a baby in an NICU because of or hasn't had a patient that's being followed up because of meningitis and amputated limbs. These are examples, because the doctor says that the risk of vaccine-related myocarditis is very high, and this happened with COVID vaccines. my my neighbor vaccinated against the flu and he caught the flu. Did you see what happened to the neighbor got vaccinated and the kid was declared as an autist, and this creates lack of trust. That's why it's very important that we work with evidence, and this is very interesting because we can detect suspicious cases and to see if the information is legit or not, and we can share this with the patient so they can understand if the information is fake. We can do this, combat this using social media, enabling bi-directional channels and mechanisms to be able to address rumors and doubts. Not long ago, we worked with Dr. Maria Luisa Avila and some physicians from Sleepla with pre-banking. And get ahead of myths allows us to speak in a very safe and efficient manner so that we are able to build the trust in vaccines. And we always says when we need to try to correct the wrong information that has been already published to show the real publication of what we're saying. Please be mindful that as healthcare professionals, we have the mandate to reflect the sources of information. We need to be trained in all the technical aspects of the vaccines, but also in the communication and the management of misinformation or infodemia. We needed to work with the communication teams, with doctors, with marketing teams to do active listening and to try to listen and try to address the myths and the rumors.
In communication, this is very important because we need to correct the misinformation, to work with the communication teams, doctors, marketing teams, to do a social listening, to learn to listen to the patients if needed, to be empathetic and to not judge, educate the population, and report the false information to the communication teams. There are some regional examples that we have, like in Brazil, where they have a strategy to fight against misinformation. We have a site called Chequeado to verify if this source is true or not. The training sessions in Bolivia, Peru, and Colombia that have to do with a lot of information regarding vaccines. So, trying to improve the perception of the communication when you indicate a vaccine, to understand really the vaccines that you're using in each country, to talk about complicated schemes, and to try to take advantage of these opportunities. Here, I can share with you. You can scan the QR code, and we have a guideline for the healthcare workers, for the communications team, educators, and also some tips for the journalists and influencers. This is a very good guideline done by the PAHO. So remember, if we do a very strong communication based on the sources of information, I'm pretty sure that the patients will understand, making sure that the vaccines have positive effects, always generating empathy. I'm pretty sure we will improve the coverage. I would like to thank you and say that communication is key to have trust in vaccines. We need strategies based on evidence, and also training of the healthcare professionals has to be a priority. And we are already doctors with a lot of experience, but we need to train the students. We need to say that this relationship transforms. Science is done by the brain, but also is done by the heart. So thank you very much for your attention. It's a pleasure to be able to participate in this very important ASEPNEO 2026.
Bueno, muchas gracias, Fernando.
Thank you very much,
Ahora
Fernando.
vamos a seguir con
We will continue with successful strategies in Paraguay with nirsevimab. Thank you very much for the invitation to this Congress. Good morning to you all. As Alejandro already mentioned, I'm going to share the experience that we have in Paraguay. During the next 15 minutes, I'm going to share some results and outcomes in my country. As you will know, the VRSV represents 60% of the respiratory diseases in children, and the vast majority is in newborn babies and preterm babies, because you can see much more than other bacteria. And as I already mentioned, 80% in children that are born healthy. We have a lot of tools for prevention, and we're going to share specifically nirsevimab. Nirsevimab is approved in more than 60 countries and recommended by scientific societies in 40 countries. And technical committees have really approved that in 32 countries. Here we have 3 countries throughout the world that are Spain, Chile, and Paraguay, where it is implemented as the only strategy in prevention, the nirsevimab. Here we have nirsevimab. Nirsevimab, which is a monoclonal antibody of prolonged action, has a lot of power neutralizing to prevent PRIEF and avoiding the bronchiolitis. So protection of nirsevimab is direct through the administration, intramuscular administration of antibodies. Is very fast because the next day it can act. It doesn't need the immune system of the newborn, and it has a long-lasting protection due to the modification of the antibody of the FC portion with a half-life of 71 days. Here I want to show you the experience of Galicia, Spain, and Chile, where they were able to observe 89% in the amount of hospitalizations compared to previous seasons in Galicia. Of 453 cases, they had 43 hospitalizations with the introduction of nirsevimab, and a reduction in Chile of 90% regarding hospitalizations compared to the previous seasons. Nirse in the previous season, again, this hospitalization, and with Nirse 950 compared to the first season. It's very important to highlight that to complement this strategy, we need to consider what is epidemiology, circulation of the virus in each country. And likewise, we have the timeline of implementation of nirsevimab in Paraguay that started in 2024. Our first season was in 2025. In 2024, the Paraguayan Association of Pediatrics recommends and decides to start a process to be able to implement this program. It starts with consensus, and we're going to see all what happened. Here we can see on the 13th of March a consensus interinstitutionally with scientific societies, universities, and several hospitals. This consensus was published in the Pediatrics Journal in May and August, where the Paraguayan Society recommends the inclusion of nirsevimab as only one strategy approved by the LACTAP of Paraguay, which is the National Association of Immunization, COTENAI, and this recommendation was sent to the ministry. Afterwards, a study was done of cost effectiveness, where it's estimated the cost of the effectiveness of nirsevimab compared to the strategy that we had before, which was palivizumab for the prevention of respiratory viruses. And we can see here the reduction in hospitalizations and NICUs with mechanical ventilations, and also outpatient visit, which would be a savings of $14.6 million for Paraguay in just one season. in this respiratory sisters virus. Therefore, we did advocacy to the Ministry of Health with the senators in the Ministry of Economy, and you can see the different images with different authorities of the country. This was very important for us to see the President of the Senate speaking to all the people, showing what had happened in Chile with the President's message and recommending the inclusion for the prevention of these infections. As a campaign, also in the Regional Congress of Pediatrics, we were able to share a letter signed by thousands of pediatrics was sent to the ministry. And now in August in 2024, we have a technical committee conformed by different directions and vice ministries of health to establish the guidelines. Here we can see that the circulation of the respiratory syncytial virus is seasonal, and we also have a period of circulation of around, let's say, April and August and September. This is why it's able to define a strategy. We can see that the children that are born before the circulation of the virus or before the season must receive their vaccination on April once the campaign starts. And those who are born during the season with a hospital strategy since they are born. It's important to highlight that in the first season, Paraguay bought 40,000 doses, and the strategy, therefore, was from January towards July. Currently, in the second season, with 60,000 doses, we are starting to administer to those born among November 2025 until March 2026, and afterwards who are going to be born from April till July. So here we have the launching done on the 28th of March. And it's very important to say that Paraguay wrote a new chapter in the history in prevention of respiratory infections. Here we can see the first baby vaccinated and the first baby boy vaccinated. Here, I would like to say that Paraguay has a nominal registration of vaccines, and for this to be very effective and to really apply coverage, it was included the virus was included, where we can see registered by healthcare center the amount of babies born with name of the mother, and the vaccines already in the calendar. You can see that it has VCG, hepatitis, and also the virus. That is why we were able to do a meeting led by the Vice Ministry of Health and authorities, also to be able to do a follow-up of each of the cases to be able to have a very broad coverage. We can see here different images of people going by boat towards the indigenous vaccines, sharing the information of these diseases. It's important to say that those who were born during the season had a coverage of 94%. We had more doses of 50 milligrams that are for babies that weigh less than 5 kilograms. And we had others that were born before season of 49% due to the small amount of doses, less than 100 milligrams. Here we can see the results, outcomes of 2025 compared to the previous years, and we saw there was a very important reduction in hospitalizations and in those born during the season and those who were born in the CACHAF group. Not eligible children had the same amount of cases compared to the previous years. This shows that there was a very important circulation of virus, and also we have a very important reduction in those that were born during the season and those that were not born during the season compared to the previous years. And we can say that here are the outcomes. The Ministry of Health informing 14,000 babies protected, 70% reduction in hospitalization, and 0 deaths by the virus in less than 6 months. Afterwards, I wanted to show you this work that compares nivolumab with the mother's vaccine. It shows 26% of less risk of hospitalization with nirsevimab compared to the mother's vaccine, 42% less risk of entering the NICU, less use of therapy, and also less use of oxygen therapy. So we have some logistics, the economic impacts of two strategies. We have also challenges on communication and safety. This is why we have two strategies and includes that we had two strategies. So nowadays we have only one. We have the new consensus of Paraguay that reviewed all the data, the literature, all the information of Chile, Galicia, international data, which is the work that I showed you comparing the strategies, and recommends the country to continue using the just one strategy for the prevention of the virus. This is the summary that the consensus has. The conclusion, the final message. Nirsevimab has shown to be very effective, safe in the population in real life. This evidence supports nirsevimab as the best option, highest effectiveness to prevent the virus. Paraguay is one of the countries in the world to be able to include this strategy, and to mention that Paraguay has also decided to continue including a protection of babies less than 6 months of age. Thank you very much. Okay, let's talk about strategies. Continue. I would like to hand the floor to Dr. Claudia Beltran. Good morning to you all. Thank you very much. Thank you very much for the organizing committee for this invitation. For me, it's an honor to be here with you today talking about these topics, because I'm really interested in the newborn babies. So the idea behind my talk is the mission today is talk about this, strategies to expand coverage and protection in high-risk newborn babies. What I would like to share with you today, apart from the evidence that exists, what are the strategies that have much higher impact to improve protection in these newborn babies? It's going to be accompanied by some practical recommendations that are born from my own clinical experience. This is my conflict of interest, doctor, pediatrician, but as I've been saying, what I'm going to talk about next is based on evidence and some personal recommendation, or maybe personal reflections faced with what we need to improve to be able to prevent infections in this high-risk population. This is the reality right now. There are different studies, and there are studies in this country where it's being assessed how well are we in coverage and protection with newborn babies. We've seen in different studies in the region how we have a delay, and this is the reality, not only in ICUs, but also in follow-up. There is a delay in the vaccination scheme in all of these babies, because we lose opportunities, because we have fear, and because there is lack of knowledge regarding what are the recommendations that we should give in the NICUs. We see a lot of opportunities lost when babies are discharged, and one of the main vaccines that are lost are the vaccine, the BCG against tuberculosis, and polyoral, because there are countries that are polyoral. So those are the two vaccines that are being lost. Currently, this oral poly is replaced by rotavirus, because there's a lot of fear in the vaccine in the NICUs. Now there's another mistake that we still see in the units, the inappropriate use of corrected age and not chronological age. So it's been shown, it's been recommended that the vaccinations in newborn babies should be done according to the chronological age. And this is a message that I want you to take home, because we need strategies to improve coverage. There are some clinical conditions that definitely we need to consider that will increase risk. Generally speaking, those babies that have congenital cardiopathies, that have some are immunely compromised, or maybe with HIV, or that have Sturge diseases, and also pulmonary dysplasia. It's important remembering the message is that all newborn babies are at high risk because it's the most vulnerable population. We know that the conditions that the newborn baby has, and also the preterm baby even more. That's why they are at higher risk of getting ill. So we have a very important opportunity in which these interventions that we do for them will change their own story. So it's very good to think about the baby at risk, but it's important to think that the newborn baby is the highest vulnerable population where we need to focus all our interventions to step out of this risk discourse to an equality discourse. You can see some information based on evidence. When we need show that with data in which we see the tosferin, the pertussis infection really is very, very heavy in the population less than 1 month. Pneumococcus also is worse, highest risk of dissemination, invasive pneumococcal disease, and mortality. Due to rotavirus, also there are much more deaths by rotavirus. Meningococcus, for example, that I'm going to show you in another slide, is also has a lot of complications. So here we have strategies that I want to share with you today, and we can reflect upon. First of all, the principle of chronological age. There's a scientific justification faced to the immunogenicity, the window of risk, and safety. There is no evidence of severe systemic events related to vaccination on chronological age. There's evidence that they're immune, that the newborn baby produces antibodies and is going to be protected. And there's evidence of this risk window that I was saying. What are the guidelines of the different scientific associations? That definitely the vaccines should be administered according to the chronological age, independently of weight, in some recommendations, like in the guideline of healthcare secretary here in Colombia, BCG, we need to have a certain weight, but 2000. But there's still evidence in which BCG can be safe in other children. The only prerequisite for vaccination is the physiological stability. Prolonged hospitalization is not prone to start vaccination. The first strategy should begin in an ICU and due to chronological age to guarantee coverage and protection. Here we can see this graph. If I vaccinate on time, I'm going to arrive to a final age of vaccination in which all the time I'm going to guarantee higher protection. Because sometimes we say, it's okay, let's not vaccinate, wait until we have a window and we vaccinate 1 year after or 2 years after. Each one, every time I'm going to the yellow line, I'm delaying the vaccination. What I'm doing is I'm creating some nodes, susceptible nodes, and these susceptible nodes not only generate more diseases for this patient, but for the rest of the population. So this is what we need to avoid when we vaccinate the newborn baby. The second strategy, part of the first strategy, is that vaccination should be done in the NICU in some scenarios. Like, for example, Colombia's living right now, we should opt for this accelerated schemes. Why Colombia? Because we have problems with pertussis, with very small babies. And what was decided by the ministry is we're going to advance in our scheme, and let's start vaccination at 6 weeks, not 2 months, and every 6 weeks to try to optimize and avoid these nodes. There's another barrier that Fernando mentioned. of the barriers of access and parental vaccination, remembering this, the role of the medical society. The absence of recommendation is the main barrier when we talk about vaccination in newborn babies. There are also some structural barriers, and for all, it's clear that in Latin America, there are some centers where there's limited attention to healthcare, like in the rural areas. So we know that we have a baby in an ICU and is going to go to remote area. Ideally, that baby should leave the NICU so that he or she can have access to vaccines. Sometimes it's very difficult, but if we have difficulties here in the cities, you cannot imagine what can happen in rural areas. Babies that start schemes but never end the schemes. So I hope there's some plans that take care of this population in the rural areas where we can guarantee that they complete the vaccination calendar. What is the second strategy? Okay, medical support. The recommendation should be active and it should be a constant recommendation accompanied by education. We must identify the high-risk baby and not have any access barriers and to try to offer these opportunities so that they can complete all the vaccination schemes. So here we can see other data that we have regarding specific vaccines, DCG, BCG. The criteria is by baby's weight when born. If it's higher than 2,000, maybe it's going to leave at 1,900 because it's not vaccinated. That's a barrier because he doesn't weigh 2,000. What do we have to do then? We need to know that the evidence supports the BCG in premature babies and that as doctor I can give that recommendation. Okay, I can say, okay, I'm going to talk. Okay, he goes to a place in Chicorodo. There's tuberculosis there. The vaccinates afterwards is very low. So what I do is I advance the doses and I give discharge the baby. So to know this evidence exists and it can be recommended. With hepatitis B, dose 0 is some topic that has had a lot of discussion. We know what has happened in the United States faced with this. 0 dose has enabled to reduce the prevalence of hepatitis B throughout the world. Even though when we have mothers that really don't know they can have hepatitis B. But this is a strategy that we must continue to implement. And in the mother that is positive to hepatitis B, independently of the weight. This is a strategy that's going to save lives. Pneumococcus starts at 2 months without considering the weight, okay? We all know the chronological age. This is a vaccine very well accepted that we have also the opportunity to offer a strategy of much more expanded coverage. And we have to be aware of how these changes. Rotavirus. How many of you apply rotavirus in the NICUs? This is a vaccine that is lost. It's a vaccine that is high upper limit of application. It's being lost. There's evidence that shows that it can be applied in the NICUs. If you have an ICU, that I believe we all have it, of high quality in our countries, where the isolations of contagion and management of the patient and management of all the things of the patient is really managed very carefully. We must use the rotavirus vaccine. Let's lose this fear to the outbursts that can happen that are secondary to the administration of the vaccine. It's important to say that that patient must be vaccinated and continue the protocols. This is strategy number 4, the opportunity window that we have with this vaccine. Just imagine that I have 1 minute and I still need to share 10 strategies. Okay, I'm going to try to avoid other strategies, but okay. This hexavalent is a strategy shown by Dr. Galvison yesterday that improves logistically in adverse events the coverage and protection in the preterm babies. I'm not going to stop. It has safety profile, very, very little adverse events, and definitely this has to be another strategy. Vaccination with hexavalent, acellular hexavalent in the newborn babies, and continue the calendar, not only in the unit, but complete the calendar afterwards. This is the other strategy I was to present to you. I can share all this information, this presentation, so you can really double check with the evidence. Doctora Celia, this is another strategy she mentioned. Definitely, with the current evidence, balizumab, palivizumab is not going anymore. We need to continue with the strategy with monoclonal antibodies, long-lasting monoclonal antibodies. Colombia has a strategy that we need to protect, that we need to promote, but there are some newborn babies that are not being covered by the maternal immunization, which is the high-risk population, and among them also the preterm babies. Meningococcus is another of the strategies I want to present because there are studies, clear studies published in the IPSA journal where meningococcal has an increase of complications and death in the preterm babies. This is a high-risk population. And if it's a high-risk population, this is the strategy that I bring to you. The inclusion of vaccination against meningococcus. This is a study which is shown that half of the cases in the QK could be prevented with vaccination when assessed mortality due to meningococcus. Strengthening of immunization by the mother. That's why I talked about monoclonal. Now I say this. We have to guarantee as doctors that our mothers must be vaccinated against the flu, virus, pertussis, against COVID, because there's also evidence in the world, I'm going to continue quickly here, that this protects the newborn baby. This is my strategy.
Strategy 9, it's one that we forget, which is immunization during the course. And therefore, how are recommendations for this immunization? Be careful with whoever takes care, if it's whoever educates, and it's we need to cut the transmission chain and to do timely recommendations. And also identifications, we need to identify and that have a scheme, and we need to identify how do we recommend a rescue scheme. And please take a picture, because how do we do, what are the accelerated catch-up in the high-risk neonate? We have to evaluate the scheme, the age, and therefore we can see, and therefore we can do the minimum intervals. A high-risk baby that has a trace cannot use the normal skin. They have to have accelerated scheme. Remember the window of opportunities, and they have to use and we need to recommend it. We need to take into account every contact, and therefore, and we need to communicate this. And these are key opportunities for the catch-up, and that's why the follow-up and all hospitalization. I come because he's been crying all night. And mom, is she vaccinated? We always need to ask for the vaccines. Always, always. Are all the vaccines in place? And to be able to use those opportunities. And finally, just to finish off and to be very strict with time, we need to have a political prioritization, a governance, and neonatal immunization. We need to be part of this. We need to talk with decision makers. We can't just stay in the office or in the units. We need to talk about what's going to have an impact in our newborns. We need to be public policy agents. And here I'm going to show some strategies: combined vaccines, BRS, and near in maternal immunization, and digital record, because sometimes it's very difficult, because if we don't have a unified record, it's very difficult to do a follow-up of these newborns. I can see that in these high-risk populations, we can see how they received what they need and how they can do it. This is the Colombia scheme. And because we have 6, 12, and 18 because of the whooping cough, and my recommendations of the excellent pneumococcus enterovirus, be very careful. We need to consider meningococcus for this population, taking into account risk factors. Finally, this take-home message: the best neonatal technology loses its value when you fail to prevent what is preventable, and that's what we want. Thank you. Thank you so much for speaking so fast and recover the time that had to be recovered. Well, first of all, I wanted to apologize for all the technical issues that created some delays, and we are going to ask for a very few minutes from the following talk so that you can ask two very synthetic and summarized questions, and if you can please answer in a very summarized way, because and if not, if you have no questions, the doctors are going to be available if no questions are there. We're going to give please, Angela, okay, we do have, I know that I know there's no time, but I had to talk about this wonderful discussion that left us some wonderful expectations to work. I think that we all can take home a very important message, is that we need to be active agents of our children protections. We need to do public policies. I know that you are strongly working, but we need to keep on working in the generation of change, and therefore, in high risk. Thank you so much. And to close up, I want very proudly to share a thought from the Argentinian Nobel Prize winners, one of them, Dr. Hernando Jose. And education, it's not expensive. What it's expensive, it's ignorance. Let's let's educate all the politicians. Thank you so much for your participation. One more thing to close off, one more thing. Yes, go ahead. Go ahead. Well, first of all, I would like to thank you for this, for all your talks, but I would like to close with a legacy that I have, and that was a sentence by William, and that it's a Canadian doctor that says, and I repeat this because I want this to be disseminated, it's that the medicine, that the contact with the patient, and it needs to have the 4H, humility, the humanity, and also humor, and also honesty. If we are honest with what we propose, beyond we can see any policy, public health, it's only one. We need to work as a unity, and with humor, we're going to make a better benefit from Argentina. I would like to greet you all. Thank you so much for allowing me to be here. We would like to thank for the speakers and the coordinators, the future of the baby when they weigh less than 1,000 grams in the low resource context, with Dr. Sergio Colomet and Valdemar Carr, and it's going to be coordinated by Dr. Jose Macastro. And she works in the neonatology unit, and she's the coordinator and postgraduate professor of the pediatric unit. She's a founding member in ASEPNEO and the general manager of the board. And Dr. Rene Barrera, who is a neonatology, that it's part of the neonatology division of the Perinatology Center of Mexico, the coordinator of immediate care of the newborn. And it's also a longitudinal pediatrician follow-up of IMPED, associate professor of the neonatology especially, and therefore a current VP of ASEPNEO. Welcome. Good morning, and I would like to welcome you. Thank you so much. Following this segment, it's going to be a conversation, what we talk, a ping pong between two experts in the management of extreme prematures of and therefore Dr. Jose Mar and and you heard them yesterday are going to do their presentation. I would like to thank if you prepare your questions so that it's a very dynamic conversation. Good morning. Good morning. What we considered is to show you a little bit of the evidence of what happens in Latin America. I'm going to show you a couple of slides, and we're going to share our studies, and when we are done, we're going to show the two current publications in PubMed about what happens with this extremely premature babies in Latam. Let's see. We are going to start with a very straightforward question. When was this published? When was this published? We believe that this is okay. We think that some things are indicated for those who are born at 25 but not of 22. If a baby, we can see that this is something that needs to be discussed among parents, healthcare professionals, and society. This could have been published last week because we can see this was published in the New England Journal of Medicine in November 93. Some of you were not born at that time. That's why you can say that 40 years later, we're still talking about when things should be done. And even before this, Pierre Boudin wrote in a book that it's fascinating called The Norseling, and you can download it from Google. We can say the neonates that weigh between 3,000 and 3,500 grams, though preterm weight less between 1,000 and 250 grams are considered congenitally weak. We will not talk about survival in babies under 1,000 grams. Rare times are they safe, and we shouldn't mention them. Although the book is fascinating, if you like the history of medicine, it's very interesting to know how much has medicine changed in the last 150 years. And yesterday we found out, and please sing a happy birthday, because yesterday we found out it was Wally's birthday. We can't do this in the US because it's to talk about personal issues, and because of HIPAA regulations, I can't do it, but here I can. So happy birthday, Wally. It's a pleasure to share with you. Let's go back to science. I am going to tell you about what's happening in the world with the recommendations from different societies. In this case, the Swiss societies, what recommendations do they have for the prenatal care of extremely small babies? And they talk a lot about the customized risk, so that it's not the babies that weigh 930 grams, no, and the ones that weigh 282, no, because each baby has an individual risk. Each baby is different. And one very interesting thing is how they use what youngsters use, its infographics, and to see how they present data in a very clear and straightforward manner, as how many babies at a certain given time survive or don't survive. And this is a very clear manner to show parents that, for example, what needs to be done, what it's in the best interest of the babies, what are the different options for the management, what it's the way in which they can decide, along with the father, what's the authority that parents have about what it's done and what it's not done with the baby, and what it's the final decision. And that's why there are some graphs in this publication. So this is from last year's, from last publication from Acta Pediatrica, where it says that at 23 weeks of gestations, 60% survive. How many of you work in hospitals where routinely you resuscitate babies that are 23 weeks of gestations and 60% survive? We cannot not say that. We can see that 70% at 4 weeks and 83% at 25 weeks of gestation. Why can we show this? Because not all of them want to have figures. They love drawings, and to tell them if it's a dark blue they survive and the gray they don't survive. Not only that, but we can say that in this study, if they survive, which one of them it's going to be a morbidity, and if they are severe or not. And I think this is a very good way to show the data. The same thing happens at 26 weeks. You see that as more weeks pass by, more babies survive, and less morbid mortality, less severe morbid mortality will they have. This is not just important that they survive, but to see what type of role will they play in society. And this is very complex, and I'm just gonna tell you that in Australia we had kids, and the social they function the same if they're premature or term babies. But if we join all the data that you heard yesterday, the fact of doing an early intervention, of doing an appropriate diagnosis, and to be able to give them all the help that they need, favors that at 20 years there's not such an important distinction. A couple of months ago, I had the chance of listening to Dr. Tetsuya Isayama from Japan, where he was in February. He showed the Japan's data. Japan, it's one of the main countries that 10 or 15 years ago started to resuscitate smaller babies at 24, 23, 22 weeks. And they have published their data. Then we're going to show you. I took a picture from the laptop while he was speaking. That's why it's crooked. But you can see that mortality changes according to the country and according to the data. We can see that there is this publication of the Journal of Pediatrics 2019, where he compares what has happened not only in Japan but also in other countries. And you can see that since 2007 to 2015, in all of these countries that you see over here, they include Spain, the UK, Italy, and Finland, Australia, New Zealand, and Canada, and how this has changed and has improved the future and the survival of these very small and immature babies. And therefore, thanks to the technology and to see babies in a different ways. And I think that we can see the babies as individuals, and not as a general population, that all the babies that are 21 and 22 weeks are the same. And the obstetricians that I worked would administer antenatal steroids to mothers if they were less than 24 weeks. Therefore, at 10 p.m., the mother that had 24 weeks and 6 days wouldn't receive this prenatal, and at 12:01 they would give it. The problem is that for us, the neonatologist, if this baby was born at 3 a.m., and this was not very useful, we tried to change the philosophy that and we could need to do a better assessment of the babies. And we can see there are a lot of data between mortality and morbidity and what type of survival do they have. But we can say that many of these statistics improve from between 2007 and 2015. The same thing happens to how many required treatment for retinopathy, or also for bronchopulmonary dysplasia. But please be mindful, and especially in a region like this one where there are so many people that do follow up. It's not just that the baby was discharged and good luck and let's celebrate. No, and some neonatologists think that it's a good way to celebrate, but that's where everything starts, because morbid mortality is going to follow these families and these kids throughout all their lives, at least in many cases. And we can see that this is not published. We can see this was published. We can see that the mortality that are the mortality of preterm babies in Canada, we can see that there's a high risk of morbidity between 5 and 2 years of age. It's not surprising, but nothing explains what happens with these kids. But it's not just to say, hey, mom, they're gonna go home. Please take care A, B, C, D, E. No, you need to be mindful that there's a follow-up to see if this baby requires any types of help. He gets this help because this morbidity persists throughout the times until they're 10. And you can see that this is not going to surprise you, that the different gestational ages, and we can see that the heart conditions, cerebral palsy, and also we can see neurodevelopment, epilepsy, and autism are higher and more premature babies. To the left of the graph, we can see the babies between 22 and 28. And here we can have the babies that are 42 and 44 weeks. It's not surprising, but this is something that we need to insist on, so that a premature baby, it's not considered as a normal baby, but smaller. No, it's different. Even, please be mindful that these neurodevelopmental disorders are also being seen, especially the ones that have a cerebellum pathology, have issues, and for many years people wouldn't be mindful of this. Now we do a brain ultrasound, including the posterior fossa, to be able to check out the cerebellum, because we know that some of the disorders that we find in these kids are because of cerebellum disorders. You can take a picture about this, but this was just published in Pediatrics about the Australian group with Lex Doyle, where they compare babies that are under 27 and babies that are under 26. And you can see how the statistics change depending on the countries: Sweden, Australia, UK, England, and many studies, and the assessment have varied between 6 years and 12 years. But you can see to the right what significant percentage these babies have when they grow. What is the possibility of having a normal nerve development? We invest a lot in these kids, and I think that we're going to talk about this when we talk about the Latin American countries. But you can see that the percentage, it's rather significant. Wally, I'm going to show you, and at the end, and thank you so much, Sergio. I am going to emphasize two concepts. The first one, we're going to talk about immature small babies and how we can optimize the care. And I'm going to give an example of the University of Iowa in the US. What part of this collaborations of small kids we have in Uppsala in Japan, we have in Iowa, and we have several centers, but they've been more time working with them, and we also have very good outcomes. And although I am going to talk about extremely premature babies and even 21 weeks, I don't want to emphasize, I don't want you to think that I'm in favor to get to that such a low gestational age to keep those babies alive. I think that as a Dr. Head, we can say that in 19.3, we can say that the limit is at 22 weeks. Or 24 weeks. And I think that in many of our countries, that's the reality. It's a reality, and to have a very premature baby. And in the U.S., and they vary. It varies. There is a study that was published in Pediatrics that they say that less than 25 weeks, they give them comfort care. They administer palliative care. And in the U.S., where there are many resources, and we in Alabama try to be able to establish we determined some agreements with the government to not to take care of babies that are 21, 22, 23 weeks, but the government wasn't in favor, and the insurance wants us to keep them alive. It's a very interesting situation. And that's why we had the Guinness record of the smallest baby, or the more premature baby, 21 in one day, that was confirmed with ultrasound. But now Iowa won because they have 21 weeks and 0. And therefore, I'm not going to give you my data. I want to talk about Iowa. And therefore, I'm going to talk about a very interesting concept. It's that we take care about these really premature babies, and that we need to think in how to do things better each time. And as a quality improvement, how do we improve the care of what we're doing? And because in many centers in the U.S. we've said about how we do them, and if they had a high mortality at 25 weeks, and we don't focus in 24, we started to reduce mortality at 25. And therefore we go down to 24 when we know what to do, modified as Dr. Colombek, because we do know that there are other variables, and that found other variables as antenatal, steroids, sex, and that varies the prognosis. And to emphasize something limited, and when we take care, it's a long maturity, and we can say that baby, how we can say 25 weeks, and the lung, it's not developed. The lung is not developed. There's no alveoli. There's no alveoli. He's not going to have alveola for 2 or 3 weeks. That's why, yes, there is an exchange in the respiratory bronchioli, but it's not enough to keep them alive. That's why we have certain limits that are going to be physiological limits, and we're not going to be able to take care of this premature, because we can see that the lung develops, and we can see even at 35 weeks, as we say over here, that the alveolus are being developed, they're maturing well. And we can say that this is something that the parents need to know, that we cannot take care of the baby with good outcomes because the lung, it's undeveloped. It's very poorly developed. This is a summary, and that for some very good reviews, and you can see that they identified that more than 75% of living babies at that gestational age, that it's equal or below 27 weeks, require initial mechanical ventilations to be able to survive, giving the immaturity of the lung. And that's why they need a lot of support. And what can we do to be able to improve the respiratory care? And this is something that I'm going to mention tomorrow. I am going to talk tomorrow about how we can improve this, because if we add 75 patients in ventilators, we know that many are going to have trauma. They're going to have ventilator-associated trauma because of the volume. And this is an example that I'm going to give you about quality improvement. Quality improvement, and this is a project for quality improvement that I'm going to teach you as an example of many others, because we have an excellent one that we've done, that it's called the Golden Week, that was published by Dr. Travers, and where we have a program that lasts a week, and we can see that all the care is structured. We have a program that we can share, so that you can see how we do things in these babies that are less than 27, 28 weeks. It's called the golden week. And sometimes we make fun because say, okay, they're in the golden month, because the second week we still have very special care. And as you can see over here, what we want to do is we want to reduce the mechanical ventilations in extremely premature babies. As we can see, our center has a low ventilator usage. That's why at the beginning we can see more or less 44% at the beginning, and we doing this, and we had already done the study of the Golden Week. We had already reduced the mechanical ventilation, and as you can see over here, we had a care plan. Where all the healthcare providers agree and how we are going to take care of these babies in many parts of the care. And we can say that after this, we start with interventions. And over here, we can see that we reduced the ventilator usage to 25% in such small babies. And we can see that it's an assessment done. We do a special cost variation. And this indicates that statistically, what you see over here, it's that the initial average is 44. And as of now, as we can see over here in the middle of the graph, it's a reduction. This is done statistically. But what we have done is that for each case where we implement we want to do this. We want to see all the causes. We try to organize what we try to organize what is baseline, what is possibility, and what's going to depend from these first elements. And here we have an example.
Otra vez con este programa que tenemos, que incluye el último que dice aquí del Ventilator Dashboard, que es lo que estamos haciendo. Esta reducción en la exposición de la ventilación mecánica tuvo efectos, como se ven aquí, en la displasia broncopulmonar. Fíjense en la muerte acá arriba, era más alta inicialmente, bajó, aunque ha subido poco en los últimos periodos, pero en general lo que se trata de lograr es que mueran menos y que tengan menos severidad de la displasia broncopulmonar. ¿Esto es tuyo? Está bien.
This compares certain periods of time from 89 to 91, and here you can see how mortality has been reduced, but also is postponed. They were dying early on, but they are dying later on in time. But you can see a very important reduction. Here we can see the associated causes with mortality. Mortality causes in these preterm babies is respiratory diseases mainly. So after the first part, that we need to do these very important efforts in the quality of care to improve the outcomes. And we're going to do that, and step by step, improving and reducing the mortality in much more severe babies. But we need to place a limit at the same time. We are very concerned taking care of the babies in the first 21 weeks. And when we have a mother at 21 weeks, we say, okay, we're not going to do anything at all. We have some live babies, but we say that we're going to do palliative care. And something I always say is that we are going to always be with you, supporting you, because the parents need a lot of support. This is the Iowa, and other centers had very good outcomes, as you can see in the yellow column. These are the Iowa data. At 22 weeks, it has 60% of survival rate. It's wonderful. I visited the center. I was with them to see what they were doing. And basically, similar to what we do, but improved, I must say. The best thing is that they think that every baby must have an opportunity. And that's why they use a lot of processes, a lot of care, and this is very important intervention, a very effective intervention. I published 14 years ago a multicentric study where it was reported for the first time that steroids at 22 weeks were effective. To be able, just to give you an inside story, and I sent that to ECOC and they sent via email the response. So since they didn't answer, the first time I said, okay, please, any comments? And I want you to be co-authors. And they said, okay, we're not interested in giving steroids on the 22 weeks. So it's not we have to give steroids on 22 weeks. But if you're going to take care to babies at 24 weeks, you need to have a high course of steroids. This is according to AWA. This is the best center. As you can see, the one of Iowa compared to the Vermont, and you can see Iowa in yellow, mortality in all these weights are improved in Iowa. This is a very important concept, and it's been shown many times before that if you have best outcomes at 25 weeks, you will have best outcomes at 26, 27, and 28 weeks. The centers that have better outcomes at any gestational age usually have better outcomes throughout all the gestational ages. So it's not only that this baby is extremely small on 22, 23 weeks are the only ones who are going to benefit. All of them will benefit. Of the smaller babies, I would like to mention Dr. Klein and Dr. Patrick Namara. They have promoted the care in these preterm babies. And also Dr. Bell, that you may know him very well. He's not the enterocolitis Bell, it's another one. You can see them severely premature, and they take care of these babies. Here we can see the outcomes at 24 weeks. This has been recently published in JAMA, and I think this is the best publication at 21 weeks. And again, I don't want you to think that we need to take care of these babies at 21 weeks, but you can see how they've had much more baby. They are resuscitated, and they have very good outcomes. This is the percentage of active care, and this is also very important. Around 13 years, the active care was duplicated, was doubled more and was tripled again, doubled and tripled. I think that a very important concept, and it's been really shown by Dr. Rasabi, that the centers that have high mortality at any gestational age is because many times they don't give care, they don't have care when the babies are born. We did a study that showed that it was very difficult to predict early on. This is a list of studies. You can see ours here that I just recently mentioned, and other of babies on the 22nd week or extremely premature. And as you can see, how increased the survival in recent years. Mortality causes through infections, sepsis, early sepsis, late sepsis. We need to think about these patients to avoid infections. And this is the data of Iowa, the outcomes at 18 to 22 months. As you can see, in Iowa, many babies need oxygen around 27%. At 22, 23 weeks will need oxygen to be discharged. And also the increase of cerebral palsy. There are certain morbidities, and we need to start thinking how to reduce morbidity. Thank you very much, Wally. Let's continue with the ping pong. We don't have a lot of data from Latin America. That's the importance of having this conference. One from Neocosur, mortality was around 26% in the past 16 years, around 12,000 babies. The cause are also pulmonary dysplasia, and it's important to be considered. You know this reality, that there are important references according to if the baby survives in the hospital or not, and according to the country. Here you can see the causes of mortality in very, very low weight in congenital infection, respiratory, bronchopulmonary dysplasia, among others, similar to what Wally talked about, the data of Iowa or the Vermont-Oxford or the Neonatal Research Network. Death age in days, expectable, the higher mortality in the first hours or first days of life. And afterwards, here you can see this graph that there's still mortality at 2, 3, 4 months, but a lot less. When you see mortality according to the birth weight, the lower birth weight, higher mortality. And it happens on the 22, 27 weeks or 28 to 31 weeks. This is a study from Colombia, the second published in PubMed. The socio-demographic determinants in those preterm babies in Colombia in 2016-2019, published by Dr. Jorge Muñoz from the University of Cali, the Valle de Cali, increased 13 times the risk of the mortality was 4.9 in those babies born live. With a weight less than 1,000 grams, increased the mortality, and really, as you can see, the time. In conclusion, prenatal, as you can The mother also being Afro-descendant, C-section, premature with less than 32 weeks, higher mortality. Mortality and morbidity depends also on the departments, provinces, or different areas of the country, because not only all the places practice the same type of medicine, not all of them have the same capacity to be able to treat these babies, and this will come through the questions that you may ask. So, I would like to wrap up by saying we need to balance. It's not easy. You've seen the data throughout the world, through all the countries that are really advanced. Trying to resuscitate babies from 21 weeks. And it's not that we're going to say that the 22, 23-week baby should be treated aggressively in a way. Some talk about the ethics against these babies, and it's not fair. If the baby is going to die, must die ethically and not start to place a lot of tubes and needles. What this baby needs is, we're going to talk about in the afternoon, is care, palliative care. This baby must be warm, comfortable in their parents' arms. So this is the highest technology we can offer the babies, without a doubt, that for many countries to proactively resuscitate and invest in really and at those costs and maintain a baby of 21, 22 weeks as really the same cost to one only baby will cost the same as all the scheduled vaccination. So we need to make a balance. We would like to wrap up and have the floor for you. Now a hand of applause for all of us. Thank you. Okay, we have any questions from the audience? Good morning. I'm from the Dominican Republic, and this Congress is wonderful because I've seen a lot of experience, and I'm very satisfied to see this. But I'm really concerned to read the concepts in the books. For example, when you divide abortion less than 500 grams, less than 20 weeks. When you define extreme preterm, you say less than 28 weeks. But I'm concerned, so what should I do who have those who are in 20, 23 weeks of age, and they say they should not be resuscitated in the majority text. So I would like to know, what should we do with that limbo among the 20 and 23 weeks? What is your opinion? So I can practice, I take to my personal practice, professional practice. Wonderful your question, but I think the answer is individual. In each center, we meet with the obstetricians. I invite them to be part of when I'm going to prescribe steroids, but we do a consensus of what to do. And we are aware that there are other centers, and we try to coordinate with other centers. And we do not say that you have to do certain practice in all the state of Alabama. We say you need to do this practice here in our center. So my recommendation is that to get together with the neonatologists, obstetricians, and discuss and have a consensus what the gestational age and other criteria like gender and what other practices must be done, not only if they're resuscitated or not, may be one of the main things that we discuss with the other professionals in how to optimize the use of antenatal steroids. We did a study regarding the improvement of care in which we agreed that it was 24 weeks that we need to prescribe steroids. Any baby among 24 weeks or more that was born and had not received steroids, we needed to do a fishbone process, let's say an analysis, what really happened, because it cannot happen again. And that's why we increased it to 98 and 99% the use of antenatal steroids. This is something you should do with the group. If I may, I'm going to shift your question a little bit. It's not that you don't need to resuscitate the babies. There's a lot of publications about this. But the most important thing is what we should not do. Because to do is black and white. If you have a 22-week baby, sometimes it is born in the delivery, is dead in the delivery room. But I think that if you're in your unit, a 25-week-old baby never survived, why are you going to put through suffering a baby that has 22 weeks? So we need to understand what we should not do with this baby. Without a doubt, if we don't have a good communication with the rest of the professionals, and we try to do all those prenatal visits together, because it's important for us to be aligned. So we need to ensure that we are all on the same page. That's why we get together previously, and it's important to think what is appropriate to be done in your hospital, because your reality is completely different. In Dominican Republic, after many years of work with some colleagues there, we reduced mortality in less than 28 weeks and more than 30% only with education, teaching what is the appropriate thing to do and what is not appropriate to do, including antibiotics and thermoregulation and everything else. But I think that for these babies in the limit of viability, without talking about science fiction here from 10 years on, that was going to be a portable uterus with amniotic, artificial amniotic liquid. No, that's another thing. But right now, for me, I am concerned. The idea is not to do anything to the baby that has 22 weeks, and that is not fair. And that's a reality in many of the hospitals you work in. Thank you very much, doctor, for your talk. My question is, I'm from Peru, and again, what the norm says is that abortion is less than 500 grams and 22 weeks. Nevertheless, in my unit, which is a high complexity hospital, mortality in less than 600 pound baby is 100%. So we agreed upon the 24 weeks, but our mortality in 24 weeks is almost 100%. Not sure if there's lack of a consensus in the unit, because in our unit, some of us, we see how the baby is born, a 24-month-old baby was born breathing, crying, and it's very difficult to make a decision to take that baby to palliative care. Have you had difficulties in a unit where some are pro and to resuscitate children in 24 weeks, and others don't want to, due to also religious beliefs? That's going to put surfactants in the hand without thinking if that baby is going to be resuscitated or not. So, justice principle, because you mentioned I have a 24-week baby, and I can see in other units 30-week babies that really die. So that is discrepancy there. I don't manage babies by norms or names, I'm sorry. The law in New York is different regarding newborn baby, and high or maybe a heartbeat. In the United States, this is a live baby, so we need to understand what's going to happen. Many years ago, with concerned with these babies that are going to survive even more. And the obstetrician started to protect the mother and give her magnesium to protect the brain after several studies. We did something that's called a trial of life. If the baby is breathing, has a cardiac frequency that's reasonable, even though whatever, but it responds in the delivery room, we grant that possibility and we leave the baby in the delivery room with anything else. We take him to the unit and openly speaking with the parents, we say to them, okay, meanwhile, everything's okay, but maybe we will do an ultrasound if it has any other problem or maybe has a list of conditions. This is moment to stop. To start is always easier, but emotionally it's very difficult to leave a baby like that. When I started almost 30 years ago in the hospital, that we have a wonderful unit that started with only 20 beds and now it has 60. I started working and I had a baby in 23 weeks and I left him in a crib. When we arrived 1 hour afterwards, the baby was still alive. He was really, he survived, but with a lot of difficulties. And we changed the philosophy of the team. And all of us work together, nurses, neonatologists, because I cannot say that I'm going to intubate and my colleague is going to say, no, you're crazy, how are you going to intubate? This baby should have been really in the jet, and others said, okay, no, CPAP is okay. So it has to be something much coherent for the families. So my philosophy and what we practice in the group where I work is we speak among each other if we all agree. Because if we do not agree among two, it's not fair for the baby, nor the family, nor the team. And we need to give them possibility, always speaking with the parents and having good communication. What is the next step or next chapter for that baby? Yes, I do agree to work as a team. We do the same thing for all the practices. Every Tuesday, we get together to discuss the practices that we're doing. We discuss each patient as well. But we see if we continue with the practice or not. And if we have to maybe adjust an agreement. So the idea is that all the people know what we're doing. And we discuss that on a weekly basis. Anybody can bring one case. If maybe two doctors think differently. So we discuss that as a team. And we change everything and improve. We try to improve care. This is the first message. And the second, it's very important to say that when we need to do an addition, some things are very clear. As an example, that your NICU at 25 weeks, you have good outcomes, everybody agrees that the treatment must be given. So this is fundamental. 25 weeks, every time it's going to be done. Maybe at 23, 24 weeks, we don't know. 22 weeks, we know nothing is going to be done. Only palliative care, sorry. So we have that window of 22, 23 weeks where there is much more consideration of several factors. Number one, what the parents want, first of all. And to think what are other variables we can consider as a group to define that moment. In that area, that window, we have much more variation in the division. We need to think about what we should do. In life, you want to do which is going to be you can be much more reversible. You cannot say, no, we're not going to do that. You can maybe define a strategy and go back again. So that's the idea, to think how we can continue that can be reversible at the same time. In that way, in the 22 and 3 weeks, 22 and 24 weeks, we don't have a complete consensus. Maybe it's important to resuscitate, and we can see then what happens. And the third concept is, it would be withdrawal of support. That would be the third concept, withdrawal of support. There was an old concept in the United States that it was better not to start with anything than withdraw. But now people think these are comparable and better to withdraw. So if we are not sure about 22, 23 weeks, the baby is ventilated, wait and see if the baby responds, and afterwards, if the baby does not respond, well, we do a withdrawal of support. Okay, one question talking about this that also comes from the audience. If you need to choose any recommendations to do in the management of these extreme preterms in remote areas, rural areas with low resources, where really they're going to have problems, what would be these recommendations? Well, the answer is more or less the same. I want you to think in your own hospital, 3 a.m., who is going to the delivery room at 23 weeks? The student has done only 2 intubations in his life. Okay, maybe a fellow, a student, Dr. Barrera, have you seen him in an ICU? In the delivery room? No, I don't think so. But pay attention. As in remote areas, we need to be very careful how we spend these resources, because these babies are very costly. The trachea tube, ventilator, oxygen, also the blood gases in blood, a lot of inputs that can be used in a different way. So, as Wally said, we have changed our philosophy. There are things that are irreversible. If this 24-week baby, I'm not sure in what area of Venezuela, but...
Okay, La Guajira. At 23 weeks, and he's crying, and he has a good color and a good tone. And therefore, if we don't do anything, the baby will die. But there are things that one can do, like CPAP, that works really well. And many of them are going to require intubation and surfactant, but we can allow the first stage. And I don't know if La Guajira, they have the possibility to fly by helicopter or by plane to Barquisimeto or to some other area where they can be given a bit more. But and therefore the body, it's 200 weeks away, and the mother and the father has 6 kids more, and therefore that's not ideal. But what Wally said, it's accidental. There's certain things that are reversible. If one doesn't intubate the baby, when I was a fellow, if somebody says if I can add an laryngoscope inside the mouth, I don't intubate. Okay, it's something funny, but this is without doubt white or black. But if we start and we see what's going on with the babies, some babies are going to survive. And how much can we invest in an area where it's not enough technology? I don't know, because it's not fair to make them suffer either. And therefore, if there's no technology, maybe I would try to invest in other things, and invest in a better care of the mother, and to invest in a better care of the mother, and to invest in better food, and therefore we can say that resources and capabilities are going to be different amongst the units, and therefore I work in Zambia, and then when I work in Zambia, I know that the 26 weekers or less almost all die. And therefore we have a certain ways, and therefore I need to accept that this is ethical. And I cannot do, okay, this is a conference, that it's a follow-up conference. What I would like to see is that besides the palliative care protocols, do you call the follow-up team to these meetings? Because beyond the publication, that no kid is the same as the other, and that no unit has the same outcomes than others. Maybe it would be great if we can receive the information directly from the team that's doing a follow-up to the patients that you send to other centers, and also to be able to answer to the colleague from Dominican Republic. And something that you said, and something that no one else mentioned again, it's data. And therefore, it's our own data. And therefore, it's if we tell Colombek and if they tell Dr. Gualicardo, then it's ours, because we have different kinds of realities and different kinds of circumstances. And maybe one day, using our data and improving our data, we can get to these standards. And therefore, I would like to invite you to participate in the record of ASEPNEO. And do you call the follow-up teams of your units? And as we can say, we had an advantage that one of our neonatologists, it's the follow-up one. It's the one that works with palliative care. And the transition, it's very good, and we work really good as a team. And it's not only her, but we have a complete multidisciplinary follow-up team, and then we also have a palliative team. But we have someone that coordinates with the neonatologists all these activities. And of the four, two of my colleagues are the ones that do follow-up, and that's why they are in all the regions. And if I say no, they won't invite me. And as you can say, that we did this follow-up, it's done by two of my neonatologists, and that's why you're here. And that's why I understand that the reason why I told you the data of Switzerland, it's because you use your data, because when my fellows do the prenatal of 23 weeks, they need to decide after weeks, they only 25% start to, and percentage survives, because they quoted the data from Wally and from other hospitals, and it doesn't have value. But it's not value in my hospital in Brooklyn, because the data is different, the population it's different, and our data it's different. That's why to do this type of infography, to tell the mother this is what happens here and what happens in the last 2 years, and I can quote the literature, but the mother, it's going to have this thing and taking care of our neonatologist, and the baby's going to be taken care of in this NICU. And I'm Adriana Montealegre. I am from Hospital Universitario, Bogota. And we, in a couple of months ago, we started to use this pre-viable kids, and we also established our survival around, we're established to survival around 25 weeks. We also do prenatal consultations, and we also only talk about high-risk babies, because we don't know, sometimes it's unforeseen. Maybe it's an unforeseen birth, but we always had the concern when we started to use the Japanese studies. We always had the, and we saw it like Star Wars or something like that, because we can see 22, 23 weeks, and as the colleagues have mentioned, for us it's almost an abortion in 23 weeks. We always had the concern. I would say I want to go to Japan, to be able to see what they do, as Dr. Valdemar said, and when they go to another institution in the U.S. And I've always concerned, and this is, and I can see that it has to be customized, and I think the baby that fights to struggle, and then to give them the right to be able to see the variables. However, there it's something that it's very important. One of them, it's survival, and it's one thing, it's the quality of life. Why? Because if we have some cohorts that we have been studying, the French cohorts, and we can say that we starting having issues of cerebral palsy and even of schizophrenia. And we also had mental health issues and nothing to say with regards to neurodevelopment. And therefore, if we go into the happiness train of survival in our countries, and especially in our Latin American countries, what are we giving the family, and what kids are we giving to families where they have a very low income? What kind, if even in European countries and North America, we have that big cohort. I don't know what the Japanese are going to say, how the kids are doing at 10 or 15 years of those families. I don't know how they're going to do. But the problem, what I would like to ask, and I do know that, I don't know that they have no long-term cohorts for 22, 23 weeks, but more than survival, I'm worried. And if we're here in the follow-up conference in LATAM, the quality of life of those kids and of those families. Thank you so much. And okay, very brief because we don't have time, but yes, but I do want to see that young people know that whoever, but we needed to resuscitate babies without surfactant. And the back days in Argentina in the 80s, they didn't survive. And nowadays we're talking about 25 and 24 weekers. In Japan, it's not science fiction, but it exists. But as a country, a lot of resources have to be invested. And these are resources that you don't have. Or I would rather say that you don't invest in something in that, but in something else. I understand, but if you can see, check out your statistics from 1920 to 2010, and maybe they wouldn't survive. And now they do, and now that we're changing, but we can't do a revolution from one day or the other, and to think that tomorrow the babies are going to be reanimated. We can see that the neonatal network and the NRN, they have a website. They have mortality in each gestational age and other needs, but they also have they have death or disability at 2 years, and this is a way to think that is extremely important. That's why we need to consider the quality of life. And therefore, I want to close up with a question. I think that this is a topic that has no solution. On one hand, we have all this medical knowledge. We have all this epidemiology that, but on the other hand, it's the ethical part. That's why it makes sense to me that in Iowa they are talking about to talk about an individual risk, and that you talk about an individual situation, because if the baby is 23 weeks and in my unit have at least an occasional survival, and the baby is born at 23 weeks from a teenager that doesn't have a couple, and that it's not a wanted pregnancy, that's why there's a lot of social risk. And that's why that same body, that 23-week, and also and without having any previous babies, and therefore this sets the context or survive in something that it's just personal, where the baby cannot decide on its own. But it needs to be a joint decision that people talk about it. On the other hand, and we can see that that the baby is altered, that baby, because of an anatomical definition, is not going to be okay. And that's why this is where we generate this doubtful space or of viability, where we have very humbly assume the border, and to sit down to talk about with the parents and the four H's. And what do you think with regards to the two cases? And if she doesn't have a couple, how does she get pregnant? It's true, but the decision, it's in a gray area, because I think that we cannot make decisions based just on social aspects, because the discrimination doesn't match in this type of environment. But I do understand that ethically, it's something that we need to take as a state, as a city, etc. Because we have both poles. We have adolescents and we also have elderly mothers. But the U.S. beyond 35, when they're pregnant, they are elderly mothers. And I think that the basic thing is communication. If we match as a medical team, and if we match as a health team to talk about with the family openly, hey, this is what we can do, and it's okay. And if the mother is 16 or 42, if there is an understanding about what we're doing, about what we propose, I'll continue. If not, it's harder. But I think that the most appropriate response is to communicate so that we're all on the same page. And maybe the 16-year-old mother abandons her baby. Maybe the 42-year-old mother has very serious medical conditions and doesn't survive the NICU or the pregnancy. But if we communicate well, at least I'm going to be happy that I explained what type of baby. It's a 23-weeker. And what happens in this unit, and what's going to happen in 6 months, at 9 months, or at 5 years. If we are able to get the type of communication, I'm okay giving the baby all the possibilities available. Our group has worked a lot in predicting, as a Jogi Berra, in predicting, because it's hard to predict the future. Jogi Berra makes comments like that, but we are very interested in predicting the future. And there are many studies to be able to predict the future that include many other variables different to gestational age. You know, the work from Tyson. It's based on something that Dr. Banabana and I did, and that we use more variables and to make it easier. But he said 5 things, but in true were 7. And also, depending at the postnatal age, that varies, and that's the work done by trajectories by Dr. Bana with me, that we found that at least that a baby at 7 days of life has a level 3 hemorrhage, has a better survival than what he had when he was born, because he's been alive for 7 days, and the mortality is during the first days. And likewise, we need to start thinking with the social variables, and that's why it's a concept that I don't know how we translate it into Spanish, but it's the social health determinants, social determinants of health. And this is something that we need to study to be able to understand this social situation. Thank you so much, doctors. Thank you so much for this wonderful conversation that leaves us so many concerns for that future that you are considering. We will invite you to take a snack, a very brief break, and we'll be back at 10:30. And we hope to see you back in the same
la mesa Vulnerabilidad Social Severa en Latinoamérica, abordajes posibles. En ella participa la doctora Iliana Curiel y la licenciada Yanilda Moraes, y coordina esta actividad el doctor Luis Carlos Ochoa. Él es médico pediatra puericultor de la Universidad de Antioquia y coordinador y profesor de posgrado de pediatría de la Universidad Pontificia Bolivariana y docente de la Facultad de Medicina de la Universidad CES. Y yo me voy a tomar un atrevimiento a decir que es el maestro de muchos y nos ha formado en puericultura a muchas personas aquí. Es maestro de maestros. Él me hizo resúmalo y lo resumo en esa frase. Y la doctora Ángela María Lombo, ella es pediatra de la Universidad Pontificia Bolivariana, magíster en neurodesarrollo de aprendizaje de la Universidad CES, coordina el programa Madre.
He teaches in neurodevelopment and also in CES, and he's also a member of the of Fundación Canguro. She is the co-founder of Red Sanar and the founding member of ASEPNEO, and it's also part of the and also the president of this 5th International Conference from ASEPNEO in Medellín. Please be all welcome. Good. We can say that this round table it's like a stop in the way, but it's something that we've seen during this 15th ASEPNEO conference, because if we can take into account what ASEPNEO means and what we've dealt with this, it's a follow-up. And nowadays the topic it's which is a follow-up in babies under these conditions. Therefore, we can say that it's like a stop from this perspective. And when we talk about the follow-up, and as many things in medicine, we always talk about premature babies. But if one were a bit more optimistic and say, why don't we talk better, so that there are not so many prematures, and because we talk about the poor and how we're going to help the poor, but the best plan is what to do so that there's no poors, and that's why we need to remember, and that when we talk about follow-up, it's that we need to start that the ideal it's to prevent. And therefore, we can see those 15, and many of which risk factors are modifiable. And we can reduce them, and that is what our guest speakers, because they are protective factors that we can. And we can also talk about the word follow-up, because follow-up is an action that needs to be focused in the culture of the anticipation. We can say we can start based on past experience, and we can set them into a context for the present to be able to modify the future. And this is the slogan of this 5th conference. We wanted to transforming the follow-up today. We build a future, and that's why to have so that the follow-up it should be planned, it should be ensured. And as we said in the past, and what this conference has said to. And therefore, we can see that many efforts, especially the ones in the NICU and the support and interventions, many efforts are lost when we haven't planned a follow-up. And that's why this is the topic today, with all the practical experiences that we wanted to add a Latin American vision about what follow-up is. Dr. Angela is going to introduce our speakers. Welcome to our speakers. I am so happy that I'm so happy how this presented, because we're going to see this realities in our LATAM context, and I think that this was the best talk that we could had. I would like to include Aliana Curiel. She's a pediatrician. She has a master's in public health, and she is the VP, and she is a researcher, and with experience in, and also social inequality in health, and also intercultural, and also neonatal follow-up and vulnerable. She is an author on the follow-up of the high-risk newborn in rural context and indigenous of the book of ASEPNEO, and therefore we can say this is the primary care, and therefore I want to say that the social determinants of the communities, of the different context. Thank you so much. And therefore, there we have another guest. She is a nutritionist. She's a specialist in nutritionist and the NICU, and also in the breastfeeding. She is a member of the NGO prematuridad.com, and she's also part of the breastfeeding monitors of the friend of the boy from the Health Ministry of Brazil, and also she's a nutritionist in primary care in a pre. Okay. And therefore, as a because when Hilda, we've and therefore we can see that this the second days in the prior presentations, and therefore we talked about the intra-hospital space, and Indistia and I have a lot of experience of taking care of life when there's no pediatrician. And therefore, this is what we can see, and they end up in our hands. I'll end up in our hands after you do so many efforts. And therefore, I can. And therefore, this is a series of Lancet from 2023, and therefore we can see that one of the babies that is born with, it's an issue of human rights, and now to cover this priority, it's a risk for babies, for a collective. And that's why our efforts are inside the hospital. And I think that this big challenge allows us to work. And we can say that we are going to talk about a newborn outside the hospital, and how inequality in care in exclusion context are completely critical for the survival of the newborns. And I'm going to start with this question: what happens when the newborn leaves the hospital? And let's think about this moment in which we did all what we could, and therefore I say, okay, if it's born in the community, indigenous community in Guajira, where the closest hospital, okay, if it's in a very remote area in La Guajira, the survival, it's not going to be the same. We always talk about vulnerable neonates, but I'm going to say who is vulnerable. Is the baby vulnerable? And therefore we can see that the conditions under which they were exposed, that's why and therefore this is a very complex, therefore it all depends on the areas where they are born, and that's why we want to say, and why produces neonatal vulnerability, and we talk about vulnerable childhood, and because we wanted to say what is vulnerable in neonatology, and that's why we're going to see. Therefore, we talk about the fragility, and that's why this situation where the newborn can increase the risk of dying, and the social vulnerability where they live, what's the territory. We can say that the territory has a very complex that not only talk about poverty, food insecurity, the low educational level of the mothers, about migration, about teenage moms, and also maternal mental health are the other thing in the territorial. We can see the difference. Um, we can see where we can have access to a specialized center that it's 3 hours away so that they can be and therefore 3 and 5 or 8, and that's why when it changes and especially where it's damaged or not at the ambulance, if the doctor knows or not how to intubate, and therefore we can see the institutional vulnerability, and therefore we can see it. This is very complex, and we can see the lack of coordinations of primary care strategies with the hospital, and that's why we can see that the newborn has. We can see biological vulnerability who requires more clinical care, or if it's social vulnerability who requires more social family support. And that's why we need to focus on this part. It's something that Martha tells you when we ask the mothers, and the baby is fragile, and these are the and we sometimes say it because it's that the baby still doesn't have a soul. Okay, this is not doesn't mean that that's why we're going to leave the baby die. There is a difference between fragility and vulnerability. When we talk about vulnerability, it's what factors increase the risk so that that fragility turns into a continuous damage. That's why this type of things, we need to understand them, and we need to listen and to translate. An example, it's that they didn't, maybe they had an issue with the umbilical cord. Maybe the mothers are seeing this or not, or sometimes they speak a different language, and you can say there is and they say it's that the sea, so the okay, sometimes they see that they have different ways to talk about the signs. Okay, the mothers talk about things differently, and sometimes the discharge talks about a different NICU, a social NICU, and this is why we talk about the different topics that we've been talking about. But there are some data that I'm going to say because many of these things have already been mentioned, and 1 of 4 babies are premature, 7.4 thousand. And this is very important, but also we can see that the follow-up, it's not just one visit that is happening in many of our regions. That's why we can see that the follow-up of the newborn, it's happens. The question in primary care is, why don't they bring the baby? That's a question they always ask. We should change. And what doesn't allow for us for the system get to the baby is what structural barriers allow the continuity of care, and what happens, and when there is no transportation. That's why that care doesn't start in the hospital, it starts in that territory. And this is something that we've been doing with sociologists and anthropologists where I am in La Guajira, and many of them know that this is one of the territories that I call an error case in Colombia with regards to the death of undernourished babies, and we just ended up on investigations in why do undernourished babies of La Guajira die, and why do they die? They die because there's a rupture in the care paths. It's not hunger.
Hunger is still there, but this really is what's happening. They're in the hospital, the discharge, what's happening in the home, the distance, transportation. So maybe when I'm going to do a primary care strategy, transportation in Chocó is not the same as in other provinces in Colombia or in Latin America. But how can I use the nutrition, family, and community to really create these strategies? So really care transforms the realities and creates opportunities for our newborn babies. It should include everything we've talked about. And not only include after discharge, because we're talking about neurodevelopment, support of the families. So what does Latin America need? Care, pediatrics, because here is something that's not only the care of the newborn babies, depends on the professionals, but we're going to see that because we need much more territorial community, much more near the families, are focused on care. This is what we started to see. How can we maintain this? These are the practices that we use. We are in designing these kits to be able to support the families at home using technology. So we can have telemedicine, teleguidance, and there are other different networks inside the communities where newborn babies are that we can take advantage of. So technology and tools really can approach us to that territorial care that we need. So my invitation is to look for the book, and you can see what are the feasible approaches. So we have telemedicine, teleguidance, but also the mobile brigades, considering the territory where we are. The community agents, which are bridges among the healthcare system and the families. Also, house visits, and these are all experiences that are their biographies are there in the article. So once a newborn is being vulnerable, we must ask ourselves what rights were taken off before that baby arrived to our hands. Because as professionals, we are afraid about policies, and that's why we are actors to be able to do advocacy for these babies. We found newborn babies that don't even have a civil registration. We need to understand the pathway for that baby to have a civil registration. So 5 actions for Latin America. Before I hand the floor to Hanilda, to integrate follow-up in primary health care. No, primary health care will be the first here, but really, what other things do we have? We can do primary care from the hospitals in ICUs as well. Also strengthen the family and community networks. This is very important because we not only take care of the babies as professionals, there's a very interesting work coming from the United States in the university, I don't remember the name, but they did it was a sociologist, anthropologist, and they decided to do pedagogy. So they mapped cultural resources and support networks of the communities, including tourism and culinary practices. And what did they find? That when I map all that service network, who take care of life, it's the Christian pastors. It's taking care of the people who work inside the communities, teachers. So if I have a newborn baby, I need telemedicine, we're doing that. The mother doesn't have a cell phone, but the teacher of that community does have a cell phone. So I will communicate through the teacher to do a teleguidance. So what we have to do to map the care system of that community to be able to identify key actors that are part of the work, but also those who weave live, dance, because this is called social recipes. How through the music mothers take care of their babies and promote development. So we need to map those resources, and that's why we need to strengthen these community and family networks to include community agents, who does vigilance, who are taking care of those who are in the hospital, and to adapt programs with the intercultural focus. all our manuals that we use, not only we need to change the design, it's another sense that needs to be taken into account to guarantee social protection. How can I do to be applied that let's to vaccinate this baby? Or I need to know all the pathways of protection because at least in my region preterm babies are being born from girls, from 14-year-old girls. We did activism with feminist groups, 569 reasons, more than 500 babies that were born low weight. So we need to guarantee protection, invest in the follow-up. It's very important, equality, development, and future for Latin America. Many strategies many of those are documented, but also there's a word that's called therapeutic itineraries. What does these mean? Is what we invented to take care of. For example, I'm a chronic patient, I have diabetes, but I haven't received the prescription, so I asked my friends if they have a prescription. Could you please lend me your prescription? So how do the newborns or the mothers of the newborns, how really can we help that mother to breastfeed? These are strategies that in the support networks, mothers, grandmothers, and aunts are going to teach over time. It's important to have these supports where we don't have specialized professionals. With that, Hanilda, please let us know how you do that in your community. Thank you very much. Jamilda, of course. I think it's important to mention, and Doctora Eliana, something that has been done many times, but when we don't know the story, we are condemned to repeat it. So a lot of years ago, El Dr. Héctor Abad Gómez in Colombia did that practice. He was Vice Minister of Development, and he wanted to promote this program of agents, rural agents. They saved a lot of lives. Before that, and before the Industrial Revolution, there were a lot of doctors in China without wearing shoes, and we know we have a lot of agents, community agents, and we need to take out the healthcare system out of the hospitals to really go to these remote areas. Milta Videla, an Argentinian psychoanalyst, said that health is something as serious that we cannot leave that only in the hands of the professionals. You have the floor. Good morning. We're going to talk about an experience that I'm having in Brazil, in the Amazons, in the Brazilian Amazon, which would be in the Acre province. This experience was developed from the primary care point of view because Acre today is a province where there are more preterm babies in Brazil. We have the highest index of preterm babies in this province, where I'm being a nutritionist in primary health care. So I understood the need once I arrived to this city because there were only numbers. So the healthcare secretariat had data that in the city showed that there were around 50 babies that were preterm in the city. But we didn't know really where those babies were because there were only numbers. So I started to do a search. I started to search these babies to be able to bring them to the primary care to do all the follow-up of these babies. So I'm going to talk about the experience of 3 babies that I found in the city and had wonderful outcomes. So just to give you a context, Brazil today is a country with a lot of preterm babies. We have around 10 babies, 10 minutes, 6 babies, preterm babies are born. Our rates are around 11.567% of premature babies. And these data shows from 5 years where it says that Acre, there's a rate of 14.02% of preterm babies. And it's the highest rate of preterm babies throughout Brazil. In a territory with the highest concentration of preterm babies in Brazil. When we talk about prematurity in Acre, we talk about all the challenges, huge challenges that we face. It's a region where we have difficulties to access, vulnerability, limited assistance, vulnerabilities, because we don't have specialized teams nor equipment. I'm the only nutritionist of the province of Acre that has a specialty. So we're going to see that we don't have pediatrician, we don't have professionals, and we are limited related to a multidisciplinary team. So the challenges are geographical, territorial, assistential, and also social. We have a lot of challenges, as you can see. So how can we do a follow-up in the Acre province? We have a specialized service in the capital, in fact, 2 services, 2 units, where one receives the babies that are born in the capital city. Another unit was going to receive the babies that are born in other municipalities of the province. But both units are in the capital city. So our main concern is that the babies that are not in the capital city, these babies don't have any support follow-up. So we have 22 municipalities in the province, but we only have 2 units that are in the capital city. As you can see, it's a huge challenge for us. I am trying to really, so the politicians and authorities can hear me, taking advantage this elections year. I love the phrase that I saw here. It says, "We are public policy agents." I wanted to own this phrase. We are agents of public policies. So I have recently spoke with people here, and I will insist, because our Brazilian babies, they need to have an opportunity of access. We're fighting so this can be a reality. The region has low assistance, and in this territory where I am, we have a concentration of 13.4% of preterm babies. That today are only figures, because we are not able to find these babies, because there's no registration about these babies. That's our main barrier that we have in the city. And I'm trying to put in place some strategies so we can do an active search with the data, because we know there are registrations of these babies, and it's important to know where they are, where they live. And we can, in that way, do the surveillance needed in the primary care. So a region with 13.4% of preterm babies, and we don't have a pediatrician. Can you believe that? We don't have a pediatrician. So where I am, I'm the only nutritionist that I'm fighting to do the care, fighting towards the care of these babies. We don't have therapeutics area. We don't have anything at all. We don't have professionals. So the two units that we have in the capital city, they only have pediatrician. There's no nutritionist, there's no neonatologist, nothing at all. So we are really fighting to change this reality. So the babies that are far away from the capital city depend on the primary care. They depend on that, but the primary care that is giving a little bit more attention is in the region where I am. But we still have 3 more regions that I cannot be there, and there's no access for these babies. And they don't have any assistance or health care. The strategies that I developed based on this primary care point of view was the active research of these babies. When I went to look for these babies, they said to me, there's no preterm babies in this city. How come? We are in a province with the highest preterm babies, and you don't have any preterm baby here? So the data showed that there was 50 babies in the region, but they didn't know where they were. So I started, and I spoke with the community agents, and the community agents said, no, there are no preterm babies here. So I started, and I started to go to the radio stations and trying to really ask for the families where these babies were, so I could have these babies in the healthcare system. So I found 3 babies. And I did have the nutrition education. 2 babies that I found. I wasn't able to teach breastfeeding because this is the first case I'm going to present. The mother, she had some problems. And she was only able to see the baby 3 months afterwards. So, because she had some difficulties. The other baby with Down syndrome, premature, and the mother died. So the second case that I saw the opportunity to give the support during breastfeeding. I also developed information, development of the practices, of the food practices that were not good at all. And also, I organized the calendar vaccines. In one case, the baby had 7 months and wasn't even vaccinated. After 6 months, the baby wasn't even vaccinated. And also, something very important of this experience was vigilance through anthropometric, the overseeing the cephalic perimeter, and also family support, because we don't only treat the baby, we treat the whole family. We treat vulnerability. We take care of the social vulnerability, existential vulnerability as well. So this is case 1. This is a preterm baby of 31 weeks. And here we have an evolution in weight from 2.8 kilograms towards 10.3 kilograms. That's the evolution of the baby. So we did all the support of this baby. We accompanied the baby, the family, and basically what we can see here so we gave the support, and here you can see the curve. You can see an ascendant curve. We did all the monitoring. When he came back to us, when we arrived, was 2.8 kilograms, and now this baby is weighing 10.3 kilograms. You can see the baby with 11 months. He is having supplemental nutrition, and everything is okay with that baby. This is the first case. This is the second case. It was very special. Why? Because this baby arrived in our unit with 7 months chronological age. The mother had 14 years of age. During the visit, the mother said that she was pregnant again. So that day, the day before, she was breastfeeding, but the day before she arrived to the unit, she gave milk to the baby, and the baby was not tolerating the milk. So when we did the evaluation, the baby had 2.5 kilograms below the expected weight. So we have a high degree of vulnerability here because it's a teenage mother, 14-year-old teenage mother was again pregnant, and the baby was below this expected weight. She arrived to the unit with 5.3 kilograms, and we were able to take that baby to 9 kilograms. Here you can see the plots. So we did the support in weight. Here is the plot, as you can see it, showing the growth of this baby, gaining weight. This pointer is kind of crazy. Here we can see the growth plot, and here we can see the cephalic perimeter. So it's more than numbers. Here we're talking about the fact that it's more than a number. Sometimes as professionals, we only see the figures, the numbers, quantities, and plots. We need to reflect on quality. Apart from these graphs, we have the information that even though there's a lot of difficulties, even though that we don't have a multidisciplinary team, when there was a professional dedicated to make things happen and to take care of these babies, they had the opportunity to have a normal development and had the opportunity to receive a continuous care. Okay, so it's very important that in many territories that we see there are no teams, and primary care should really support this care that many times is going to be the only support of continuous support to these babies. This is the case number 3. This is a Down syndrome preterm baby. Here you can see the plot, all the curves that we did during the visits. And this is a special case because this baby, preterm baby with Down syndrome, his mother died. So the aunt took care of the baby, and he arrived with 2.7 kilograms, and we were able to take that baby to 5.8 kilograms. But this baby is still ongoing in his development and growth. So this is the experience that we have in primary care. So the final reflection is, in the Amazon territory, where I am working, basic care or primary care is not only an entry point, but yes, the most important network of survival and development of the preterm baby. As conclusions, that in these territories, primary care means the protection of the future of these preterm babies. And survive is not enough. A preterm baby needs to be continuously taken care of, and we need to guarantee development, nutrition, and continuous care. So primary care in our territory, and also when we have territories under social vulnerability, primary care needs to be strengthened so that these babies can really have access to healthcare system and to guarantee nutrition and growth. Okay, thank you very much. Okay, we've just heard 2 very important experiences, practical experiences of different situations compared to those of us who live in the big cities. So that's is a halt in our journey. I would like to ask you, do you have any questions, comments regarding the experiences that have been recently presented? Thank you very much. This is a very moving experience. Something very important from the science, quote unquote, of the pediatricians. I, first and foremost, would like to ask forgiveness to Iliana, because I was visiting Comuna Tresa, which I recommend for you to visit. I said to Leah, okay, I want to tell you a phrase from my colleague, from invisible to invincible, from invisible to invincible. So it calls my attention, this thing that you mentioned, Janilda, regarding it's not premature, meaning not knowing the problem.
And not recognizing the issue. This we know when we go to the analyst and to the psychologist, if we don't acknowledge the problem, we won't solve anything. And this is which I think it's the first vulneration of we wanted to make their issues invisible. We can see according to your activities, because I think that it's I think it's wonderful that you're making things visible, but how do we get to the highest spheres of the political brains that decide the future of our countries? Thank you so much of talking about this that define my path. One, it's this from visible to invisible, and one, it's the of the political health. I've been working about this. First, first of all, humanizing data, and you mentioned this, and how we, the pediatricians, there it's a sentence from the book The Little Prince that I love. It's that we love to use data, and therefore we love data. How much it weighs, how what's the size, but we never go beyond that. In pediatrics, we need to start translating, and I think you did a very good job with the second case, because we had a case that they wouldn't gain more weight, but he didn't have a caregiver because the mother had died. I think that sometimes to focusing in the curve and to see the weight, the size, or to see the formula, pediatric formula manual should be different, and to humanize the data, it's the best way to say things differently, to have an impact. And this is the first thing. It's not just to say that in the Guajira there are 567 women that are low weight. No, to say that there are 10 to 14 years teenage girls that are delivering babies. It's different. Or if I go to a neonate rooms, one of 4 beds, there is a baby that it's the child of a girl. But that the way in which we see things, and we as pediatricians, this is a commitment, but also we need to understand that the system, we are so scared of understanding the system. The guidelines, the protocols are perfectly written, but the reality of the territory are different. That's one to say when you read a manual of guidelines. And right now I was talking about this with Catalina. How do we accomplish this? We have a basic team delivered not long ago that the regulation changed from health promoters. And right now we have the health promoters law. We have intercultural pediatricians in the territory. But if we don't open up to understand the regulation, we don't know how to leave to the academia to get to these spaces where we may have an impact. That's why we pediatricians are the architects of the internal product of our country. We take care of the brains of those kids, and this is something that we need to understand. That's why the pediatricians need to know about public health. We need to know about public policy. We need to know about economy. If I invest in that brain, what is the investment rate to be able to get there and to tell the politician, hey, we're saving so much money, because they love money, right? And that's why this is something that we need to know, and we need to understand that it's not just a guideline and a protocol, but the best way is to open up. Also, it's a different development from the academia. In the academia and in how we are trained, we need to start to teach the social determinants, how to talk with the families, what skills may we have to be able to understand those territorial dynamics that are going to allow us to adapt the way in which you do things from primary care. And I think that this is so important. And I need a thank, based on what Dr. Ileana just said, something that we use a lot in, we can see the pediatrician that only takes care to organic disease can be a very good specialist in kids' disease, but he's never going to be a good pediatrician. A pediatrician needs to know about public health, etc., because if not, it doesn't make us different. We need to know a lot about a thing. We need to know about many things. Thank you so much for such a wonderful intervention. Thank you so much. I loved it. And I wanted to ask you a difference based on that experience that you have, that there is a population but there is a forgotten population. It can say that despite that there are very low resources, there is a cell phone, and in many cases, despite of the isolation, there is some internet, and it could be some very positive. But I would like to ask you, what impact have you seen in this with the misinformation? We can see the sale of the herb, or of for so the mother can produce more milk, or also in the inadequate way to do not feeding the way, because the influencer is saying all this information that everybody can include in, that everybody can give an opinion, anyone can be considered an expert, and that we can see that an expert voice. What have you seen? What's the influence of the misinformation in these communities? And therefore, we can see that according to the experience that we have, basically this is something that it's not permeated, at least in the most internal indigenous. And now let's talk about the suburban regions, because we're having a movement. Um, we can see that people trying to look for better opportunities, it's moving from rural areas to suburban areas. And there's a lot of misinformation. We have created groups, anti-vaccine. There have been anti-vaccine groups because doctor says this and this, but we have a lack of ancestral practices that were protectors, and I already modified them with the use of new food. And also I would like to say that the saturation of some food industries for the babies that are very small, to be able to include them all also in these areas, it's very complex. And therefore, besides misinformation, is how do I get to a community? And I get there with a term that it's also part of the misinformation, to be able to have the social programs or the organizations or the product that I want to sell. And I use the baby bait. Who is the premature? Who is the vulnerable? Who is the and from there we have a transactionalization of childhood, and therefore this is a baby that was born small. This is a small baby because we don't call premature, low weight, or whatever. We say a small baby. This is the baby that needs the program, and this is where the service gets. And therefore there it's an action, because misinformation, because the arrival of social media, that they get this, they say that at the end there's no continuity in the job, because I don't want the baby to get better, because I miss the governmental help. But therefore this, we can say this information about the exit product, it's gonna leave from here, and they're not gonna deliver me the water tank that I'm looking for. This is where we need to get there. I think we need a lot of and a lot of care education. We need to use social media. But something good about social media, it's maybe sometimes the cell phone, it's the only way to ensure the continuity of care, because sometimes you get to a community and you say, oh my God, I don't have I don't, in the community they say, okay, you need to go on the top of the tree, that there you can get a cell phone signal. Therefore you go up there to the top of the tree and you try to look for connectivity, and when you go there, that there's a phone in that connectivity. Therefore this is like to fix the, because if you are outside and you call there in that tree, you're gonna have a phone. I am going. Can I talk about this? Yes, I have a very interesting experience with WhatsApp. And therefore, we can see that all the babies or the families that I find of prematures. And and I connect them to the cell phone, and also I do all the guidelines if they are breastfeeding issues, and when and therefore and therefore he is going to see there's going to be a very significant tool, and so that the company of those babies. And I can see that we are out of time. We're out of time, but I have a wonderful sentence that you said, that it's that we are public policy agents, and um, and therefore uh, and therefore we are clear that that the pediatricians and whoever does follow-ups, we need to be public policy agents. Thank you so much. I think it's excellent that we don't need to build aqueducts or sewage. We don't need to do that, but we do need to do a lot of health education. When we do health education, as the sentence is anticipatory, if we change the first story, if we say we change the first story, we change the whole story. And the first story are the first years of life. Thank you so much. Thank you so much to all the speakers and all the coordinators of this segment. Thank you so much. And we're going to continue with the talk, immediate skin to skin in a very premature neonate with Dr. Stina Clemming. Please remember that we are going to have simultaneous translation available. You can scan the QR code that you can see on the different screens, and please use your headsets. And this is going to be coordinated by Dr. Catalina Lince. She's an advisor and kangaroo mother, and Alexandra Jimenez, who is a nurse that has a master's in maternal paternal. She is an advisor, and she is also a member of Fundación Canguro. Let's welcome.
Good morning, Dr. Stina.
And for all of you and the ones that are connected, good morning and welcome to this.
También de las charlas más esperadas, la doctora Stina Clemming es pediatra, consultora y neonatóloga, además de entrenadora NIDCAT afiliada a la Federation International. La doctora Clemming trabajó en el Karolinska University Hospital y en el
and in the Astrid Children's Hospital, included in the NICU, and it's been part in the NICU since 2002-2022. She is the director of the Reese NIDCAP of the Karolinska between 2018 and 2021. And she was the co-director of the NIDCAP Loncomalmo between 2021 and 2025. And she was an active participant in the research group of the randomized clinical trial IPSTOST, immediate parent infant skin-to-skin study. And she promotes and she teaches the family and baby-centered healthcare, taking into account the assessment and the customized care of the NIDCAP baby, both at the national as well as the international level. She currently presides the IFC group within the Swedish Neonatology Society. We can see are the concept of zero separation, immediate skin-to-skin contact, and also the joint care between the mother and the newborn. And also she was a co-president of a multinational work group appointed by the local Swedish authorities that in 2024 published the Swedish national guidelines regarding initial skin-to-skin contact and also the mother. And we can see that Dr. Clemming also presides the organizing committee of ultra early interventions in 2018, and she's been with us with the presentation. And therefore in the preterm care. Welcome. Go ahead, doctor.
This one. Well, thank you for that long presentation about me. Yes, we will have some practice today. So maybe I need that other microphone also, if I walk around a little bit. So I don't have to say anything more about myself, but today, and this talk is about the clinical practice of the best place of care for a baby, which is in skin-to-skin contact in kangaroo. And kangaroo is not a special care, it's a special place. Do you all have seen that you can get translation? I hope you have. So care is the same, the place is what we're talking about. And let's see, bumps. This is where I'm from, Sweden, if somebody didn't know where on the globe that is. It is, I come from Stockholm, but Sweden is also archipelago with small islands, and as well as deep forests, and up in the north with mountains, snow, northern light, reindeers, and our indigenous peoples, the Sami. So now you know that. And we will touch briefly on evidence, and as you said, the immediate parent-infant skin-to-skin study. And then I will present some clinical practice from my experience as a neonatologist, and also from this research. Sorry, I have 2 clicks to do. So here you see Sweden. And our indigenous people there. And yes, so just a little bit of the evidence and mostly clinical practice. I have always too many slides, so we'll see what happens. I have to speak faster, I think. So I have consent from parents for all the pictures and films. I have quite a lot of that. And as you said, I'm a member of the NIDCAP organization. So Sweden is, as you see on the upper picture there, is half the size of Colombia, but Colombia has 5 times the population. Sweden is a rich country. That's the per capita, the GDP per capita, so it's a rich country. And we have a very low neonatal mortality rate of 1%. In Colombia, it's 6.5 or 6.3 or something like that. We have, as the talk before, the previous, about the very tiny baby, we have active care for babies individually assessed from week 22 and 23 with the individual approach. There are less than 100 of these tiny babies a year, and about half survive. And we have a very high survival, as you see, for the older gestational ages of preterm infants, extremely and very preterm infants. And unfortunately, these numbers and figures haven't changed much the last 10 years. And between 30% and 50% of the smallest babies have severe handicaps. So there's a huge discussion on that at the moment in Sweden. Swedish neonatal care in numbers from the Swedish Neonatal Registry database, just for you to get some idea of the setting we have. We have about 100,000 newborns per year. It's declining as everywhere else in the world. We have only 5 to 6% of preterm birth, which is extremely low, and about 10% of babies need some kind of neonatal care. We have 30 neonatal units and 8 neonatal intensive care units, as we have 416 hospital beds for neonates, 1,200 registered nurses, 1,000 assistant nurses, so about 2,000 nurses on 10,000 babies a year as patients over these 38 units. We have short hospital stays. We use home care for early discharge with tube feeding, phototherapy, etc. Some other numbers. I will go through this fast, but we centralize care for the very most preterm babies below 28 weeks. We have good and consistent routines for antenatal steroids, magnesium sulfate, late cord clamping. We are restrictive with invasive interventions, with blood tests, and we are also very restrictive on blood transfusions. We try not to have mechanical ventilations, so even from week 24, we go for CPAP first. We have very low numbers of significant intraventricular hemorrhage, with about 9% if we don't count the tiniest babies. Low numbers on health-associated infections, necrotizing enterocolitis, retinopathy, and bronchopulmonary disease. We focus, as I said there, on CPAP, and we really focus now on skin-to-skin contact in kangaroo position for all babies that needs neonatal care. And as you see in the middle there, for babies below 32 weeks, 64% of the babies have skin-to-skin contact with the parent the first 24 hours. So this is really, and we have a focus now on zero separation with shift in organization of the neonatal care. Being close and in skin-to-skin contact is instinctively right and biologically needed for all patients, all parents and newborns directly at birth. And this is described by the rationale in the field of nurture science, which is describing the science behind zero separation. For all newborns, term and preterm, it is important to present these biologically expected experiences during the very early phase after birth. It is a critical period. So it's immediate mother-newborn skin-to-skin contact, smelling, connecting emotionally, suckling, getting breast milk. The baby being in the right place leads to increase in oxytocin with the foundational feeling of being safe. Lowered catecholamines and cortisol regulate stress and emotions and actually sets the stress system for life. Autonomic regulation leads to adaptation and stabilization of physiological systems. Instinctive behaviors for breastfeeding lead to nutrition. Microbiome maturation from the skin contact gives immune competence. And getting the right experiences sets the epigenetic programming. Improved emotional connection leads to parental sensitivity for the baby's behaviors, which gives the child the best possible start in life for the best possible development. And this is important not only for healthy term babies, but also for small and sick babies, even more for them. So we will now look into how we can keep all this and still do the care that many babies need. You know that WHO recommend skin-to-skin contact or kangaroo mother care to start as early as possible and continue for as long as possible during the hospitalization and actually beyond if the baby is small. And the WHO also envisions for healthcare services to be reorganized around the baby and the mother instead of, as it is now, around ourselves as staff. And this is really a description of zero separation and immediate and continuous skin-to-skin contact. They also acknowledge that this is difficult. It needs a rethink, a radical rethink even, to do this. And a rethink where we partner with parents, and parents have the most active role in the primary role of providing physical, emotional, and social care for their baby. a rethink where parents, initially the mother, provide the place of care in skin-to-skin contact or kangaroo. Also, when babies are small or sick and combined with technology and needed care. Separation is the most important developmentally supportive intervention for all newborns. Skin-to-skin is the natural and best environment for the baby. The WHO also highlights the importance of the father or the other parent and other family members to care for the baby, provide kangaroo, and supporting the mother. This is not for low resource settings, but for all babies. In 2024, the Canadian Pediatric Society published a position statement on skin-to-skin contact, stating that benefits outweigh the risks in most situations and that we should provide early and immediate and continuous skin-to-skin contact as a global standard of care for all newborns, term and preterm, and their families. And Cochrane updated their review on immediate skin-to-skin contact last year, and they conclude that the scientific evidence for immediate skin-to-skin contact is very strong for all newborns, and that they advise against more studies where babies, newborn babies, are randomized to separation. So they say that actually all babies need to be skin-to-skin contact in kangaroo immediately at birth, and we cannot do it in any other way. So that's very strong. The most important study for our knowledge and evidence on immediate skin-to-skin contact or kangaroo for very low birth rate babies is this very large IKMC study that was done in Africa and India. And in this study, mothers and newborns were cared for together. So they centered actually care around the mother-newborn unit. And they were in almost continuous skin-to-skin contact during the first 3 days, the ones in the intervention group, compared to the control group that did not have kangaroo the first 3 days. And this reduced neonatal mortality by 25%, which is an enormous number, or yeah, many babies that were saved by this. And it was specifically the infections, invasive infections, sepsis, that the babies were saved from in kangaroo. They also had a cohort of the group had a significant improvement in the Bailey scale at 12-month corrected age. And those were the babies that were randomized to immediate KMC and who actually had KMC within these first 3 days and had more than 8 hours per day. The others, if you had less than 8 hours per day, they saw no difference. So this is actually quite remarkable that we try to improve our neonatal care, and the numbers do not, at least in Sweden, improve much, despite all our efforts. But we put the babies in skin-to-skin, and that improves developmental outcomes. This study was initiated by Nils Bergman and Björn Westrup, and they also took the initiative to the sister study in high-income setting that I was part of, the Immediate Parent-Infant Skin-to-Skin study, IPISTOS. And we did it in Karolinska, Sweden, and Stavanger, South Norway. I was one of 2 neonatologists at Karolinska in this clinical RCT. So on the pictures, you will see my hands quite a lot. And we will briefly look at the results from the study, and then we will go into the clinical practice. So this is the extended IPISTOS group, but with, now yes, I will take these away. That was stupid. I have so many things now. So, so this was, the research group. And here is to show what we did, we randomized the place of care for the first 6 hours for 91 very preterm infants, 28 to 32 plus 6, just before birth. And the newborns were randomized to either skin-to-skin contact with one of the parents as soon as possible and preferably immediately. And that is the red group, as you see, and then the conventional care in an incubator for the first 6 hours of life. That is the blue group. And the skin-to-skin contact group, they had 5 hours out of these 6 in continuous skin-to-skin. But that extra hour that they were not in kangaroo or skin-to-skin contact was because of procedures like X-ray or something like that. So the intervention for 6 hours, and we measured how the baby was cardiorespiratory stabilization and temperature. And after 6 hours, both groups had the regular intermittent skin-to-skin contact or kangaroo that we usually have in the unit. And that was up to the parents to decide how often they wanted to hold their baby. But interestingly enough, in all the studies, all the analysis, we had to control for that the red group, the skin-to-skin group, they continued the first week to hold their babies twice as much as the other group, the control group. So when you start to hold your baby, you will want to continue. And then we followed the babies up to 2 years of age, and we did some publications, the protocol in 2020, and then the cardiorespiratory stabilization, which of course showed positive results, thermoregulation, where all babies had normal temperature, both groups, but skin-to-skin seemed to protect against hyperthermia, which you can get from the heater if you have it too hot. We asked the parents about their experiences, and they wanted this. They felt that it was a good experience. It helped them to connect with their baby emotionally, and it also seemed to protect them against early signs of depression and anxiety. We did a very interesting follow-up. At 4 months, we studied the mother-infant emotional connection in a test called the PESERA, Parent-Child Relational Assessment. And it showed that although the babies were often with father in skin-to-skin because of a high number of C-sections, and you will see that in my picture later, the babies at 4 months had a better social capacity in interplay with the mother. And we saw that it is safe to do this, although the babies were like this, prone with the head to the side. Some groups recommend that the head should be in midline the first 3 days, but we didn't do that. And we didn't see any increase in neurodevelopmental delays or IVH or anything like that. And we also followed the babies at 4 months with, we looked at cortisol and HPA axis regulation and co-regulation with the mother, which is a very interesting test, and it was also confirmed with the still face paradigm, where you have a stressor that the mother becomes still face and just looks at the baby and don't react. And that showed that the babies in the control group had a flattened HPA axis, which is very sort of bad for your resilience in life. And the study group, the intervention group in skin-to-skin, they had a co-regulation with the mother in their HPA axis, which is a very nice sign of resilience of your stress system. So our conclusion was that this is feasible and safe, have positive effects, and that this should be the standard of care for all babies above 28 weeks. And we also concluded that this study confirms that there is a critical window of time during the first hours. These first 6 hours are special. So that sets off a trajectory for the best possible outcomes. And we also saw that the effect of separation is devastating. We also have in our Swedish register data some proof for that this is a safe and good intervention. The very and extremely preterm babies in our register, and it's over 1,005 extremely preterm and 1,500 very preterm babies during some years of time. The babies that had skin-to-skin contact during day 0 and 1, so more or less 24 to 48 hours, they had lower risks of intraventricular hemorrhage and sepsis. Lower risks. So that confirms the IKMC study results too. Zero separation needs to be our common vision for all mother-newborn diets, regardless of gestational week and condition of the baby, actually. We should analyze every separation as a fault in our care and as a dangerous and negative intervention. And actually, nobody has studied what incubators do to babies. Now we're studying what skin-to-skin contact does to babies. But we should have studied incubators and separation before we started with it. Now we have to work a lot hard to come back to what it should have been from the beginning, mothers and babies together. So we have to prepare many things to be able to do everything in continuous kangaroo or skin-to-skin contact. And this boy, as you see, he is in direct skin-to-skin contact in kangaroo position with his mother, directly at birth and continuously for the first period of his life. And there he gets all the care with CPAP, and peripheral line is inserted on the picture. Yes, and then we will see a little film where things are a bit more complex, and then you can stabilize the baby next to the mother, not on the mother if there are difficulties, but next to the mother.
Fokus på att förebygga och skapa bästa förutsättningar. Men allt kan hända i det skedet för tvilling 2.
It's a twin, vaginal twin birth.
Bra. Det är bra. Upp med hakan i bröstet, Jane. Och all kraft neråt. Kom igen. Bra där. Och så en gång till. Jobba hela verken. På ren vilja. Jättebra. Stötta det. Bra. Och så vågar du. Där har du. Kom igen. Fortsätt. Jättefint. Kom igen. Nu kommer huvudet. Så, ja, hej vänner. Och så fortsätter du krysta. Tryck på. Tryck ut den här bebisen. Och så tänker jag att den här lilla bebisen går bara via bordet här och vårt gäng här. Kom och lägga ner honom. Fast. Kom nära. Upp med den. Den lyfter man bara upp den, jobbigt. Tag i handtaget där, upp med den. Så, snyggt. Ja. Och lite övervakning. Bara där. Ja.
This baby was very soon stable and could be positioned together with the twin in skin-to-skin contact on the mother. You saw how they put the baby on a small table with the cord intact, ventilation with an RPAP, which is, we can keep if it's okay, because I have many photos and films, so we can keep the lights off, please. Ventilation with this RPAP, which is a nasal CPAP that you can also ventilate on. And it's very convenient when we work like this. And the pulse sensor is called NeoBeat, and it's also very convenient and useful when we work like this. So whenever possible, we should avoid to place the baby on this little platform or table, the birth trolley, and instead work in immediate skin-to-skin contact. But here it was occupied by the twin, and they thought it was safer to move to the table and then back to the mother. But sometimes we actually need to do this in life-saving situations, and we should never compromise with safety. So, and also when, let's see here. So in this picture, this baby was in shoulder dystonia, so she was stuck for many minutes, and she was rushed to our resuscitation table. I intubated her, but after 30 minutes, I could extubate her. And we went into the room, and I think everybody does this. The mother can hold the baby a little bit or hold a hand on the baby, see the baby and so on. But I insisted that we should put the baby in skin to skin. And those 15 minutes, they made all the difference for this mother. She didn't experience as if she had been separated with her baby. She thanked me when they went home. Thank you for not separating us. Well, you were separated. First for 30 minutes, and then we took the baby to the NICU to put amplitude EEG and central lines and so forth because she wasn't okay. But the experience of the mother is that she had her baby. So we can always find 15 minutes. Also, if the baby needs hypothermia treatment, 15 minutes you have. We did this to speed up the change in Sweden. I shared a group that wrote this guideline, national guideline, and it has really helped. So that's a recommendation from me. Write a national guideline that can help all the units to then write their local guidelines. And you already heard that I was part of this, but so the main message is that mothers and newborns are cared for together, regardless of medical needs and complexity. And of course, that isn't, we are not stupid. We care for babies and we have safety. But this should be our vision. And that the baby is in kangaroo from birth and onwards. And that has to be translated as early as possible and as much as possible. In the guideline, our definition of, because as you saw, it is called immediate and uninterrupted skin-to-skin contact and mother-newborn couplet care. And our definition of couplet care is that two patients are cared for together, and that could actually be an old couple in a nursing home or a parent and a child after a car accident. But here it is the mother and the newborn, and that's why mother-newborn couplet care. And we will talk more about that tomorrow morning. So come and listen then. And for the immediate and uninterrupted skin-to-skin contact in kangaroo position, we define that as being in direct skin-to-skin, of course, and during the first 2 hours. Many recommendations say 1 hour, but not all babies proceed to through the 9 stages of breastfeeding behaviors, of the intuitive behaviors. So we said 2 hours. And this is for all babies from approximately 28 weeks and 1,000 grams. And if it's not possible to do skin-to-skin with the mother, we have written that it's the other parent, the father, or who else, and or a person appointed by the parents, so another family member. We need to prepare a lot, as I said. But stabilization and newborn care in the birth room, it is not different from our regular care. We do the same things. It's only the place that is different, and that is in kangaroo. We inform the parents and support them. We need equipment that is a bit new for us. So that's like the most critical step to prepare this transition to another way of caring for babies, that we need to get some equipment. We, as a NICU staff, need to be in the birth room, and we need the equipment, of course, to be connected to gases and power supply, not to run out, so that we can stay in the birth room. And the neonatal team have to listen to the obstetric team. They decide until the baby is born, then we decide. But we can really mess up vaginal delivery if we come in with a lot of noise and all our equipment and scare the mother. And it's not that she becomes, really, really scared, but just that little increase in stress can really put off the contractions. So listen to the midwife or obstetrician. And then we have the respiratory support and monitoring, as usual. We have temperature control, and that needs some extra attention. We need warm textiles, fabrics, and a warm, clean place. In a warm, clean place, yeah. So a cupboard like this is very nice. And I will show you later how we did with the textiles. But tubes, lines, feedings, fluids, everything is as usual, only the place is different. We have to keep that calm atmosphere and a good communication, and that's really what we do in neonatal care, right? We communicate, we have clear communication. So it's the same. And this is the equipment that we need to have to go mobile. Everything has to be on wheels and preferably in one setup, so that we know exactly where we have everything and no communication glitch of I thought you had and so on. We need everything to be there. And this is sort of a list of what we need. We also need an adult bed for the mother, a wheelchair for the other parent, and maybe one of those stabilization platforms or birth trolleys. So either equipment that you put together yourself. We started like that in 2006, many years ago, 20 years ago. But then we have also bought these readily made, commercially available ones. And this is how these birth trolleys, they were actually made for stabilization and resuscitation on intact umbilical cord, which is a very good idea and a very nice new intervention too. But this is a perfect backup plan for us to increase safety for our patients when we go for immediate skin-to-skin contact. And here you see in the operating room, the operating theater, a baby who needed CPAP. He was put first directly skin-to-skin with his mother as a healthy term baby, but he needed CPAP, so we brought the equipment to the baby instead of the baby to the equipment. And that's just that's the mindset we have to shift. And then we moved the mother with the baby over to a regular bed from the operating table and transferred the mother back to the delivery department. Why? Because in the recovery room after in the operating theater area, other laws sort of prevail, and we cannot decide anything. So we rather take the mother with us, and we take over responsibility of checking the mother and ask the midwife or the obstetrician to come to the mother instead. And you see also how we transfer with the wheelchair. So we don't have the baby on this platform if we can do it otherwise. So this is how it can look when stabilizing a very preterm infant in immediate skin-to-skin contact kangaroo. This boy, Elvin, he was born with cesarean section in week 28 plus 2, weighing 1,052 grams. We do not resuscitate babies in skin-to-skin contact after a C-section, in skin-to-skin with the mother after a C-section because of respect of the sterile field. We had a discussion of it. We had in Tuesday, we had like a workshop, and I was very surprised, but I haven't seen this in real life, so, but we couldn't try it. Maybe others have succeeded, but so we went instead to skin-to-skin contact, kangaroo position with the other parent, the father, the surrogate. And in this case, it is the sister of the mother. And here, little Elvin got all the conventional care with nasal CPAP monitoring, temperature control. The place was different, care was the same. And you see how we put the electrodes on the back since he was in prone position. We could also have in side lying, so he was probably a little bit in side lying in the beginning there and then in prone. The first, we covered him here, as you see, with, is this working? Yes. With a merino wool blanket. In the beginning, we had the plastic wrap, but some patients became cold when we kept the plastic over the baby and then continued with continuous skin-to-skin contact kangaroo. So we changed to this instead, merino wool blanket that we have closest to the baby, because wool keeps you warm even if you're wet, damp. Like when you go for skiing, for example, in the Swedish mountains, you always have wool to keep us warm. And then with the binder on top of this. We always try to go for nasal CPAP because, and not to have the mask over the face, because preterm babies are very easily get this trigeminal reflex. So they stop breathing if we put a mask over their face. And then we succeed in that we need to ventilate them. And we ventilate them, and we are so happy that we managed to ventilate them. Instead, skip the mask, give the baby just the nasal CPAP, and the baby will breathe. What else do we see in the picture? Yes. And then we put, of course, the saturation monitor on the right hand. And we just hold hands over the baby and let the baby adapt. We assess the breathing movements. How do we do that when we've covered the baby? Well, we feel them. And I asked the aunt, mother of the sister, if she felt the boy breathing. Yes, he's breathing well, strong. So we can trust the caregiver, we can trust the baby. The baby will breathe. If we are gentle, if we do no suctioning, we do not do suctioning. I have seen here that you do suctioning in vulva and directly when the baby comes out. We do no suctioning in the nose or the mouth. Because that can also make the baby stop breathing or hold their breath. They can, worst case, they can get a laryngospasm, right? We stopped that 40 years ago. Sorry. We put an elastic band on the cord. We do not have plastic clips because if you're going to lie on that clip, it's not very comfortable. So we have a rubber band, and we have that for all babies. And for this situation, we can cut the cord very long, and we can do it again later on, not to interfere with the position and lift the blanket and make the baby cold. Here we can give vitamin K, which we did here, but we could also wait these 2 hours and give vitamin K afterwards. But it's a good idea to look at genitals and anus to see that everything seems to be sort of there, not to get any surprises. And keep the towel, the blanket close around the baby, and also warm towels around the baby so to keep more warmth. Hold still protect the baby, be gentle. There's no stress, nothing, we don't have to hurry to something. We can just stand here and wait for the baby to regulate. We will get that time back later on because we will have to do less things with the baby. And when the baby feels stable, regular breathing, effective breathing, then we can start to put on a cap or hat or other things. But if we start that too early, the baby will stop breathing again. They're very sensitive, and the breathing is really what is most sensitive. And over here, so we have this wool blanket under this binder that we pull up, that the parent or the caregiver had on her already. And then on top of that, we put a heat-preserving blanket. There are different kinds of heat-preserving blankets. Yes? And now we will see a little video clip from a vaginal birth in Stavanger, Norway. I should also say that after 30 minutes approximately, this Elvin, the previous boy, got a nasogastric tube and food, but still in skin to skin. He also got a peripheral line. So now we will see this video, and it's very short. But you can see that the exact procedure is a little bit different than to what we did at Karolinska. They use the mask, they use the plastic wrap, but you can see again that no suction. So let's go. And if the cord is very short, then we have to work further down on the mother. But here is a very soft place, so we want to move up from the soft place as soon as possible. And we can never leave a baby down here. This way of working is possible also for twin birth. And also, I have to say, you saw that we do not have sterile drapes or covering at a vaginal birth. That was something that I was surprised over. That is a routine here. Maybe not in all of Latin America, but mothers just come in from the street in their own clothes, give birth. And we do not have high numbers of infections for mothers and so on. But here is a vaginal twin delivery in week 31 plus 5. The father was, of course, in the room, and that is also, I heard that is quite a recent routine in Colombia at least, but we have had that for many, many years. So the mother decides who attends her birth. If it's the father, another partner, grandmother, a doula, whoever. That's up to the mother. And then, so here we went for, after the cord was cut, the twin 1 was moved to the father to get the care there. Regular care, place skin to skin with the father. And then twin 2 came up to the mother. And then we just stayed. We had 2 nurses here, as you see, and 2 sets of mobile equipment. So quite a lot of things in the room, but it's okay. It works. It's crowded. It's a lot, but it's okay. And 1 nurse stayed, and me, just because I like it, stayed for 2 hours, and also because we did the study, so I was collecting data. But the mother spontaneously started to hand express, and she got 20 milliliters of colostrum. here. She had a 1-year-old at home, so that's probably why. So she started with this 45 minutes after birth, and that is perfect because it should be within the first hour. It has been shown that the breasts fill with colostrum from the oxytocin rush from the birth. So during the first hour, hand express. And we also use this very nice, and of course the mother should hand express with her baby in skin-to-skin contact. That's the good thing. And all over Sweden now we use this very nice invention. It's a little plastic bag with some syringes and cups and lids. A brochure on the importance of breast milk and how you hand express, stickers and a pen. Super easy. We call it colostrum kit. And all mothers get this if they have a baby that need neonatal care or are not expected to suckle during the first hour. And this has really made a difference in our setting. So we postpone routine care of the newborn for all babies, including small and fragile and sick babies. 2 hours in kangaroo with the mother or the father or a surrogate. Mother is always prioritized. So if we couldn't put the baby with the mother from the beginning, if the mother then is available, we move the baby to the mother. But we do not weigh the baby during these 2 hours or measure or give vitamin K or anything else, if possible, to wait. For things that we do want to do, like put peripheral lines or give food, put a nasogastric tube, of course we do it, and we do it in skin-to-skin contact, uninterrupted. Because most motivated procedures and interventions can be done in continuous skin-to-skin contact. Yes. So, I didn't speak fast enough. For C-sections, we have a recommendation that one arm should be free for the mother to be able to hold her baby. Otherwise, mother is like this, right, on the table, and sometimes clothes on. So, bare chest and one arm free, and so that she can have her newborn there. And for the preterms, as I said, we put them to the other parent. And this little girl was only 965 grams, and she's 15 minutes old here. I love this picture. And then for complications, we always have that backup plan. So either the father is the backup plan or the other parent, or we have a table prepared as the backup plan. And this little girl, she didn't breathe, 988 grams after a C-section. We put her to father, tried to ventilate a little bit, but she got bradycardic, so we went to the table to be safe. And then we could put her back to the father again. And this fellow, he didn't breathe, and he was very flaccid and pale, as you see here, and it showed that it was an ablatio placenta that we didn't notice until exactly at birth. He was rushed to this table and intubated, got surfactant and the rest of it. And then he could go back to the father. And this is how we transfer babies, either in a bed with the mother or with the other parent in a wheelchair. In Sweden now, we have a routine that is more and more common to take away the incubator or baby bed and instead have an adult bed to have skin-to-skin, kangaroo continuously, and if the parent has to put the baby down, we have a small little nest. And this is a setup for hypothermia treatment, because then you cannot have kangaroo because it's counterproductive. So that's how that is. And I know that I am taking too long time now, but I just want to talk about the safety. A soft place is not safe. We need high up, sternum to sternum. We need binders to have the safe place, not for the baby not to glide, slide, fall. And we need monitors. So for mother to sleep with her baby, we need to have the baby in a binder with a monitor. So safe KMC is really to have all the regular care that we have. High up, kissing distance, sniffing position, nose up. And to see a little bit of the baby. We want to see the face. And there is a nice thing I will show you soon. I have that, a positional support inside the binder. And this is how I at least want babies to be positioned, because this is how a competent term baby wants to be positioned. We will skip this film, but it is an online course with a QR code, and I hope you can reach it. It's 14 videos on iKMC on KMC. It will come again. And very short.
If you are in a setting where the incubator or cot and the mother's bed or chair have wheels, then think about moving the incubator and bed rather than the baby. In this example in Sweden, the baby is taken out of the incubator along with a small nest in which she lies. The incubator is then wheeled out of the way, and the mother, still in bed after giving birth, is moved into position. The baby is put onto mother, and then the fabric nest is taken out. This method involves much less handling of the baby and moving of tubes and cables, but it does require more healthcare workers and space. Remember, the idea is to disturb the baby as little as possible, to move her.
And of course, this can be instead the father, the grandfather, mother, so it doesn't need to be more staff involved. You just have to guide the parents the first times. But it's really nice not to take too much energy of the baby during the transfers. And when parents get to do all these things themselves, they get to know their baby, just holding the kangaroo is of course the most important, but also to do these things like, and I call them baby stuff, cuddling, washing, feeding, weighing, comforting their baby. They are prepared to do that, and they need to be able to do that. It's their right to do that, and it's the baby's right to have the parents there. And when we do this, parents are really the primary caregivers. So, and it makes work much more fun too. Start with that one bed for a mother. Start with that one family that is ready for this. Like Benjamin here and his parents. Mother had him 7 hours, then he was moved to the father, and then they spontaneously continued to take shifts of 8 hours. And they held him for 7 days. Start with the not so complex situations and patients. But let us together, step by step, increase the numbers of families that instead of the devastating experience of separation and disconnection, get an experience of zero separation and connection from birth of the baby and onwards, as the most important developmentally supportive intervention for the best possible development and the best interest of the child. And I will end with the voice of Gabriela Mistral, Nobel Laureate in Literature 1945 and founder of the UNICEF and Convention of the Rights of the Child. We are guilty of many errors and many faults, but our worst crime is abandoning the children, neglecting the fountain of life. Many of the things we need can wait, but child cannot. Right now is the time his bones are being formed, his blood is being made, and his senses are being developed. To him, we cannot answer tomorrow. His name is today. Let's do the radical rethink. If you are interested in, I forgot to click that. If you're interested in seeing me more with the recorded presentations and stuff, I have a YouTube channel there, and that KMC video, the online course is there. And my email, please email me. Thank you.
Muchísimas gracias.
Thank you. Thank you so much, Dr. Thank you so much, Dr. Stina. I think that everything that you told us is so inspiring, and definitely it's a mindset that we need to change, and how that the care is the same, but the change is the place where we're doing things because of time constraints and because they need to organize the rooms. Dr. Stina has another talk tomorrow, and that's why the idea is that the questions that you have them today, we'll keep them for tomorrow to be able to be compliant with our schedule, and or we can ask the questions of the doctor later, but we need to be compliant with time. Dr. Stina, thank you so much. Thank you so much. They do things that I think that we Colombians are so proud of. One, it's coffee, and another one thing, it's the mother kangaroo method. But one of the things that we should learn, because of course, is that the mother kangaroo method. It's something that we feel so proud of, and as we say, it's from Colombia to the world, is what you're teaching us today. And it's that we need to learn that we can do it since minute one, and that saves lives. Thank you, doctor. On behalf of my colleagues, thank you. We
Alexandra, Alejandro y a la doctora Lidia y a todo el grupo organizador, un congreso espectacular. Disfrutamos muchísimo las conferencias de esta mañana, inspirador la última para nosotros, entender que se pueden hacer cosas integrales, excelentes, conceptuales. No estamos hablando de tecnología, estamos hablando de hacer las cosas bien. Así que muy contentos, primera cosa. Segundo, Andrés, agradecerte a ti. Andrés estaba ayer en otro lado del mundo. Agradecer que hubieras llegado. Muchas gracias por estar aquí, te vamos a aprender mucho. Espectacular poder compartir contigo, así que gracias por haber llegado. La tercera cosa es, yo creo que todos nos sentimos orgullosos de Medellín. Cada vez que uno viene, Medellín está más hermosa. Cada vez, es impresionante. Uno viene, una zona nueva, es una ciudad que nos demuestra que las cosas se pueden hacer, ¿sí? Es un potencial impresionante, no ha perdido su encanto de la gente maravillosa, pero ahora tiene cosas culturales, educativas. Es una ciudad espectacular, así que espero que después de que salgan de aquí puedan disfrutar la ciudad. Bueno, Andrés, yo creo que la primera cosa, si le pregunto aquí a Sandrita, a Liliana, a Julietica, a todos mis compañeros, a Martica, todos decimos sufrimos en esta época con los recién nacidos. ¿Por qué? Porque como decía Julio, tiene un impacto impresionante el virus sincitial respiratorio en las unidades. Son niños que te llegan, se ponen muy malos y que es un pico en el cual tú tienes que incrementar siempre el número de camas. Así que, ¿por qué ocurre eso? El recién nacido no tiene reserva. Ya tiene una frecuencia respiratoria suficientemente alta, una frecuencia cardíaca suficientemente alta, entonces falla con nada. Así que nos pasa a nosotros. Segundo, es muy importante que en el periodo neonatal se manifiesta diferente a los chicos más grandes. Estos niños llegan con apnea, llegan con bruit, llegan con cosas delicadas en poco tiempo. Y tercero, eso Andrés, le voy a robar una frase de él, espero que no importe repetirla, y es que me gustó mucho esa frase que tú tienes en una diapositiva posterior que dice, después de que el virus sincitial respiratorio llega al pulmón, ese pulmón nunca va a ser igual. Impresionante, no lo hemos visto nosotros, siempre vemos las cosas a corto plazo.
Entonces acá nos unimos como especialidad en lo que ustedes ven el día a día, ¿no? El resfriado común que se vuelve no solo un resfriado común. Y partimos de un caso en una historia previa a lo que en Colombia fue el ingreso de 2 opciones que tenemos hoy disponibles adicionales para inmunoprevención y sobre todo en esto, pensarlo en que también al sano se afecta, no solo el neonato pretérmino, sino la deuda que teníamos con la población sana, que también enferma, ocupa camas, fallece no solo en hospitales, sino también en comunidad. Y miren el tiempo, es todo muy rápido. Y realmente cuando ya se detecta, en los que los podemos detectar, doctor Oscar, la pregunta grande es esta: ¿dónde quedó la ventana de prevención? ¿Qué pudimos hacer mejor en ellos? Miren, este es 2024. Estos son pacientes que siendo sanos también se intuban, también se ventilan. La detección de sincitial, por supuesto que lo acompañan muchas veces otros patógenos, en este caso micoplasma, y yo siempre me río y le pregunto a los neonatólogos cuándo aprendieron que la sepsis neonatal la causaba el micoplasma. Y pues no siempre está ahí, tiene un facilitador y en este caso el sincitial es uno de ellos. Miren la afección pulmonar tan grande y la rapidez, doctor Oscar, con que progresa. Esto se cuenta en pocos días. El resfriado común o la ira por sincitial se pone grave entre el día 3, 5 o 7. Conforme pasa el tiempo, no es que necesariamente vayan todos a mejorar. Y algo, doctor Oscar, importantísimo, cuando la señal de alarma, dificultad que él nos cuenta de taquipnea, apnea, etcétera, aparece, ya la prevención pasó. Entonces, doctor Oscar, este punto importante, ¿por qué el sincitial hoy no sigue ganando?
Sí, como tú lo acabas de decir, es una presentación totalmente atípica. Casi siempre estos niños llegan, ahora hablamos un poquito de los fenotipos, por apneas, por ejemplo, tiene un deterioro que es progresivo, el bebé le llega y uno lo ve, no, esperemos un poco, al otro día el niño ya está en cánula nasal de alto flujo. Así que son niños que se deterioran rápidamente. No olviden que esto es importantísimo, Andrés, golpea al niño previamente sano. Nosotros con Lili, el grupo de nosotros presentamos en ASCON nuestra experiencia de 4 años y adivinen, más del 90% de los niños que habíamos tenido habían sido niños previamente sanos, muy parecido a lo que están diciendo ahí. Así que, claro, el prematuro, el displásico, el niño cardiópata tiene problemas más delicados, pero quien aporta la gran mayoría de esa pirámide es el niño previamente sano. Y los fenotipos, solo vamos a recontarlos así rápido, ustedes se lo saben. Primero acuérdense que es el niño que, como el que estamos hablando del caso, que hace apnea. El segundo es un niño broncostructivo realmente, el tercero es un niño hipersecretor, el cuarto es un niño con hipertensión pulmonar asociado, el SDRA, y el niño con displasia. Pero no quiero aburrirlos con eso, solamente que si uno los agrupa, usted tiene 3 escenarios. El primer escenario es el niño que acabamos de ver, gripa, deterioro súbito y apnea. El segundo es un niño parecido al más grandecito, que es un niño ya con sibilancias, con síndrome broncoconstrictivo. Y el tercero es el SDRA, que nos saca canas, que se pone malo, que hace PEP inadvertido y que nos hace neumotórax y otras cosas. Así que esos son los fenotipos que están ocurriendo y estos mensajes son muy importantes, Andrés, en esta primera parte que estamos hablando.
Y acá contarle, doctor Oscar, y contarles a ustedes lo que nos debe pesar como médicos. Esto, lo que llamamos, y debemos tenerlo así presente, la carga invisible en la enfermedad por sincitial. Miren, lo que vemos es el hospitalario, ¿no? Ese que logramos diagnóstico y los que tenemos acceso a diagnóstico, o sea, los que hacemos el ejercicio correcto con PCR o prueba molecular. La prueba rápida, doctor Oscar, la que a veces ni preguntamos qué tenemos, deja escapar 5 de cada 10 pacientes. O sea, probablemente muchos los declaramos negativos siendo sincitiales. Entonces, esta es la cúspide de la pirámide, el triangulito de arriba, pero todo lo sumergido es todo lo que tenemos al otro lado. Aquel que el fenotipo no le dio, la gravedad no le dio para ingresar a la UCI neonatal de intensivo intermedio y no le hacemos diagnóstico, queda como bronquiolitis no especificada. El regreso del ausentismo escolar, lo que le cuesta a un papá cuidar a un paciente que se admite por causa respiratoria. Y la huella futuro que el doctor Oscar ya les mencionó, el pulmón no vuelve a ser el mismo. Entonces tenemos que salir de esta primera columna a decir todo lo que tenemos y las opciones que tenemos para prevenir esa carga invisible. Doctor Oscar, para preguntarle un poquito de esto también. ¿Qué pasa en el agudo? Lo que usted ve y lo que nos contó, pero ¿qué pasa en el horizonte lejano para el neonato?
Bueno, la primera cosa es que, como creo que todos lo sabemos, nada sirve en el recién nacido que presenta una bronquiolitis, ¿sí? O sea, uno mira la evidencia y realmente, septocando el alto flujo, de pronto algunos con microdosas de solución salida hipertónica, colocar una sonda, de resto, nada de las cosas de evidencia te sirve. ¿Qué ocurre? Que cuando todo el mundo dice, ah, sí, yo no lo uso en mi unidad, pero cuando el chino se pone malo, malísimo, empieza Martica, mi terapeuta, doctor, ¿pero por qué no le hacemos una pruebita de adrenalina? Doctor, ¿pero por qué no le ponemos petalosa? ¿Cierto? Entonces, en pocas palabras, es muy importante entender que no hay evidencia para tratarlo. Si tú no lo haces juiciosamente y eres rígido, no ves ninguna diferencia en la historia natural de la enfermedad. Pero entonces lo que dice Andrés es muy clave. ¿Por qué? Porque lo que sí tenemos que hacer es prevenir, porque no tenemos con qué tratarlo. ¿Qué pasa? Hay reingresos por nuevos episodios broncoconstructivos. No sé si lo sabían, pero imagínense que el 44% de los pacientes que presentan una bronquiolitis grave en este periodo va a ser otro episodio sibilante el primer año de vida. Pronto lo van a ver ahorita más tarde en algún estudio. Y ojo, me voy a adelantar con algo que de pronto vamos a hablar con Andrés, ¿cierto? Y es que 4 veces de riesgo cuando un niño hace una bronquiolitis importante, o sea, síndrome constitutivo bajo, ese niño para hacer 4 veces más asma en el futuro. Asma, eso no lo sabíamos antes. Así que, en pocas palabras, sí sibilancias, sí te requieres consultas repetitivas, mayor riesgo, como lo acaban de ver, de asma, una remodelación de la vía aérea, ya Andrés nos lo va a mostrar en cómo actúa en esa vía aérea, pero es una enfermedad que no es, chao, bronquiolitis y no pasó nada, no, siempre nos va a generar cosas adicionales.
Ahí, doctor Oscar, la pregunta que queda es esto, ¿no? ¿Por qué prevenir realmente modifica el futuro biológico de todos los recién nacidos? Y para eso, doctor Oscar, quiero invitarlo a que nos hable un poco de carga de la enfermedad. ¿Qué tenemos de los datos que tenemos? Entendiendo que los datos que tenemos son esa cúspide de la pirámide, que tenemos una carga sumergida que a veces no contamos.
A mí me impresiona, no importa cuántas veces lo leas, pero no sé si a ustedes ese número no les parece increíble. 33 millones de episodios de infección respiratoria baja en menores de 5 años. Ahí está 2019. Es impresionante. Colombia tiene 50 y pico, o sea, más de la mitad de Colombia, un país como el nuestro, hay infecciones en el mundo por virus sincitial. Y miren, 3.6 millones de hospitalizaciones anuales. Así creo que la introducción de Julio que decía que pocas terapias marcan la diferencia con un impacto tan grande, es cierto. Así que miren, 33 millones, 3.6 millones de hospitalizaciones y ojo, no sé si ustedes lo sabían también, de los 500,000, ¿cierto?, pacientes que mueren por esa bronquiolitis, ¿cierto?, el sincitial es la segunda causa después del neumococo, en los menores de 5 años, o sea, 101.400 muertes. Y para dolor de nosotros, Julietica y Martica, la mitad de esos pacientes ocurren en menores de 6 meses y en el periodo de nosotros, ¿vale? Así que el impacto en la mortalidad menor de 5 años es impresionante. No olviden esos números que a mí siempre me han parecido increíbles.
Pero les quiero contar este otro dato importante. En lo que lo aprendimos con la experiencia con palivizumab, la población de cachap que se nos quedó pendiente, la población que diagnosticábamos postnatal, el error innato de la inmunidad que aparece, la hipogama común variable, la fibrosis quística que detectamos, la cardiopatía que detectamos. No sé, doctor Oscar, si usted seguramente se enfrentó en ese momento con el anticuerpo monoclonal mensual, que teníamos a veces la limitación que autorizaban una, tal vez no la segunda, de pronto no la tercera, y se salía del mapa la necesidad y el derecho garantizado que tenían en su momento de las 5 dosis. Sincitial tiene esta dificultad, lo mencionaste, primeros 6 meses, 46% de los muertos ocurren ahí, pero afecta hasta los 2 años significativamente, con el impacto en la remodelación biológica, doctor Oscar, que continuamente vemos. Entonces es un mensaje insistente, que tenemos que tener el mindset todo el tiempo presente. Claro, hay una población que debo proteger desde el primer momento, pero hay un catch-up que debo hacer cuando la población se me escapa, y es la labor poderlo identificar en eso que llamamos segundas temporadas, que a veces se difumina un poco en la estacionalidad de países como el nuestro, pero que tal vez Chile, la Argentina tienen más claro, o ciudades particulares como Bogotá. Pero es muy importante porque van a ver que la solución da cierto grado de protección de tiempo, pero hay una ventana de oportunidad hasta los 2 años donde podemos intervenir.
Espectacular eso que acabas de decir, y vamos a adelantarles un poquito como conceptos para que vayan quedando fijos. Antes no se sabía si, bueno, esos niños se les colocaba el nacimiento y si el catch-up era igual de efectivo. La respuesta es lo que acaba de decir Andrés. Sí, los estudios han mostrado eso, que en Galicia, que el catch-up es muy efectivo. Muy bien, entonces si ustedes se fijan en esa mortalidad por virus sincitial respiratoria, lo más doloroso es que no se distribuye homogéneamente en el mundo. ¿Sí? La mayoría, por encima del 90%, los bebés mueren en nuestros países, o sea, con ingresos medios y bajos. Es muy doloroso, se nos mueren es a nosotros. Y, aunque creo que Andrés lo va a tocar ahorita en la siguiente diapositiva, para acabar de completar, por ejemplo, en Colombia, 2 departamentos aportan el 24% de la mortalidad. Es increíble que eso ocurra. Entonces, en pocas palabras, es heterogéneo, no es homogéneo en todo el mundo y para nosotros tiene un impacto muy alto negativo. La buena noticia para nosotros va a tener un impacto aún más grande positivo, poder prevenir el virus sincitial respiratorio.
Total, Doc. Y esta gráfica, ¿qué tanto la podemos volver, pues, gráfica? 1 en 5 niños van a tener necesidad de atención hospitalaria, pero pregúntense en los priorizados, consulta prioritaria, triage. Y 1 en 50 será hospitalizado en su primer año de vida. Y si le sumamos segundo año, pues esto nos aumenta la cadena. Doc, esta parte, América Latina, ¿cómo estamos en respuesta, hospitalización, punto centinela? ¿Su trabajo es centinela en los COBOS?
Bueno, todos hemos sabido que aunque tenemos unos picos en las ciudades, de todas maneras no es fácil porque está durante todo el año. Estos anticuerpos monoclonales que son de larga duración nos van a poder cubrir 150 días mínimo y algunos incluso tienen un impacto hasta del 49% hasta los 180 días. Entonces eso nos va a ayudar muchísimo en esa parte respiratoria que cubre buena parte del año y que además los chicos se están volviendo más grandes. Así que esa es una cosa que nos va a ayudar a nosotros en forma importante porque es diferente. Fíjese que hay circulación del virus en todo el año. UCI pediátrica se reduce. Y entonces cuando usted, como dicen los chilenos, cuando usted logra reducir esas camas de virus sincitial respiratoria, ya tiene camas para manejar a otros pacientes de UCI pediátrica. Así que el impacto que ha tenido, y me adelanto un poquito, en Chile, la charla de la doctora Celia Martínez esta mañana de Paraguay, espectacular el impacto que ellos tuvieron. Bogotá, o sea, Colombia con la experiencia de Bogotá va a ser la tercera experiencia en Latinoamérica. Así que vamos bien, Andrés, con eso, muy bien.
Y recordar la heterogeneidad y el sufrimiento, doctor Oscar, que estamos viviendo, por ejemplo, en Colombia. No sé de sus países cómo estén, pero acá el cierre de camas pediátricas y neonatales se nos volvió rutina y se nos volvió el sol diario. Y tener una oportunidad de darle camas a otros pacientes cuando podemos prevenir algo inmunoprevenible, pues es un reto adicional para el médico pediatra para poder lograr dar respuesta a todas las otras enfermedades de la primera infancia. Y quiero mostrarles ViralNet, este grupo que se encarga de mirar vigilancia y mostrarles cómo es Colombia, porque hay que individualizar país por país y no puedo tener la misma óptica de zonas con picos y seguramente acá caiga Perú, acá caigan muchos de los países de Centroamérica, Ecuador probablemente también. Miren un poquito, a ver si me da esto es Bogotá, Bogotá con su pico claramente marcado, que es abajo. Miren Cúcuta, que es esta, es mi ciudad, todo el tiempo. Pero mensajes claves, sincitial nunca desaparece, o sea, durante todo el año, miren, la positividad está ahí. Llega a picos de 60%, a veces más, pero siempre hay un estado basal, no es que llegue a estar en cero. En general, casi 40% de los datos son sincitial, en lo que vemos de circulación anualizada. Y cuando no tenemos estas estaciones claramente definidas, uno puede decir por territorio la universalidad de protección es necesaria, o al menos por ciertas ciudades o departamentos. Y quería contarles esto que lo preocupa a uno mucho, que son los datos de mortalidad que menciona el doctor Oscar. La Guajira y Chocó, hombre, donde más se mueren, denominador común, menor camas de UCI neonatal, menor capacidad de pediatras, menor atención por neonatólogos, por supuesto menor proceso de inmunización, y con todo eso son los que más datos aportan. Y si les digo, menor capacidad diagnóstica, y a pesar de eso tenemos sus primeros lugares. ¿Cómo sería si en la realidad a todo el que consultara le hiciéramos los estudios?
Andrés, ahí ese 361, que ya lo has comentado antes, ténganlo en mente, porque somos un país mucho más grande que Chile, mucho más grande que Paraguay y la población es más alta. Entonces, este número de muertes, van a ver cómo, me adelanto un poquito, Paraguay bajó a 0, de 12 a 0, de Chile de 13 a 0, muertos, habiendo una intervención de un anticuerpo monoclonal, y tenemos la esperanza, todos los que amamos a nuestros recién nacidos, que logremos impactar con esta mortalidad que es mucho más alta, pues porque somos un país más grande.
Esa tablita la tenemos para mostrarles Colombia tan gigante como es, pero neonato no es un dato más, Doc. Cuéntenos acá un poco de estos 3 puntos tan importantes y por qué el recién nacido tiene que salir de ese concepto de solo prematuro, solo niño con comorbilidad a una protección completa.
Bueno, como ya lo habíamos dicho, fíjense, la mitad de los pacientes, un poquito de la mitad de los pacientes corresponden a neonatos menores de 28 días. O sea, ocupa una gran cantidad de las UCI neonatales. Y el 50%, ya lo habíamos comentado, de las muertes intrahospitalarias por virus ocurre de menores de 6 meses. O sea, los que se nos mueren son los chiquitos. Esos son los que nos están muriendo. Así que hay una parte muy importante que es la presión en esos primeros días, que mayor estancia, mayor apnea, pacientes prematuros, cardiópatas muy vulnerables, y esta, que no la tenemos en cuenta porque la dejamos de ver, que son los pacientes que reingresan luego por cuadros respiratorios o básicamente por secuelas de un episodio viral primero, y ojo lo que decía Andrés, que es muy importante, pero que queremos recalcarlo, no olviden este número, la mayoría de los bebés que están ingresando no era el bebé que cubríamos afortunadamente con un anticuerpo monoclonal de antes, sino los que estábamos descubriendo eran los pacientes sanos.
Y este dato es importante, esta es la factura en el sistema. Todos somos actores públicos, todos tenemos una obligación en ahorrarle gastos al sistema. Si yo tuviera una protección universal, miren todo lo que puedo disminuir en gastos directos e indirectos. No me detengo para aumentar lo que ya hablamos y lo que ya mencionaste, pero la oportunidad para otras enfermedades, familia y productividad, hospitalización y gastos directos. Entonces, doctor, acá hablemos un poquito de más allá del pulmón. Quería preguntarle por esto, un espectro diferente a la bronquiolitis. ¿Cómo más podemos ver la infección por sincitial?
Pues fíjense que ya habíamos tocado un poquito del tema, esto es lo que nosotros vemos en las unidades, pero después vemos que esos niños vuelven a reingresar, incluso a veces llega uno y dicen, hey, llegó un prematurito de canguro, y uno, bueno, tómenle panel, miremos a ver qué pasó. Y resulta que lo que nos dimos cuenta es que ese niño ha tenido un episodio previo y lo que están haciendo es un segundo episodio ahora. ¿De acuerdo? O incluso es un niño displásico o cardiópata y el niño está haciendo ahora un episodio de ese tipo. Así que en pocas palabras, en la parte aguda y en la parte ambulatoria sí tiene un impacto importante. Y a largo plazo, Andrés, estamos viendo que esos niños empiezan a hacer, como ya lo dijimos un poco, una frecuencia mucho más alta de asma.
De acuerdo. Y eso nos trae a la conclusión, ¿no? ¿Con qué pulmón sobrevive el niño? Eventualmente ese es lo más interesante de esto es la prevención de sincitial. Entre más temprano prevenga y más tiempo dure la protección, sobre todo en esos primeros 2 años, sobre todo en cohortes susceptibles, podemos tener garantía de que el pulmón no se va a ver tan afectado. Hay unos mecanismos, doctor Oscar, relacionados al daño pulmonar.
A mí me parece, cuando empecé a leer esto, me acordaba yo del epitelio intestinal y yo decía, pucha, mire lo parecido. Entonces, miren, hay un daño epitelial directo por el virus y además nosotros le ayudamos después con el ventilador. Segundo, hay cambios epigenéticos, es decir, hay una expresión diferente cuando se expone al virus. Y que es un tema que creo que a todos nos encanta, el de disbiosis, porque está metido en todos lados, incluso para nosotros mismos. Y miren que hay una disbiosis del microbioma respiratorio, igual que en el intestino. Hay una inmadurez y desregulación inmunitaria. Andrés, me gustaría que hicieras un par de comentarios al final porque sé que eres un experto. Y hay una reprogramación metabólica en estos recién nacidos. ¿Se acuerdan cuando hablamos de reprogramación metabólica en los pacientes con restricción de crecimiento, que hacen enfermedad metabólica, después con enfermedades cardiovasculares en la adultez? Bueno, lo mismo ocurre en reprogramación metabólica en estos pacientes que presentan infección respiratoria y después posinfección después.
Y ya lo mencionaste, ¿no? Sibilancia es una gran cantidad que quedan pegados el primer año, pero lo importante es la última oración. Prevenir la infección es prevenir un fenotipo, 1, 2 o 3 a largo plazo de afección respiratoria. Y miren esto, pasamos de decir que un virus podía probablemente dar asma a decir definitivamente sí se relaciona con asma infantil. Y ese es el factor de riesgo. Y el dato más importante es el último. Entre más grave la infección por sincitial, más riesgo. Miren el OR, casi 4 veces más riesgo de tener asma más adelante en nuestra vida, pues de la infancia. Entonces es muy importante, todos los estudios son consistentes y quería mostrarles el estudio INSPIRE. Disminuyo la probabilidad de ser asmático si disminuyo la probabilidad de infectarme tempranamente. Ojo, en los primeros 5 años, sobre todo en los primeros 6 meses, si esa infección no se presenta, el riesgo de no tener asma pues está ligado a futuro un 26%. Y doctor Ovalle, miremos esta parte. 4 tiempos. Esto es como el sincitial reescribe el horizonte, ¿no? Primeros 6 meses, levito bronquiolitis, neonato, ventilación. Primeros 5 años, sibilancia recurrente y asma. Pero le quiero contar, doctor Ovalle, que en el adulto tener sincitial temprano da 2 veces más riesgo de muerte prematura y se asocia con remodelación pulmonar y aumentar el riesgo de POC. O sea que si ese adolescente vapea o fuma después y tuvo sincitial de niño, su riesgo de POC va a ser mucho mayor. Y todo eso se resume en prevención, todo lo que podemos evitar en el horizonte de esos pacientes. Esta reflexión para que se la lleven, doctor Ovalle, ¿no? Prevenir sincitial es modificar todo lo que puede cambiar la historia biológica de los niños a futuro. Y ya voy a robarle 10 minuticos, doctor, para contarle un poquito en infectología. ¿Cómo verlo saliendo de la unidad neonatal? Lo primero es esto. Es muy común. ¿Quiénes de ustedes han dicho bronquiolitis sobreinfectada? Todos los días decimos. Y entre más maluquito se ponga el niño, si pasó de cánula a alto flujo, eso es casi que antibiótico al lado, ¿no? Eso es imposible negarlo. Si no tengo diagnóstico, pues peor, queda como posible neumonía. Pero eso hace toda la disregulación del microbioma, nos impone adicionalmente un riesgo a futuro de daño epitelial y depresión ecológica y mayor resistencia. Lo que sí vemos, y en esto la doctora Claudia Beltrán, que está acá, tiene unos estudios muy lindos, ha mostrado que el sincitial no va solo, el sincitial co-circula, ¿cierto? No solo llega sinci solito, sino que sinci permite inflamar, puede llegar con rinovirus, con neumococo, y miren, si se infectan los pacientes, uso más antibiótico, pero la gran realidad es que el sincitial cuando está solo con otros virus no requeriría antibiótico y a pesar de ello a la mitad se los ponemos, a la mitad. Y dígale usted como infectólogo a un neonatólogo, suspenda el antibiótico. Doctor, es que está en ventilador, no, malito. Es muy difícil, se vuelve una conversación a veces compleja. Tenemos que tener un grado de confianza muy bueno con el neonatólogo para que nos siga el proceso y una confianza en la práctica terapéutica. Entonces realmente permite optimizar el uso de antibióticos. Y adicionalmente, para ustedes este dato no es nada banal. Yo escuché al doctor Oscar mencionando que en su unidad, él, y de hecho en la indicación, administra palivizumab 5 o 3 días antes del egreso. Pero cuando yo involucro un anticuerpo monoclonal de larga duración en un protocolo desde el nacimiento, yo tengo la garantía que el niño quedó, así tenga que estar hospitalizado, protegido. Y eso es muy importante porque hay una fuente de infección en el recién nacido que no vemos, nosotros. Y hemos tenido, la doctora Martica Africano ha tenido también en su unidad y en todas las unidades, brotes de sincitial de causa nosocomial. O un niño que llegó, lo cortizamos mal y como se transmite por contacto, pues infectamos al resto de niños. Y esto sí que cuesta, doctor Ovalle, y poder prevenirlo, pues nos ahorraría todo este impacto.
Importantísimo eso, Andrés, y sí, tienes razón. Con estos anticuerpos monoclonales que son de mayor duración, nos ahorran dos problemas. Uno es que hace unos años estuvo Leslie mirando eso, Julieta también, estuvimos mirando en ASCON y resulta que el promedio más o menos de que se colocaba era 1.8 de palivizumab y tenían que ser 5 dosis. Imagínense, o sea, tú no lograbas la adherencia realmente para hacerlo. Y la segunda cosa es que yo tengo ahorita varios bebés, ¿cierto, Lili? En la unidad con un cuadro respiratorio. Imagínense, tengo un prematuro de 25 semanas y tengo 2 prematuros gemelos menores de 27 semanas que estuvieron ahí. Si ese niño no hubiera recibido el anticuerpo monoclonal, yo estaría así. ¿Por qué? Porque se le puede pasar la infección a pesar de que tú separes el personal de enfermería. Manejan el mismo teléfono, se saludan por la mañana. Así que en general lo ayuda a uno mucho realmente a reducir brotes en la unidad porque tú ya lo colocaste. Así que eso ayuda para uno tranquilizarse.
Y mostrarles esto. Línea verde es todo lo que es la atención de urgencias, ¿cierto? Entonces, esto es Bogotá, del doctor Iván Felipe Gutiérrez, de lo que hacemos en ViralNet. Y cuando se dispara la moradita, miren lo que es sincitial, ¿qué se dispara? La atención en urgencias. Si yo evitara la moradita, pues las camas hospitalarias quedan libres. Y ese es un mensaje que quiero que se lleven con el doctor Ovalle de esta reunión. Y lo otro importantísimo, y eso que el doctor Iván es intenso con los antibióticos. ¿Qué se le disparó al doctor Iván cuando aumenta el sincitial? El consumo de ampicilina, que es nuestro antibiótico de primera mano para la causa número 1 de neumonía adquirida en la comunidad. Entonces imagínense todo esto en vida real, cómo se haría meseta si no tuviéramos la necesidad o la duda clínica frente a un paciente grave por sincitial. Por supuesto, pediría que saquen sus celulares, este QR es importantísimo. Nuestra aspiración es LATAM, tener patrones de circulación en Latinoamérica para nosotros es muy importante. Ya lo hacemos en Colombia y nos permite realmente tener algo de decisiones, diríamos, preventive, antes de. Hablemos, doctor Oscar, de la ciencia detrás de una sola dosis y le entrego esta lámina que sé que le va a encantar.
Sí, bueno, si alguien entrara en este momento, le diríamos, oiga, las cosas que hemos hablado hasta ahora, primero es que es una carga importantísima. Se nos mueren los niños y más en nuestros países, ¿cierto? Segundo, no hay con qué tratarlos. Sí, les ponemos antibiótico, pero hay muchas cosas detrás. Entonces, la prevención es la solución. Tercero, ¿hay nuevas alternativas? Sí. Y cuarto, esos nenes no solamente se enfermaron en la unidad, sino que siguieron con consecuencias a largo plazo. Muy bien, esta diapositiva sí me fascina. ¿Por qué? Porque es que se nos olvida cosas tan sencillas como la lactancia materna. Y aquí, casi que de mi lado, es ridículo hablar a personas que son expertas en lactancia materna y que les he aprendido tanto. Pero miren la lactancia materna. La lactancia materna reduce un 41% el riesgo de bronquiolitis. Pecado no darle leche materna a esos bebés. ¿Qué nos está pasando? También reduce enterocolitis, reduce muchas cosas, pero respecto a esto, mire lo que hace. ¿De acuerdo? Entonces, la primera cosa, por favor, lactancia materna. Y la segunda, yo no sé si todos vieron el estudio en COVID de las mamás que se llevaban se le llevaban a los bebés a alojamiento conjunto y luego se iban a la casa. Cogieron como 200, fue publicado, es un estudio de la Organización Mundial de la Salud, y los niños se fueron a la casa piel a piel y dándole lactancia materna. Adivinen cuántos se infectaron de los 200 y pico. Ninguno. No, casi ninguno, ninguno. A mí me pareció impresionante ese estudio. ¿Por qué? Porque sí sirve el tapabocas y sí sirve lavarme las manos. Y por eso la lactancia materna y explicarle a los papás es tan importante. No, es que la gente no es educada. No eres educado tú que no le enseñaste. ¿De acuerdo? Así que no olviden esas dos primeras terapias, lactancia materna y segundo, lavado de manos y uso de tapabocas.
Y mostrarles datos de la ciencia en resumen rápido para el médico pediatra. Todos tenemos conformaciones proteicas y todos queremos una estructura antigénica que nos dé buena respuesta. La proteína F de fusión siempre ha estado conservada ambos linajes, entonces primer dato nos protege para A y para B. Y segundo, su forma activa donde más impacta es en la parte de prefusión sitio cero. Y esa fue la modificación, una de las dos más importantes para que este anticuerpo monoclonal, 1, aumente eficacia y efectividad. Vamos a ver los datos. Y 2, para que sea de larga duración. Y esto nos simplifica todo el proceso. No creo que requeríamos ser tan específicos más allá. Esto es lo más importante que cambió con palivizumab y que lo hace diferencial frente a otros anticuerpos monoclonales. Y esto, doctor Ovalle, nos da el dato que usted nos había mostrado.
Sí, empezamos a ver entonces, por ejemplo, este estudio en el cual la vida media extendida te hace. Entonces, la segunda pregunta que tendríamos después de todo lo que hablamos es, oiga, venga, y eso que estaban hablando, ¿cuánto cubre? 150 días. 150 días. Incluso en Harmony, que es un estudio que vamos a ver ahorita, revisaron luego y encontraron que hasta 180 días. O sea, podría incluso entrar en la segunda área, en la segunda época invernal. Pero queremos que se queden en mente con algo que es totalmente demostrado de 150 días. Entonces, sí marca la diferencia. Ya explicó Andrés por qué, porque se cambió la tecnología para poderlo hacer. Una sola dosis, es decir, en lugar de 5, que pues ayuda muchísimo para poder proteger a los pacientes.
Y mostrarles esto rápidamente igual, lo rápido para los pediatras, tenemos que poder ser técnicos también en dar respuesta a qué estudios, esto es lo famoso pivotal, y lo lindo, pocos estudios en todo lo que sea biológicos, vacunas, demuestran que son superiores en vida real. Casi siempre buscamos que sean igual de eficaces. Y NIRSE mostró que son superiores al desenlace que ya era superior de los estudios pivotales. Entonces acá está Melody y Harmony y básicamente miraron tanto en prematuros como en cuidado estándar 1 a 1, que fue Harmony, que tanto impactó en infección respiratoria baja, medicamento atendida, hospitalización. Y miren que la reducción es de alrededor del 80-84% en general. Y estos dos son más importantes aún porque les dice a ustedes que es seguro en prematuros. Entonces, dar la opción de saber que la farmacocinética y farmacodinámica del medicamento se conserva cuando se hace la dosificación adecuada y algo muy importante, se mantiene. Y quiero devolverme, perdón, Oscar, no les mostré acá lo más importante. Miren, el anticuerpo no depende de la maduración inmunológica. Como es una inmunización pasiva, administro y cargo. Dejo cargado el anticuerpo en el neonato. Entonces no me importa si fue enterocolitis, si tiene displasia, etcétera. Ya le di la dosis de carga que va a durar y prevalecer en el tiempo. Y hace esto, que es muy robusto. Disminuye 83% en los estudios pivotales la hospitalización, reduce el ingreso a UCI un 81% y la IRA por sincitial un 75%. Acá algo muy importante, número necesario a tratar. 50% en general, que esto es un detalle, doctor Oscar, vital, ¿no? IRA de cualquier otra causa. Recuerden, el sincitial inflama y puede permitir que el rinovirus entre. El sincitial inflama y puede permitir que el neumococo entre. Si yo prevengo sincitial, prevengo incluso infección respiratoria aguda baja de cualquier otra etiología diferente, sin estar apuntándole a ningún otro microorganismo. 35 inmunizaciones necesarias para prevenir un caso grave y, por supuesto, esto es de alto impacto. Hablemos un poquito, doctor Oscar, rápido. Chile, ¿qué vimos allá?
Sí, como estamos tratando de hacer cosas puntuales, ¿cierto? Esos datos que dio Andrés, no los olviden, ¿sí? No hay que convencer a nadie. Cuando usted tiene una reducción del 80%, usted dice, esa vaina no es estadístico, eso es que realmente funcionó. Entonces no olviden que Estados Unidos es 90, el estudio de Galicia 89, pero tengan en mente por encima de 80. Esa es la protección que tiene para infección respiratoria baja y para hospitalizaciones de UCI por encima del 70%. Es un número que quisiera como que se llevara para la casa porque hay muchos números. Y en Latinoamérica espectacular porque aparece el estudio chileno. ¿Por qué es tan importante el estudio chileno? Porque son como nosotros, ¿cierto? Seguramente tienen más dinero, pero son parecidos a nosotros. Entonces en Chile lo que hicieron fue colocar y el pico era impresionante en Chile y prácticamente no apareció el pico en Chile. La protección en Chile fue muy alta, miren la cobertura, eso es en catch-up, lo que decía Andrés. O sea, lo hicieron al nacimiento, pero también lo hicieron en cobertura fuera de la temporada. Y miren la hospitalización que se logró, la admisión en UCI 84%, y por cualquier causa, que es otro punto que si quisiéramos que se llevaran para la casa, no solamente reduce el virus y la bronquitis por sincitial respiratoria, sino que reduce en general el ingreso de los pacientes por infección respiratoria. De pronto Andrés nos puede hacer un comentario como infectólogo, ¿por qué, cierto, siendo un anticuerpo monoclonal específico contra el virus sincitial respiratorio, puede prevenir otras causas?
Digamos que ya lo dijimos, no entra el virus, no inflama y no permite que el neumococo ingrese, estafilo ingrese, ni otros virus puedan ingresar. Y lo que hemos dicho siempre en protección con todo lo que sean biológicos o vacunas, puede estar, pero lo importante es administrarlo. Mire el dato chileno tan impactante, la cobertura fue 98%. Por eso fue que el dato sí sirvió. Y no me detengo en Paraguay porque ya lo vieron, pero quiero contarles que Paraguay logró catch up, que es algo muy importante. Y es una población que no podemos dejar por fuera. Y quienes son colombianos, este es el dato, este es el territorio nuestro. Miren que el doctor Oscar dijo, nos parecemos como latinoamericanos, pero no en Producto Interno Bruto y no en dimensión de mortalidad. ¿Se acuerdan el número que les dijo el doctor Oscar que no olvidaran? 361 muertos por IRA para el 2024, con todo el subdiagnóstico. Es decir, tenemos entre 4.5 a 3 veces el riesgo que tienen los chilenos pues, de lograr una implementación adecuada. Doctor Oscar, estos datos de España creo que ya los conocen, pero es mostrarles el aplanamiento de curvas.
Sí, esto es Galicia y fue uno de los primeros que empezaron a aplicar esto en España. Y si ustedes se fijan, esto que ven aquí en cuadritos es como quedó. Y el virus sincitial tenía la misma presencia, solamente que miren la reducción. O sea que igual que en Chile, ¿cierto? Igual que en los otros países, miren cómo se disminuyó. O sea, el pico prácticamente se acaba. ¿Qué es importantísimo de lo que contaba Andrés? Claro, es muy importante, uno coge los estudios 2B, 3, y usted lo que hace es que es muy riguroso con los grupos, que lo tiene todo controlado. Pero ahora estos estudios que son en vida real es lo que te pasa a ti, lo que te pasa a ti, lo que me pasa a mí, que son pacientes que tú tienes allí con diferentes cosas y por eso se llaman estudios en vida real. Son más reales a lo que nosotros vimos en el día a día. Este estudio de Galicia, el estudio de Chile, esto han mostrado eso, que los estudios tienen una reducción, como ustedes lo ven ahí, 89%.
Superior incluso al pivotal.
Incluso superior, exactamente. Muy bien. Y esto en Chile, miren lo que dijo Andrés, para inmunizar 36 y 35. Más consistente, imposible. O sea, realmente sí redujo. Miren el piquito de abajo, negrito, cómo se redujo el pico, eso en atención primaria incluso.
Día de estancia en cama hospitalaria. ¿Cómo lo ves? ¿Cómo lo interpretas?
Mira la reducción que ustedes ven ahí en el pico azul de cómo se redujeron las necesidades de las camas de UCI. Y si lo pasas a siguiente, bueno, el anterior a ese eran también en consulta ambulatoria, ¿de acuerdo? Así que disminuía tanto en hospitalizaciones como en pacientes ambulatorios, UCI y ambulatorios. Esto no los vamos a aburrir, creo que la información es demasiado consistente. Esto es Sudán y miren, estos son todos los metaanálisis y solamente que sí quiero que se queden con esos dos números. Reducción en hospitalización, más del 80%, reducción en UCI del 75%. La verdad, sí es impactante la reducción. Y nuevamente el número a tratar, el mismo. Así que, en pocas palabras, ¿qué llevamos hasta ahora? Que Harmony, Melody, Galicia, Chile, Paraguay, países como nosotros, ¿cierto?, tiene un impacto del 80% en hospitalización y un 70% en hospitalización UCI. Suena impresionante, pero pues es real porque se está mostrando.
Y vamos a cerrar el gap del asunto, Doc, para mostrarles lecciones para Colombia y LATAM, que hizo que Chile y Paraguay avanzaran. Decisión política temprana. Y todos somos actores políticos. Todos insistimos desde cada una de nuestras sociedades. Y explícita, se necesita. Es que es una necesidad. No es solamente una petición adicional. Que funcione la vigilancia centinela. Ya se motivaron en sus centros a molecular, se postularon, lo estamos haciendo. Que se apalanquen de lo que ya existe. Hagamos fast track con lo que ya conocemos para que pueda ingresar y luego expandir. Y que haya, por supuesto, acuerdos de compras. Colombia particularmente no me detendré, sé que estamos en LATAM, pues tiene unos retos adicionales y por eso tenemos, doctor Oscar, una estrategia híbrida. Pero recordarles que esta es una población de catch-up que no podemos dejar de cubrir con el anticuerpo monoclonal. En todos nuestros países hay que identificarlo. A mí me cuesta, doctor Oscar, contarle a los papás de mis pacientes cuando les diagnostican cardiopatía y tienen 12, 14 meses y llegan a cirugía, cogerlos en la UCI neonatal y preguntarles, ¿no le han puesto el anticuerpo monoclonal? En este momento tengo palivizumab en mi territorio, que es Cúcuta, pero me llama la atención, ¿no? 13 meses con la cardiopatía, con todo el criterio. Hay que hacer el trabajo.
Andrés, en Paraguay lo hicieron en ese tipo de pacientes hasta los 2 años, ¿no?
Total, hasta los 2 años. Y En general no tenemos que reinventar y les quiero mostrar un poquito, doctor Oscar, hablemosles de qué hacemos en Colombia en este momento.
Bueno, no me lo perdonan mis compañeros neonatólogos de acá, ¿cierto? Si no repetimos lo que ya Andrés había dicho, que en el estudio Medley, cuando se comparó, no hay una cosa comparando palivizumab directamente con el nirsevimab, pero cuando se revisaron, era totalmente seguro para prematuros, 29 a 34 semanas. Y hay un estudio, no sé si lo recuerdas, el rumano de hace poquito, que es de André Tadura, ¿cierto? Lo pueden mirar. Lo que hicieron los rumanos fue revisar 41 estudios. Y en prematuros, si no, no me lo perdonan, en prematuros fue totalmente seguro y efectivo en los prematuros. Entonces, fíjense que ya llevamos cómo funciona, nos lo explicó Andrés, súper fácil. Segundo, el impacto es impresionante, 80% en hospitalización y 70% en UCI pediátrica. ¿Cuánto dura? Ya sabemos que 150 o hasta 180 días. En prematuro funciona, es seguro y es efectivo. Esto, ¿qué es esto? La vacuna para la mamá, una maravilla. La vacuna para la mamá, miren la prevención que tiene, espectacular, se la ponemos a la mamá. En Paraguay decían, oiga, pero es que no teníamos para poder hacer eso, listo. Si tú tienes un buen sistema de salud que puedas hacer la cosa a la materna, se puede hacer una terapia, que es lo que está haciendo Bogotá. Pero quiero solamente dejarles un detalle en mente. Devuélvelo un momentico, Andrés, discúlpame. Si ustedes se fijan, 81%, igual que el nirsevimab en 90 días. Pero cuando te vas a 180 días, cae ya la de la protección materna. O sea, sí previene a los bebés hasta los 90 días, pero no se mantiene como nirsevimab hasta los 180 días. Y la otra cosa importante, muy importante, es que los primeros estudios mostraron que podía aumentar la prematurez. No, los otros estudios mostraron que ya no aumenta la prematurez.
Perfecto. Y eso es resumir lo que tú dices, 2 tiempos, es cierto, los anticuerpos caen, pero sigue siendo una opción como países como el nuestro, y ya los estudios más adelante dirán costo-efectividad de acuerdo a cada sistema de salud. Pero Colombia maneja este flujograma. Si quieres, doctor Oscar, nos lo explicas rápido.
Creo que mis compañeros en Bogotá, todos, no, reunión mañana, no, reunión pasada mañana hasta que no lo aprendimos. Es fácil. Si tú tienes una gestante, mira si está entre 28 y 36 semanas, y si la señora está entre 28 y 36 semanas, le pones la vacuna a la mamá, la vacuna PREF, que es muy efectiva, ¿de acuerdo? Si ese bebé nace de 36 semanas, pero recibió la vacuna hace más de 2 semanas, que es la regla de los 14 días, usted no tiene que colocarle el nirsevimab, ¿cierto? Porque le está protegiendo el bebé ya con la vacuna PREF. Eso es lo que parecía la estrategia que hacen en Estados Unidos. Si usted tiene un bebé de 33 a 35 semanas o menor de 3 semanas, inicialmente en Bogotá se dijo, vamos a colocarle, si tiene muchos factores de riesgo, palivizumab, ¿cierto? Y si no, nirsevimab. Pero ahora, después recibimos un reporte y nos dijeron, ¿sabe qué? Vamos a colocar nirsevimab porque en prematuro funciona, es una sola dosis y necesitamos optimizar los costos. Ya no son 5, sino 1. O sea que si se los puedo repetir es, 1, mamá entre 28 y 36 semanas le colocamos. Si pasó más de 2 semanas que nazca el bebé, no le colocamos nirsevimab. Si pasó menos de 2 semanas, le colocamos nirsevimab. Eso es lo que se está haciendo en Bogotá.
Excepto que sea prematurito.
Excepto que si sea prematuro, que ahí ese prematuro, no importa si le recibió, tenemos que colocarle una de las dos. En este caso, en Bogotá por lo menos se está tomando la decisión de usar más nirsevimab, por lo que hablamos de que protege al niño desde el inicio.
De acuerdo, o sea, vacuna para todos en Colombia, pero si cae en la categoría prematuro menor de 35 semanas, seguimos indicándole anticuerpo monoclonal, en este caso, como menciona el doctor Oscar, NIRSE a los pacientes. Me voy a pasar a la regla del 14, doc, si quieres, para resumir un poquito. ¿Qué es esta? Si no bueno, ya la explicaste, ¿no? Básicamente la que tenemos. Si logra los 14 días y es a término, no administramos. Si no logra los 14 días, siempre se administra, o si hay criterios de prematuridad por debajo de las 35 semanas, siempre se administra. ¿Cómo vamos? Y estos son los hitos. Lo que les menciona el doctor Oscar último es marzo del 2026. Ya NIRSE para todos. O sea, NIRSE entró a desplazar el nicho que tenía palivizumab de niños descubiertos con factores de riesgo o no beneficiados por vacunación materna. Y esto es cobertura. Y quiero detenerme acá. Que la cobertura materna está subestimada, mal estimada y depende del indicador que usted mire. Si usted se va con pertussis o tosferina ahorita que estamos en brote, pues, tenemos 80% de cobertura. Si se va a mirar COVID, 10%. 10%. Y si lo hace global, un 63% para todas las que deben recibir las maternas. Entonces, miren, a pesar de que Bogotá ha sido tan insistente en lograr la vacunación del 100% de las gestantes, hay un gap de casi el 25% o más. Y si a eso le sumo mujeres vacunadas que sí están acá en este 77%, pero que no logran un parto a término, pues vamos a tener una mayor diferencia. O sea, el anticuerpo monoclonal se necesita, es una necesidad. ¿Cuántas dosis han administrado en NIRSE desde que Bogotá inició? 2.364 dosis. Recuerden, para una protección duradera de 5 meses o más, incluso en estos pacientes. Así que queremos con el doctor Oscar terminar con esta frase. Prevenir el sincitial hoy no es solo evitar bronquiolitis, es realmente evitar una trayectoria de vulnerabilidad para toda una generación, incluso a lo largo de la vida. Entonces, siempre pensar en prevención, en integración y en sostener realmente el cuidado de los neonatos.
Un comentario.
Perdón.
Perdón. No, un comentario pequeñito es, yo le digo a los residentes, hey, tú creciste tu práctica médica con una terapia diferente. Tenemos que aprenderlo. Pero en general lo que Andrés nos enseñó hoy creo que es súper claro, súper concreto, es efectivo, es seguro y tenemos una alternativa adicional para salvar vidas. Gracias, Andrés.
Doctor Oscar, gracias y gracias a todos ustedes. Si tienen dudas o preguntas, por favor.
Voy a pasarles para que puedan y con Andrés contestamos desde allá. Ay, gracias.
Gracias por tan excelente presentación. Solo quería saber, y entonces me queda la duda de los menores de 33 semanas. ¿Cuál es la indicación?
Doctora, en este momento la mamá debe recibir la vacuna, se está tratando, no está en la gráfica porque eso sería solo para vacuna materna, pero Bogotá está intentando que desde las 26 semanas la mayoría de las maternas ya empiecen a recibir biológico. En teoría, a las 33 semanas esa materna debió estar vacunada, pero aunque esté vacunada, ese niño cae para anticuerpo monoclonal. Si está en Bogotá, ya es NIRSE para todos. Si está fuera de Bogotá, sigue siendo palivizumab, que sigue siendo la tarea que tenemos que tener. Cuando nos llegue NIRSE, pues NIRSE, pero mientras tanto no dejarlos fuera de palivizumab.
Una pregunta. ¿Se está evaluando algo de uso intraunidad neonatal?
La idea es que esto se administre, doctora, ojalá integrado para facilidad como modelo PAI al nacimiento, incluso en paciente estable en las unidades. Daría un beneficio adicional. Por el momento solo está, digamos, intramural, pero fuera de la UCI, pero sí es una de las propuestas con las que se intenta avanzar, que quede protegido desde el momento del nacimiento. No sé, en su unidad, doctor, ¿lo está haciendo?
Martica, muy buena pregunta. Y básicamente lo que decíamos, si yo tengo un prematurito que la mamá lo recibió, si cuando nace el niño se lo coloco, de alguna forma yo ya estoy previniendo el brote en mi unidad, ¿vale? Pero hay que ser justo y Andrés y yo tratamos de revisar la literatura juntos y ser muy, muy juiciosos en lo que les podemos expresar. Y es que hay varios de los metaanálisis, el del IEN, varios que no encontraron diferencia en la ventilación mecánica o en cosas severas cuando tú le colocas a un paciente, por ejemplo, que esté en la unidad. No se encontraron. Puede ser que en el futuro se encuentre, algunos estudios han dicho que sí, pero en general los metaanálisis dicen que no hay diferencia. O sea, el mensaje es de puertas para afuera, cuando tú previenes todo eso, reduces, pero ya cuando el niño ingresa, ya tiene el virus sincitial y ya tiene toda la cosa, seguramente el desenlace va a ser muy parecido. ¿Está de acuerdo con eso?
Sí, se puede, y para su pregunta, doctor Africano, se puede y sería el ideal desde el nacimiento, poderlo administrar en paciente estable a los neonatos que cumplan el criterio, porque si nace beneficiado, es decir, a término, etcétera, vacunado más de 14 días, la regla de los 14, ese niño no entraría. Serían los mismos como reemplazando indicaciones de PALI, pero en este momento tienen que asistir es al centro donde se administra. No está en administración en UCI, al menos hasta donde yo sé, sino en los puntos que Bogotá tiene destinados.
Nosotros estamos colocándole a todos los bebés cuando nacen, a todos, e incluidos los que están en la unidad. Es decir, el bebé que nació y se fue para la unidad, esos niños son vacunados en las siguientes 48 horas, a todos en Bogotá. El peso, lo que decía Andrés, si lleva más de 14 días, que es la regla de los 14 días, y es un niño a término, no lo colocas. Si es menos de 14 días, lo colocas. Y segundo, si es un prematuro, colocamos nirsevimab. O sea, a mí me entra un prematurito a la unidad, ¿sí o no, Lili? Un prematurito, y ese niño le colocamos de una vez en la UCI desde el inicio. Estamos evitando brote y estamos evitando que el niño después haga, igual que antes el palivizumab, infección por virus sincitial respiratorio. Con la misma bueno, en teoría con el IMPA, que era más o menos 55% de protección, acuérdense que nirsevimab es el 80%. O sea, yo sí quedo tranquilo que mis prematuros se les haya colocado nirsevimab, Martica, los puedes colocar desde que ya nacen los bebés sin ningún problema.
Ya, no sabía de las unidades, doctora Martica, y mire, ya le están poniendo, entonces sí. Pero en principio no tiene ningún problema. Es más logístico que eventualmente todas las unidades de Bogotá seguramente no sea como Cobos. Cobos tiene punto de vacunación PAI allá intramural, pues. Entonces yo creo que eso lo facilita, pero sería el ideal para todos.
Felipe, una pregunta.
Lili, me corriges, pero si tuvimos una reunión con la Secretaría de Salud de Bogotá y nos cogieron unidad por unidad. Hey, ¿tú de quién eres? Unidad A. ¿Por qué no se colocó? No, es que pasó que... eso se está cambiando, es muy importante aumentar la cobertura y lo que se hizo es que tiene que ser, ese paciente tiene que salirse antes del egreso, tiene que ser vacunado. Ese niño, el que está en alojamiento, el que está en la unidad también, no hay excusa. O sea, nosotros sí nos están vigilando para que el nirsevimab sea colocado antes de que los niños egresan, sin ningún lugar a dudas. ¿Por qué? Porque cuando se van a casa se pierde de una vez la adherencia.
Felipe, es la ventaja de la implementación y lo que hace sencillo este biológico. Todas las unidades en Bogotá, doctor, entonces entiendo, están como usted en este momento, incluso si se admiten hospitalaria.
Claudia Devia nos llamó, hizo una reunión que es la asesora de neonatología de la Secretaría y unidad por unidad, en público. Hey, ¿qué pasó con este niño? No, mira, es que pensábamos que como eran 36 semanas, el Valar nos daba un poquito, 35, entonces dijimos que no, habían cosas así. Eso se ha ido corrigiendo. En este momento todo el mundo está comprometido en colocarlo y estamos además vigilados, a mí me parece que adecuadamente.
Sí, el doctor Juan Fernando, doctor Niño y la doctora Mafe Tobar han hecho un papel muy, muy bueno.
Una pregunta.
Doctor.
Sí, para mencionar, ¿verdad?, que en Paraguay, Chile y Galicia la circulación es... hay una temporada de circulación. Entonces tenemos una estrategia similar de administración del nirsevimab. Quería preguntarles a ustedes que tienen una circulación en todo el año, no hay una temporada definida, si han analizado con qué estrategia aplicarla en el caso que Colombia decida utilizar al nirsevimab como estrategia única.
Doctora, lo que se ha planteado desde las sociedades y el último que fue el consenso de infectología, neumología, participaron neonatólogos que está pronto a participar en publicación para SLIPE, es todo el año la circulación. Tal vez uno pudiera coger a Bogotá y compararlo con Paraguay y Chile. Él sí tiene una estacionalidad muy clara. Y Bogotá, de hecho, ha liderado su proceso apoyado por ministerio, pero de manera individual por la carga que le costaba. O sea, el pico respiratorio de Bogotá salen todas las noticias de nuestro país. Entonces, probablemente ellos puedan hacer, y esto ya es off-label, fuera la indicación, como una visión muy particular de infectólogo, hacer algo más individual en 2 tiempos o 2 temporadas. Pero el resto de nuestro país sí requeriría una estrategia anualizada.
Algo que yo quería agregar es que en los programas de seguimiento, en este caso en los programas de seguimiento en Colombia, que son los programas Canguro, que muchas veces somos como el control de calidad de lo bien que estamos haciendo en las unidades neonatales, nos hemos dado cuenta que ya están llegando todos. O sea, el grupo etario que está ahí, están llegando todos. Es muy raro y llamamos a las unidades si lo colocaron o no lo colocaron, porque cuando nosotros vemos la historia, muchas veces no está en la historia, pero sí se está colocando en el carnet de vacunación.
Super doc, qué buena noticia. Hoy hablé con Mafe Tobar, que está en la subsecretaría, y me dijo que se sentían muy plenos con coberturas. La vacunación que les mostré en 73 global ya subió esta semana 82%. Y en monoclonales, en NIRSE, pues todos los que son beneficiados los están poniendo.
Buenas, de Panamá. Nosotros ya tenemos la vacuna autorizada y como una política estatal, universal para todas las embarazadas. Pero en nuestra unidad muchas veces son pacientes son referidos y vienen diferentes controles prenatales en diferentes instituciones. No tenemos garantía de si se puso o no en la embarazada. Su recomendación sería que a todo el que nos nace prematuro le pongamos inmediatamente la vacuna. Porque no, en realidad no hay certeza y la cobertura ya inició universal, está pagada por el Estado, pero no todas reciben el beneficio.
Mi doc, se lo diré en dos tiempos. Independientemente que pudiera verificarlo, ya solo ser prematuro significa que yo no le puedo dar garantía de paso a anticuerpos vacunales, las mismas de la término, o sea, menor de 35 semanas, sigue siendo candidato a anticuerpo monoclonal. Así no lo puede, así lo tenga verificado la administración de la vacuna. O sea, yo vacuno a la materna desde muy temprano, en semana 26, para producción de anticuerpos y esperando que llegue al término. Protege, claro, hay cierto paso de anticuerpos, sí, es cierto, pero no la misma cantidad. Por eso en el flujo de decisión menor de 35 semanas, así esté vacunado con vacuna abrisbo para maternas, cae dentro del beneficio de anticuerpo monoclonal. Digamos que sería como la deuda en la que Panamá se tiene que poner. Vacuna es excelente opción. Tiene datos de costo-efectividad para ciertos PIB o Productos Internos Brutos no tan buenos como Chile o Paraguay. Sin embargo, siempre queda sin anticuerpo monoclonal al lado, incompleta para la protección de los recién nacidos. Tampoco pasa nada. Y ante la duda, si no puede, una término, por ejemplo, 37 semanas y le ingresó a su unidad y no pudo verificarlo, también debería, ante la duda. Ahora, Colombia lo registra en el PAI web. Entonces, esto es algo muy bueno porque tenemos un doble sistema de chequeo.
Muchas gracias por su excelente plática. Mi pregunta es si ya tienen considerada alguna política con respecto a la revacunación en pacientes que lleguen a 12 o 24 meses y que tengan factores de alto riesgo, o si hay alguna política o se piensa implementar algún
Se
consejo.
piensa desde el área académica, no hay política estatal todavía y creo que nos quedamos sin tiempo, pero se va pensado, por supuesto, hasta los 2 años, sí, señora.
Creo que la experiencia de Paraguay es súper buena, porque nos abrió la ventana, nos dijo, oiga, venga, por encima del año, ellos lo hicieron debajo del año, y del año a los 2 años dijeron, hey, pongámoslo a los de riesgo. Puede ser de que después decidan hacerlo más. Seguramente nosotros haremos algo escalonado, Andrés sabe más del tema que yo, pero yo pensaría que el sentido común le dice a uno que seguramente se trate de cubrir la otra estación y seguramente la población de alto riesgo. ¿Cierto, Andrés?
Muchísimas gracias a todos.
Muchas gracias por todo. ¿Cuál? Ah, sí, tienes razón. Gracias. Muchas gracias. Con gusto.
prematuridad. La licenciada Jovita Plasencia, la licenciada Alexandra Jiménez Luna y el doctor Richard Vaquero. Coordinan la mesa la doctora Paola, nefróloga pediatra de la Universidad de Antioquia, magíster en epidemiología de la Universidad CES, Medellín, Colombia, nefróloga pediátrica de la Clínica Universitaria Bolivariana y docente de la Universidad Pontificia Bolivariana, Medellín, Colombia. Miembro de la Asociación Colombiana de Nefrología Pediátrica, Asociación Latinoamericana de Nefrología Pediátrica y Asociación Internacional de Nefrología Pediátrica IPNA y ASEPNEO. El doctor Richard Vaquero, pediatra nefrólogo, Universidad de Antioquia, Medellín, Colombia, pediatra nefrólogo de San Vicente Fundación Hospital Universitario, profesor asociado de la Facultad de Medicina de la Universidad de Antioquia, y expresidente y miembro activo de la Asociación Colombiana de Nefrología. Además, miembro de asociaciones internacionales de nefrología y Sociedad Colombiana de Pediatría y ASEPNEO. Bienvenidos.
Muy buenas tardes. Para nosotros es un gran honor.
Good morning and afternoon. It's an honor to
Estamos hoy acompañados por un grupo
We're here accompanied by a select group of professionals that we are going to see as we move on. The idea is to transform today's follow-up to be able to achieve a better outcome, and this is what we want with today's talk, to be able to have an impact on the renal health of our kids in the long term. When we are talking about high-risk babies and renal issues, we always think about acute events, hydrolytic disorders, acid-basic, but many times we forget that this kid may have an acute and chronic disease in the long term. And this is also, we are going to start with the first question. And why is it important to do the renal follow-up of high risks? And that's why I have the honor to introduce Dr. Ricardo Guerrero. He is a pediatrician of the Children's Hospital of Mexico, Federico Gomez, and he also works in the National Prenatal Issues Isidro Espinosa de los Reyes, and he's a professor in neonatal and also in neonatology with IMPERS. Go ahead, doctor. Okay. Okay, first of all, good morning, good afternoon, everybody. I love this topic. I love this topic because it sets something that today we hadn't included in a much more comprehensive manner. And we can see that the real problems of these babies that are born before their time, and especially of these that were exposed to many perinatal events that regularly are maybe the pivot, so that there is a sequela. I can see that we have also included in other organs, and especially the lung and the brain. And we were not able to see that these kids were going to, with times, they were going to develop an adaptation mechanism inside the kidney, where when they tried to compensate the loss and the lack of an adequate development at the neurogenesis, the development, they ended up with a huge issue, which is that these nephrons were overexposed and to pro-inflammatory potentials, and also hyperfiltration, and above all to a renal burden, and that much higher than what we normally than they could tolerate. And that's why this is what made us discover that these patients had an intrinsic renal damage, that wouldn't increase the creatinine level, that wouldn't increase the arterial pressure. And but slowly and slowly, from the incubator, they it would be working in creating harmful to be able to keep, and that's why at the end of the day we can see that these mothers that have preeclampsia, gestational diabetes, and that also have a very harmful events, they started to include the moment of birth with a very nocive, harmful proxy environment, and also for some inflammatory elements during the perinatal. And then once they were discharged from the intensive area, they were leaving us. They were leaving us a sense of peace for having kept this baby stable. And we lost a very important window that happens during adolescence, when we can mitigate the damage and the process that has already been initiated. And that's why I think that this group, and it's focused in being able to include in this stage more than another stage, and because that's when these things about biochemical alterations start to show up, like hypertension, proteinuria, and also the decrease in the glomerular rate. At the end of the day, they have said to not, at the end of the day, we wouldn't be able to offer preventive medicine. If we are highly analytic, we are going to find that within the big group, that I can say that it's the baby that it's in the incubator, we are going to be able to find that there are different noxes that at the end of the day are going to see like a synergy and to cause an impact in the future renal life. And maybe it's not relevant to understand that extreme prematurity, the acute kidney lesion, and the excess of nephrotoxics, and a very aggressive feeding, and also inflammation of any kind. Maybe they are the main noxes that we need to take into account when we interrupt the process and also damage it. We create an environment where that kidney needs to compensate the losses, overcome it, and to keep a body that it's in a complete development process in a very active manner. And this is where we have the opportunity to be able to change the future of these patients. And this is why, at the end of the day, first of all, we need to understand that it's not just to be born in a premature manner, but how many factors and to be able to create models, and therefore to understand that already have survivors, because at the end of the day, these models are based in being able to detect whoever has a high risk and whoever has a low risk. Let's go on. And the most important way, in the most correct way, and if we take into account, if we work with a hypothesis that's been more than 40 years on, we can see that the first impact of this theory, it's the incomplete development, that it's regularly accompanied by a second impact, which is where the neonatologists have tried to impact in a very positive manner using the baby ninja and adequate dosages, trying to minimize trying to mitigate the problem that we had with the low tisular perfusions, to be able to improve the quality of the process, as one, for example, the cord, and maybe being able to work with the excessive protein fortifiers. But what we need to have an impact is in the years to come. But this is when this kidney has bears the burden of all this. And what this shows you is a very straightforward, where the idea is to avoid that this second or third five injury, it disseminates. That's why thinking about this, and also thinking about the relevance that the impact it has of these factors, the long-term impact of these factors, there is a question, and how are we going to classify these patients to be able to have a vigilance or a monitoring that it's according to the risk. And that's why Richard McKay is going to talk to us a little bit about how do we classify this renal risk.
Por favor, nos muestran el video del doctor Richard, que desafortunadamente no puede estar hoy con nosotros. Nos ayudan con el sonido.
There are some technical audio issues. One of the most important messages is to show the risk stratification, and this is, I wanted to congratulate everybody that are here in Medellín, and also all the people that are connected, and that are connected to be able to deliver the messages all over the place. And so that you can see you, and also to thank the organizing committee in this excellent group with this group, and to be able to transmit all these messages for you. And we can see that all the neonates develop a kidney sequela. That's why the main thing has to do the modern follow-up of risk stratification. And we can see that this classification tries to identify the patients that have a higher probability of having a persistent kidney lesion, or also they can progress to a chronic kidney lesions. If in these ways we can find in this first group of the ones, we can find risk patients that are premature between week 28 and week 34. And the patients in week 34 that have had an acute kidney stage 1, some that have a critical cardiopathy or some malformation of the urinary pathways and the urinary tract, but there's no kidney involvement. There's no impact through renal markers of creatinine. These patients are going to require periodic clinical monitoring, but the difference is that they are going to have an intermediate or low risk. In contrast, we can see that the red group that allows us to think in the red traffic sign, it's a group that focus on patients that have high risk of vulnerability. Here we can have 1,500 grams of patients that can have an acute kidney lesion stage 2, or that they can have the need of a kidney replacement therapy, or that have had acute kidney lesions during their stay, and then acute those patients that with cardiopathy need to have surgical management, and that they could have during this time have an acute kidney lesion or the need of ECMO therapies under 34 or weight less than 1,500 grams, that makes them vulnerable. And we cannot forget about the patients that have that that have a pharmacological closure of the ductus with medications as NSAIDs or encephalopathies. We can see that this is something that we talked about yesterday with a wonderful groups of colleagues, and we showed the importance of the follow-up of these patients with kidney involvement, because sometimes we can say that acute kidney lesion it's unseen during neurological stabilization, and this classification allows to assess and into the follow-up and defining the frequencies of the controls and prioritizing the needs of kidney monitoring of these patients. As you can see, the physical risk of these patients, it's not uniform. It all depends of the comorbidities each of them has. That's why to identify them at an early stage is going to change the prognosis of these patients. And now let's go to the practice, and now we're going to see what we learned on the prior, and that's why we have brought this clinical case that shows what's the kidney follow-up. We have two patients that share the same perinatal environment, but the evolution has different. The evolution has different risk. Possibilities. One has a monochronic severe preeclampsia and prematurity. However, the kidney and systemic behavior is different in each of the cases. Here we have Amelia, that it's on the left, has a relatively stable evolution without significant respiratory involvement, and the only thing that she had was a dilation of the urinary tract. And according with that, with a very significant functional impact, although this patient has relevant prenatal impacts as the ones that we've mentioned, because she didn't develop a multi-organic dysfunction, it's considered a risk patient with the need of a structured follow-up with a lower intensity compared to Sebastian. That it's a patient that has a very vulnerability, renal vulnerability factors, prematurity, severe growth restrictions, and then also the septic shock, but also sepsis, and therefore we can say that they had another therapy, and also because of those involvement, he went upon discharge. He has cardiovascular follow-up and nephrological protection, which confirms the risk and classifies them as a high-risk patient. This example shows us that the neonatal kidney risk, it's a cumulative. It evolves, and despite the fact that there's shared environment, it can be different in each of the patients.
So where there's a real risk based on this information I have just shared. Thank you very much for the committee for the invitation. And again, for the work that we've done through these months. Thank you very much. So, okay. One slide before, please. Okay, continuing with the idea. We have the theory of the two steps that can be several. Sometimes we take them like an increase in risk, but this case specifically, we have twins that come from same situation. Preeclampsia and preterm birth. Both are characterized by the endothelial damage, nephrogenesis damage, an alteration, and under different circumstances, also a damage in growth or affection in growth. One of the babies was bigger than the other. And this gives us clinical scenarios that are very different. That's why Amelia and Sebastián had different outcomes. The first is a preterm that's continuing to grow, that we maintain stable throughout the time it was in the ICUN. And at the end of the day, in ICU, and at the end of the day, the success, prenatal success, was due to the fact that was able to be discharged without any additional care. But now that we talk about Sebastián, here we have a baby that, apart of being submitted into the interuterine growth, some disorders in hemodynamics that required maybe with nephrotoxins, complicated with sepsis, and that required parenteral nutrition for a longer period of time. That required also methods of ventilation that were much more aggressive. And furthermore, the most important event is the acute kidney lesion injury. So here we have a baby that is prone, that in its category of risk, its own category, will develop progressive kidney damage, because both of them are going to continue a similar pathway in development and growth. They will be limited by the capacity of the kidney that had several situations and now has to adapt in a very fast manner. So it's going to have a context of a progressive damage. With that, the first part, to identify high-risk baby and very high-risk baby, are the most important things to consider in order to arrive to the lesson that we really need to undertake. What to do in the follow-up to be able to detect that on time and to prevent that damage really to continue. This is why, next slide please. I would like to ask you this question. What is the role of nursing in the renal care in these patients in NICU? And for that, I would like to invite Professor Juita Plasencia. She is a specialist nurse in pediatrics and neonatology, professor and also manager of different hospitals, part of the scientific committee of ASEPNEO. And she's also a part of ICIPA. And also licensed Alexandra Jimenez Luna. She is also a nurse from the National University and also studied in La Sabana Magister in nursing, also in perinatal nursing and breastfeeding as an experience in the NICU for more than 15 years. She works in reference center and member of the Kangaroo Mother Care Program. Welcome. Thank you very much, Dr. Ricardo, for the presentation. Okay, I think we are going to talk about the chronology or the timeline of the renal development. And our main problem is, okay, we're talking about basically of a preterm baby. And unfortunately, being a preterm baby, well, doesn't have an intrauterine development. Okay, so definitely speaking, all the preterm babies don't have a good development, and nor the systems work properly due to the preterm situation. This is what leads to this problem related to the kidneys, because these are not the exception. So they're not going to work in an adequate manner. So it requires that us, as a healthcare team, in all the specialties, we need to give these types of babies, being preterm babies, we must give them a similar environment as the uterus, because in this phase, all the babies should be inside the mother's womb. So this is our job. In the NICU, we need to take very specific actions. Regarding nursing, we have tried to specify all these aspects that we're going to describe each of them. So I would like to invite Alexandra. Thank you very much. Good afternoon. Thank you very much for those who are connected and here present. It's important to understand that we decided to classify nursing care in 5 dimensions. I will start with the first one that I really love, and we've talked about that. That has to do with implementation of kangaroo mother care. And many of you may ask yourselves, okay, but why renal care? Why to take care of the kidney through the implementation of the kangaroo mother care? Because we have several reasons. And the first one is that the kidney is being affected by hypothermia. We need to avoid hypothermia in our newborn babies, preterm babies. In this case, in Sebastián, hypothermia is going to help to increase the consumption of oxygen, and that's why there is a peripheral vasoconstriction. What's going to happen? The reduction of the renal function. Sebastián, what we need to do an early onset from the group of nursing, and also with together with an interdisciplinary group, we should start with a kangaroo mother care from the delivery room, and to maintain this KMC in the neonatal ward. And very important also to say that has to do with the mother breastfeeding, lactation. We know that breast milk is the best food that our preterm babies must receive. All the babies must receive, and even more when in a state like Sebastián that has kidney injury. What happens with the formulas? The formulas generate higher concentration of solutes, minerals, and burden of protein. So we have an injury in the kidney of Sebastián, and this is what we need to protect. This is why to start with the KMC in an early manner is going to help us as a very important element and key element to maintain that breastfeeding for our babies. This, together with strategies like colostrum therapy that we have experiences in our units in Colombia, in Pasto, Popayán, we have colostrum therapy that's going to favor the nutrition of these babies and going to help the kidney. This, together with mother's milk extraction, we talk about the mother who stays in the delivery room should extract the milk, but also trophical nutrition through mother's milk. This would be one of the most important recommendations that we can approach through nursing for the nutritional support of our babies. What do you think is important as well? Obviously, one of the key points to protect the kidney of these patients is prevention. Unfortunately, these babies are submitted to pharmacological treatments and hemodynamic changes that in certain ways going to affect the kidney, which is an immature kidney. And one of the main actions in nursing care process that we need to be aware of, especially nursing, because it's one of the key functions that we have, is to do an audit of the medications. We know that ibuprofen Diuretics are medications that, normally speaking, are used with types of patients. So, as we know, that they are highly nephrotoxic. Therefore, one of the main specific actions is to maintain a constant monitoring of specific levels of seric markers. Another situation that we need to be aware is in what babies we should give. We never should give two medications that could be very toxic to these patients. But these patients really receive a lot of medications. In some moments, we are not aware, or maybe the doctor doesn't know and will really prescribe two medications that are highly toxic for the baby. So this is where we need to start to question ourselves that the medications will not be simultaneously delivered, because it's going to promote that toxic effect. So we want to protect these types of patients. Hemodynamic changes that these babies are going to have, we know these are very highly toxic, so we need to have a specific control regarding liquid controls. For this, we need always use infusion pumps for transfusion of these medications, also the lipids, and other key aspect that we must consider in this aspect is that this patient is to avoid any constant risks. Alexandra already mentioned about the stress by cold, by warmer temperatures, so control of vital signs, blood pressure, that we are going to talk about next. Among the interventions that we have is liquid management. As Jovita said, it's very important, and I do think that nursing, we have it included in our care plan. Okay, we do liquid controls administered and eliminated. This has to be much more than a phrase that we're going to put in the system that sometimes we tell the nursing team. But this awareness to have that daily weight of the babies, that goes hand in hand with incubators that must be calibrated, adjusted. So to say this is the right weight of the baby, because that's how I'm going to calculate liquids, and also medication doses. Another very important process is to avoid that so overcharge, because that baby has a kidney injury. So it's more important that in the registrations that we have written down, to really write down what we are putting to our babies per hour. Be careful with the infusions, the bolus. Sometimes we do not consider that. And this is a very important factor that's going to make damage to the kidneys of our babies. Also to consider the control of eliminated liquids. Education towards the parents. We are open units. We work with the parents to teach the parents how to weigh the diaper before, how it's education to register all the weight before and after. So we need to weigh all the diapers, because it's part of that that liquid balance. So, and also the paraclinics. What should I consider in these aspects? And okay, I have all the teams, and we need to group all the exams. It's a premature baby, and we must remember that we can include minimum manipulation protocol that must be included, to consider that if we integrate the different specialties that go to the unit, specialist may ask us for something, the other specialist for something, I can do that in just one more time. To that control of the blood test that's going to favor the growth and development, in this case, of Sebastian. Hemodynamic monitoring, this is key. Many moments it's simple because we talk about vital signs control. This is very common. But unfortunately, with these types of patients, in the majority of the cases, we don't use the adequate equipment. Because normally speaking, there are two ways of measuring the blood pressure. So the direct, the invasive one, is the real one that's going to be the standard of care for these types of patients, is through an arterial catheter. And we're going to have real results according to each bead. This is what the preterm babies should have. Of course, with all the pros and cons that this can have in a certain time, a moment of time. It would be ideal to have an arterial catheter, and that way we could control these types of patients. And also, from the moment the baby is born, through the umbilical artery, which is the most common thing that we use. But afterwards, if it's not possible, we need to do it through a peripheral. But the ideal would be to do it this way. Nevertheless, at the beginning, I talked about the fact that it's simple and we can say, okay, blood pressure, we can do that in a way, we can take the blood pressure. But the idea is we don't use sometimes the strap, the adequate strap. Sometimes we use it a larger one or a smaller one. It's going to really give us other results that are not real. So we always need to cover around 50 or 60% of the extension of the arm. In this case, the ideal thing would be to take that in the right arm. Nevertheless, if this is not possible, we need to take the blood pressure in the left arm, but always considering the size of the strap so that the results are more precise. And another point that we need to consider in this sense is that we need to be very careful because it's connected in a direct manner to an electronic device that is going to be insufflating. What's going to happen with this? Remember the liability of these patients. We said at the beginning that no organ is completely has grown completely, and they are very weak, and it's important to consider all these aspects. So, important to consider that with these types of patients is when taking the blood pressure. And the last care has to do with education that we're going to offer the family. The healthcare team takes care of the baby and also the kidney of Sebastian. The family is in charge of continuing this care at home because Sebastian is going to grow. And these factors and these injuries that affected Sebastian from the beginning, it will imply some outcomes when that baby is growing up. That's why it was important to educate the parents from the first day, education and alarm signs, nutrition, breastfeeding. So everything that has to do with preparing that baby for the discharge to be able to continue with that renal care at home. Okay. The next question I would like to ask you is what is the intervention of nephrology in the patient that high kidney risk in the NICU and the follow-up? Okay, let's continue with the medical monitoring. First, with the patients with kidney risk. These were the 28 to 34 weeks, stage 1, congenital cardiopathy, and also the patients with malformation of urinary tract with any affection to the renal function. We're going to do to all the babies that are high-risk babies the following assessment: clinical story about the perinatal story and the risk associated. Blood pressure, creatinine, statins were available. In Colombia, it's available, the cystatina, but it's very costly. So it's still, creatine is the most important one. Urinalysis, milcarbinuria, and this evolution should be done by a nephrologist when the baby is being discharged, but if it's not possible, it would be done by the pediatrician. With this initial evolution, we can see if the patient has a renal injury or not. We say renal disease that may be one of these. Has a creatinine above 0.5 at 36 weeks when discharged, has a blood hypertension, nephrocalcinosis, and congenital malformations. If it has any of these, we'll continue with nephrology. If doesn't have these criteria, we'll continue to be seen by pediatrics. On pediatrics, we're going to see that in four very important moments. 2 years old, when the glomerular function has matured at 6 years, and 12 years in puberty, where the metabolic demands increase and the kidney reserve is going to be under stress, and they appear the first system of the chronic kidney disease, and finally during the teenage years. So this is going to be assessed by pediatrics. They're going to assess growth, blood pressure, creatine, and microalbuminuria. So this is going to be seen 2, 6, 12, and during the teenage years. If we don't find any abnormalities, they're going to be continued assessed, as we have mentioned. If we find pathological findings, we need to confirm those findings, reinforce the preventive measures that nursing has given us, and at the end, we will hear more about this and consider visiting nephrology. We have also the high-risk patients, those preterm patients that are 20-week-olds, that have stage 1, 2 with dialysis, patients with critical cardiopathy that had other comorbidities like hypoxic-ischemic encephalopathy, and also patients that had enterocolitis, patients with urinary tract malformation affecting the renal function. These are patients at high risk that we need to monitor, and it has to go directly through nephrology, has the same initial assessment as those compared to low risk. Clinical history, creatinine, microalbuminuria, and analysis, and ultrasound is simple as that. And these patients that we're going to be visited by nephrologists, it won't be intensive assessment. The same ones, growth, and we're going to do that at 6 months, 12 months, 2 years, and therefore 1 year after teenage years, where there should be a transition to being adult, because this kidney disease or risk will persist throughout life. If we, during the assessment, we can see proteinuria, many malformations, we will continue doing emphasis in the prevented norms. And as nephrologists, we'll start with early interventions like control of the blood pressure, anti-proteinurics, and education to the parents. That nurse is going to speak about that. If the patients don't have any alterations in these exams, we will continue with intensive assessment, because these patients have high risk of developing chronic kidney disease. So the next question is how we are going to do the care done by nursing in the outpatient program. Okay, so it had the need to follow a program where all the interdisciplinary team will be there. This is outpatient. It's important to continue the protective of nutrition, to promote breastfeeding, important education that we can give the parents regarding nutrition, proteins, and restrict the usage of sodium and salt. So to avoid overgrowing in a very fast manner. And also very important is self-medication, education towards the parents, psychology. This is very important because the parents will have maybe okay, somebody told me to give this to the baby and this to the baby, and this is very important to not self-medicate. Remember always the doses during the visit. Remember what are the doses that should be according to the weight of the baby, and to remember and to remind the doctor that these were preterm babies, so that in this emergency care they would be avoided to other agrotoxic medications and contrast medication that also can affect the kidney. What else, Jovita? Next slide, please. Where we also must be very careful is in educating the family when we discharge the baby. The fact that the family is with us in the NICUs, obviously, is very important for this skin-to-skin contact. But in this aspect, in this sense, we need the family to participate in an active way, taking care of the baby. And this is what of the most important functions or roles of nursing. We need to educate from the day one to that family, mother and father, or the caregiver. Why? Because in many cases, in the institutions, what happens is 3 days before the baby is being discharged, we're still trying to educate the family to talk about the care that that baby needs at home. This leads us to maybe, if don't do that, to complications and to go back to hospitalization because the parents are not really prone or prepared to take care of that baby. As simple as, for example, the management of oxygen, administration of the medications. So they go home with medications, and it's important to control that. And afterwards, these medications will be given at home, and many times the parents don't know how to give these medications to the baby. And we've had, unfortunately, a lot of accidents in the families given the ignorance. It's our responsibility. It's our responsibility. We are the ones who didn't know how to educate these parents. So the key aspect is to be able to interact in a specific way with the perfect language so that they can understand us and that these babies go home protected. And also, we propose that to establish a real risk chart because the idea is to give all the options to those parents. So this is what we're doing. It's like, it's very important. I think that's really helped us to have a wonderful result. It's important to clarify that these recommendations are not based on high evidence. It's based on consensus. It's serial consensus. These are the consensus, and we also participated so that you consider it. This is the biography that is very important, bibliography, okay?
Okay, we're going to have some very brief conclusions, and later on, we're going to go to questions. Prematurity and the low weight and acute kidney lesions and urinary tract malformations are not just that's the history. They determine the kidney function long term. This doesn't start in late childhood, it initiates since the prenatal programming. And both neonates to risk towards the high-risk babies require an assessment through pediatric nephrology upon discharge or during the first 3 months, and then to do a follow-up according to the appearance of the kidney disease. In the NICU, we require highly trained professionals. Okay, because of time, therefore, I think this is very important. I think that the professionals that should take care, they should be people that are highly trained. Then when we talk to nursing, we cannot give way that as nurse assistants take care of this case of patients because they don't have the adequate. The ideal is to have neonatal nurses or at least pediatricians that could take care of this type of patients. And I say nursing because we are all nurses, but in general we talk about all the specialty. They have to be very kind. They have to be people that have this kind that take care of this type of people. And that we wanted to promote the empowerment of kids and to to be able to achieve the need for protection of these kids. Okay, we have a couple of minutes for questions. Go ahead. Go ahead, doctor. it called my attention that you included in the flow diagram that creatinine above 0.5. It's an indicative of renal insufficiency of kidney. Yes, yes. Maybe it can be an acute, it can't be acute until after 3 months, we talk about a chronic kidney disease. This is a point when we talk about and even it was done through an expert, and there is just one single, there's only one point that talks about the disease that 0.5, it's the 95 percentile of the kids that are born at 25, 26 weeks, and that creatinine it's at 60 days when they're only 34 weeks. And that's why it's that percentile, it's what we are giving upon discharge. It's a cutting point when we do an assessment. If we have other kinds of alterations, we can see that there's a chronic kidney disease. But I knew that was, but it's just a study, the one. And yes, it's what you say. It's risk. It's a risk because habitual creatinine with a kid with it's going to be 0.2, 0.3, but I think that it's very close to normality just to add 0.5, maybe 0.8. I believe so, but I think that it's very demanding. Yes, that was the HAMA consensus that was multicentric, and it's the last one that we have, as I tell you. And we can say that that the discussion point, it's that there's only one study that it's validating this, and the other one, it's what the experts think. I think this is very important because sometimes when you have a baby that has an acute lesion and they recover their functions, we don't see them in the heart, and they have a stage 2, 3 lesion, and we don't do a follow-up. But that's why once they have recovered the kidney function, and once we have the dyscreatinins, and therefore we can say that having had the story that have an acute kidney insufficiency are high risk and need to be follow-up, and because not with albuminuria, with microalbuminuria, and also with the blood pressure, which is what we're doing. And therefore here you are talking that they had a lesion. And sometimes I say it because a patient, he had a stage 2, they recovered that creatinine, it went down 2.4, and they didn't continue. There's not that recommendation, and this is what happens. Yeah, and therefore this is what, therefore and I can see that here we need to be very correlated with arterial blood pressure. And obviously you are only taking creatinine in 0.5 when, and therefore from 0.1 to 0.5 in a newborn, it's a normal value. That's why they are checking out one single criteria, that it's very isolated. You're not checking out the blood pressure. Yes, I think that what we are trying is to higher patients at risk and that they don't run away. But yes, a single criteria, it's not specific. Go ahead. I want to make a comment doing the follow-up and also from the posture of the follow-up. And I am worried, I'm a little bit worried and of something that it's such straightforward, but this is what we need to teach the parents, so we can say after everything that we've been listening, we know that there's something that is easy when they go home. But I think that, and one of the most challenging is to work with this. But I think that the education for parents, as in well others, and the care that the baby should have at home, and that they should be covered from a much more empathic place. Not to say. This is to say this is simple for me, maybe it's simple for nursing, but for the parents, parents should never be here. Okay, when we always do 5 recommendations, and I'm going to tell you how do we do it on a daily basis. And the first, where we are on the day that promotes breastfeeding. It has less solutes, less phosphorus, and it helps more and during these 2 days. And therefore, we can see that the kidney, it's like a plant. It needs water to grow. The first 3 weeks during breast milk or formula milk, it's okay, but then they need to start with water. And when they're walking 2-3 years, they need to take 2 or 3 glasses of water during the day. They need to avoid salt, and after 2 days, they need to avoid high sodium content nephrotoxics as well, and then that the family does self-medications. And finally, and therefore, we can say, okay, that an overweight baby, it's not a healthy baby. It's these simple things. Yes, I know, Paula. I know that that's your advice when you're empathic care, but I've heard something as the care of oxygen. It's something that I was worried, and as a scientific director of this conference, I don't think that it's the path we should follow. And therefore I have to say it, because I cannot sustain that after everything that we've been saying, we use a sentence of that kind. Thank you. Any other questions? And we can see that there is a kidney risk. We need to prevent it in a timely manner, and that's why we need us working together. Thank you so much. Thank you so much for being here. We can see that communication with families and the NICUs, we have and therefore, and we can see that the specialists in pediatrics, and she is a master and in health science, and thank you so much. But also Dr. Carmen Becchiarelli, that it's going to be online from Argentina, who is the chief of neonatology of Otamendi in Buenos Aires, Argentina, and she works and she has a postgraduate, and she's a pediatrician, and she's a specialist in hospital management and she's a specialist in public health from the University of Buenos Aires. She's also a founding member of ASEPNEO. And the presence of parents in NICU is something very important that are framed within the care and our development. Humanized care is also family-centered. And therefore, to support this kind, we need to have a constant communication with parents. And for this conference, we have Dr. Sergio Bolotek. Thank you so much. Welcome, everybody. And we are going to welcome Dr. Helen Bolobek, and that he has a very, he works in pediatrics, and he's a director of NICU, and he's a director of the fellowship program and Cyrus and from Brooklyn University and in New York. This is an international reference. He is extremely generous because he has participated in all the scientific meetings so that his communication can be delivered. He's a researcher, and he has been a mentor of several generations. But something very important is how Sergi, as I call him, is a wonderful human being, and despite As you can see on the images, I don't know if the presentation is on or not, but we can say that besides the academic part, he also has time and he doesn't forget how to share with his friends in an agreement and in a trip. And especially Sergio, it's a person, that's a friend, and it's someone that somebody wants to have in their life. And also he's going to give us his ample experience in such a straightforward topic that with all what it generates, which is the family and family communication in a critical patient. Welcome, Sergio. Thank you, Carmencita. We studied together. That we were young back then. And her mother had a wonderful peach with creams cake that was out of this world. Are you? Wake up and wake up. Yes. Good. Good morning. Okay, great. And therefore, thank you so much for the invitation. This is my last talk. And therefore, we can say that as a neonatologist that it only takes care of a NICU when they invite you so much to talk about with ethics and family, because this is the way that I do neonatology. But many of the people doesn't understand how most of my talks are about communication, and it's sad. It's sad because. And this we can see this is the perinatal grief, and I use it a lot in this type because part of the communication it's what we need to do, because one can be a brilliant scientist, one can know what this kidney failure means, one can know if the creatinine it's a 0.5 or something, as we can think. And we all agree that we have to do so many things for babies at 22, 26, or 35 weeks. And therefore, we can need to follow these babies and to see what they need. And we can see that goes to the NICU or has a very serious congenital malformation, or it's very sick. And therefore, for us, we in neonatology, either as assistants, and this is a routine, this is what we do. We do all that. But this is the day, but sometimes we can see that day, when that happens, the family changes forever, and those who are in our audience knows by their own experience that it's not easy to have and therefore one newborn, it's the death of a dream, because we all remember when we had a couple and when we had a baby that was about to be born, and one can imagine if we imagine, okay, if we want the baby to be healthy. And I don't know if you saw the picture of Carmen a couple of decades ago. I had hair back in the day, and I started losing my hair. But seriously, it's the death of a dream when a baby goes into the NICU and the baby survives, the baby goes home. And it's a normal baby. How many of these parents, how many of these families are going to have nightmares their whole life because they don't know what's going to happen? And we are going to see the specialist and follow up, and nowadays they tell us that the baby or everybody has autism, or it's deaf. There are the ways to determine the affective and cognitive, and to be able to build associations in uncertainty and in the knowledge, and above all, we need emotional pressure. Maybe that's the most difficult part. And the baby, we can help when people are under a huge pressure. As you can know, we can see decision making. It requires a lot of things. The application between researchers makes everything advance and all of things. It's great for those who do academic medicine. This is a work of many people that has published so much about neonatal ethics and also in basic science. And as Jack Lorenz, that's retired, and they talked about the prenatal consultation and the relevance of communicating the values in the way that it's required and to communicate with the parents, as we said yesterday. Please remember that emotions are an avoidable part, and with positive and negative effects. And we have days in which smile, and we also have days that we are like, and we have. And when I get to know them, it's that I'm sorry that you need to know me under these circumstances, because we don't get to know each other when we are eating ice cream. We are getting to know each other. One of the worst moments to be able to have a boy, a girl that are sick in an intensive care unit, or in a NICU. That's why this is very important to build solid partnerships and everything that they learn. But sometimes we can reveal phenomena that can see. Therefore, what I can tell you today about a 22-weeker, maybe tomorrow they do it different, or at 32 or at 42 weeks, a baby, that it's the most important thing is that all the babies should participate in a very proactive manner. Create a very solid relationships with doctors where the parents feel well taken care of. When we talked about parents, we need to mitigate when parents don't want to listen critical elements, and the parents prefer when they share data, or they prefer figures. And one of the things that I would like to mention with when you talk, it's, hey, what do parents do? Because they want to know that we are the reference, and because imagine they comes with a tie, and but if the doctor it's an engineer or an astronaut, regardless, he's going to require all the figures in the world, because the only thing that he cares is that he has 83.3 possibilities of survival. But if the father it's a gardener or a construction worker, what he wants to know is how to it's how many babies will survive and from them, most of them work well, and that's why we need to adapt. And the people overestimate how much they understand that the perspectives is something that grows, and many times it happens that they talk with the parents, and then they go and at 5 minutes later the doctor says, okay, they want to talk with it, but nobody talked with them. And okay, when I was younger, and therefore I go and I talk with the mother, and I said, okay, do you know who I am? Yes, of course I know who I am, but yes, and why? Because why did the nurse say that nobody ever explained anything? Because if the nurse tells them it within the context of the unit, that's why it's not that serious. But he goes to the cafeteria and then say, okay, they never talk with anybody. Okay, then the truth is that many of the times this is a calling, because we can talk a bit more or I have more questions. But there are many challenges when one communicates with people that are used to the world. Remember, we live in a different world. Our routine, it's the ICU or the follow-up. What it's normal about that? What normal person knows what a neonatologist is? And with my department, and they say, I'm a doctor because I'm with my pajamas. Yes, and what do you do? I'm a neonatologist. I do, okay, great, fantastic, how beautiful. And the language it tends to be twisted. We need to involve other people that are relevant in this process. because the mother, the father, but sometimes the father, the grandfather, the neighbor, that it's the neonatologist or the priest or the rabbi, depending on where they work. It's always very important to take care that the authorship of the doctors doesn't limit the conversations. Why cannot be here, standing here, and the father and the mother over there? One doesn't have to be standing. And do you have a question? No, I mean, we can't just have this superior attitude. We can't. We're all human beings. And yes, of course, yes, I know I have a lot of positions and roles, but when I talk with my parents, I also tell them that I put my trousers one leg of the times. And, but we are people. We are people that we have a training and that, but do we have something that we need to communicate with some, and therefore, therefore, what I do in 22 weeks in the country, and for example, no, what's the border of Colombia with Brazil? Okay. And therefore, we have to take decisions if we want to if we need an ambulance or not, or an endotracheal tube. And we can see in a prenatal visits, we need to always give enough time without judging, because please remember that this belongs to our family. It doesn't belong to us. It doesn't belong to the neonatal nurse. It belongs to the parents. It's the parents' baby. We can say, okay, and sometimes some ones want resuscitation no matter what. Some work disability and what type of information it's required, unless that we are very certain to know about the preferences of the parents, because I don't know who I'm talking to. And therefore, the people that we're talking, it's during the worst day of their lives, one of the worst. But it's not the normal person that it's walking in the park. And we can see that we want to say that this is an essential part, with positive and negative ways. And all of us, we all, and therefore, of course, and because we wanted to support, and sometimes some people don't talk a lot, and there are inferences that are implicit. It's very interesting that there are so many surveys and work that have been published where they interview the healthcare professionals, the families, and the kids that have some kind of disability. And there are people that have followed them for 30 or 40, and therefore, we can see the videos, but some people say some have cerebral palsy and some have disabilities, but that people report a better quality of life than expected, the people that don't have it. And therefore, how many would tolerate to lose an arm or an eye, and to lose your hair? It's okay. But we need to offer them realistic expectations. But and therefore, as Wally said, we cannot predict the future. And this baby at 26 weeks, it's not tomorrow's babies at 26 weeks, because some of them have better options than others. It's very important to talk about the relevant topics in a very comprehensive manner, in a very respectful and empathic manner. Do we have residents here? I don't see them. Okay, we have some residents here. Okay, many times one goes with a kind of menu, and one needs to see from here to here, and the parents that are usually respectful, they say okay, and therefore they didn't understand a little bit. But yes, okay, thank you so much. And therefore, it's difficult to make this type of decisions in these types and to talk slowly and to take prenatal lesions. Things need to, and maybe we can assess the survival, disability, family burden, or whatever it's required for this family. Many times, at least in the U.S., and therefore in the prenatal, and the parent says, yes, yes, okay, I understand that it's a 22-weeker in the survival, etc., but is he going to be able to go to Harvard? Is he going to be able to go to Harvard? And how do you think that you want that has a very specific and therefore the ones that went to Harvard, no, we went to the community college. And then why do you want your kid to go to Harvard? And they allowed this baby to grow into a community college and to find a job and drive, and have a fantastic life. And Harvard, it's not the best thing ever for everybody. It all depends. And we can see the delivery process, and one of the ways to treat this, it's what comes to mind if I tell you that your kid can be blind, or that your daughter can have cerebral palsy, or that they can need 2 or 3 surgeries. What comes to mind? That's a way to be able to understand better what does that family need. And that's why we need to adapt the information to the preference of the parents, and parents prefer details. And some have but be careful, because when we have options, because sometimes we don't know in common terms, not do anything, mean different things with different parents. And the same information, it's felt differently when it's considered as a win-win or as a loss. Yesterday, in the fantastic talk that we did with Dr. Judis and Dr. Macaroni, with the resident and medicine students, I told them, I offered them a trip to Hawaii, and nobody wanted to do it. Because I said, I would say for free. But she looked at me and said they didn't understand. And I said, okay, there's just one issue. It's that 90% of those planes fall down. Oh, no, I won't go there. And I started to reduce the percentage, and when I get to 49%, they started to like the idea. And therefore, it's the same thing with if a mother asks at 22 weeks, hey, in this unit, how many babies survive? I can only say, and therefore, one can say my unit 35%. Some have mild problems, 25% have severe problems. And these are our figures. And this is just a gray area. And once again, if I tell them, and we can say that 51% of the babies survive, it's a phenomenon, versus 4 out of 10 babies are a disaster. The figures are the same, the statistics are the same, but they are showing it as the glass half filled, the glass half empty.
We need to support the parents' decision, obviously, because they are the ones who continue living with the choices, and also to resuscitate or not a baby cannot be black or white. Because as Wally mentioned this morning, some things are irreversible. If a little baby is not breathing and I don't any medication, the baby is going to die. This is irreversible. If I intubate the baby and I give the possibility of living for 12 hours, 24 hours, or maybe 36, okay, that could be possible. Again, we need to engage the key people and to see what are the emotions. We talk about very important facts. The nursing team needs to really take care with connection, trust, with heart, passion, empathy, and many things that sometimes we forget. But fortunately enough, the majority of us who are here, we do that on a daily basis. We need to expand that and to publish that in the networks. But if we do that every day, this is the list. We maintain the relationship with the parents, with flexibility, responsibility, respect, being receptive. You know that in the slide there are a lot of words, but this is our daily basis. This is what we want to do. This is what I expect from my colleagues, from my residents, and from my fellows. Make me feel old, okay, dear residents? Do you know Humpty Dumpty? Sat on a wall, yeah. Humpty Dumpty sat on a wall. Humpty Dumpty had a great fall. And all the king's horses and all the king's men couldn't put Humpty together again. The students didn't know anything about this. This is an anecdote. When a story is broken, we need to repair the story to put everything back again. This is what happens to these families. A dream was broken. What the parents say to us is, everybody said, my story is broken. Help me to put that again. This is what we do. Maybe the blood pressure is this and that, and other tests. No. How can we speak to that mother to say, okay, he's a little bit better, and I reduce the oxygen, reduce the pressure, and doesn't need more dopamine. This is how we arrange a broken story. We need to listen to the parents. This is fundamental. In this case, father and mother. It is very important due to the respect, to the grief they're going through. And we need to work with parents. This is overwhelming, I know, but really, thanks to this relationship with the parents, we grow as human beings because we learn about communication, we learn about the people, the love towards people, and respect towards other people. To take care of a baby who is dying, we need to be empathetic, be bigger than ever, to take care of our words, and to not create really false hopes. This is very sad when a baby dies. And if it's a lot of babies and we lose one, is always is very, very sad. We don't want to make things worse. We need to accompany the parents. Some parents, it's enough for them, for us to be sitting by their side quietly. Others want them to be hugged. Others want to receive the explanation, to tell them what happened. It's a long story. Okay, this is our job. This is why it's important, the communication. We need to know. We need to let people talk. We need to listen because it's part of what I am. And this is something that the parents tell us. And if you don't know how I'm feeling, I will always be alone. Like the slide I showed you yesterday, the parent with the incubator, remember? If we went through the story these parents are going through today, it's false to say, I understand what's happening to you. We can say, maybe, I understand you're sad, I understand you're struggling, what can I do to help you? And to help you all, what do you need now? If you need is have an hour hugging your baby in the room alone in a dark place, this is what you will have. If they want to call the rabbi or the priest, okay, they can do that. This is what they need. That's why we need to learn to listen. Shakespeare, during Macbeth, writes down that the words are pain. The words really do not say anything until the heart is broken. We can be enclosed in pain, we can talk about pain, or we can embrace pain, listen to it, and transform that pain. And this was written hundreds of years ago, and still it's very, very important. We need to learn to listen, transform, hug, and to transform the pain of that family together with ours, because we also suffer when something happens in the unit. Not only when the baby dies, when they are very sick, and that's why we need to listen attentively. This is the most important thing. We try to teach that to all the people in the unit. What do you think about the parents? Okay, some say it's difficult, some say they're impossible. They are all different. At the end of the day, they live in the world of art, religion, writing, novels, sports, business, professions, or dreams. Many dreams are broken for these parents. Do you think that way when you speak to your families? Who are the parents I have in front of me, or because the mother is 16-year-old, doesn't have a couple, or she's 25-year-old and she has AIDS and she's a drug user? Okay, so do we see them in a different way? It's interesting to ponder upon that. We need to be very careful how we judge the people. But okay, the NICU team. The previous slides, okay, us facing the parents. Now the parents facing us. They are all similar. This is what they say. They are the same. These doctors don't listen. They don't know anything at all. These nurses say, I cannot change the diaper. I don't know how to do this and that. They're all the same. They live in the world of science. Many times we hear that. You don't understand because you want me just to sign the paper for this randomized study. And you live in the world of science. For you, my baby is not a human being. They have algorithms, guides, protocols. We write the norms for vaccinations of any virus or for the 500 grams babies. User scores, medical factors, all these predictive information, many of the information that we use to forecast an evidence. They also say the healthcare team go from one newborn to another as nothing happened. They are faced with ethical medical decisions. Sometimes they're not even aware. Many of them lacking education when the residents are not clean enough or using only tennis shoes or they don't even use scrubs or whatever. So obviously the healthcare team and the parents see it clear. They also have fear. Not a good infrastructure to support the families that sometimes see the death as a failure. Don't you think so? In the university, nobody taught us that death is part of life. And no matter what we do, sometimes the babies or the patients die. It's not that we failed, but many times, and when they are young, when we are young, we take that as our own failure. Family says we are ambivalent and have a lot of contradictions. My question to you is, okay, so the families and the doctors, nurses, healthcare team, we're all different or not? Yes, because at the end of the day, it seems we're all the same. We are criticizing the others. We don't want to listen. Everybody wants to talk and talk and talk. So this chart is a little bit difficult to read, but these are communication strategies with the parents, like give them time to listen to them, give them the privacy, intimacy they need, and what cannot be done. You heard that yesterday. Okay, you're young. You can have another baby next year. It's okay. Just get over it. Okay, this other baby had it worse. If I tell you about my neighbor that had a cousin that this, and that, we need to give them time to say during the grief, it's better that way. He's not going to suffer anymore. Now you have an angel in heaven. You can have more babies. At least you have the older brother. Sometimes things we say like this, and if you're religious, this is what we feel, I know. But really, do you think that mother is going to say, poor baby has just died, is now an angel in heaven? And what are the right I have to put those words in front of her? When we are accompanying a family, we need to give them time, no pressure, and we need to know what's important for you in those moments. Like when a baby arrives to the NICU, we're going to see what it needs, what is the follow-up that baby needs. We need to know what the follow-up of the family is going to be. Maybe the baby has a cerebral cardiopathy that's not going to be resolved or something like that, much more worse. It will not survive. One of the things that we need with the family is what's important for you. Depends on every person, the religion, how you were raised, what do you think? What are the traditions that you have? I work in a very different environment compared to yours, where there's Orthodox community and also Muslim community, Jewish community, and we need to know the traditions of these families to not offend them. Obviously, I'm not going to give the hand to a woman who is Jew or Muslim Jew or Muslim women due to respect of their beliefs. And once they die, their beliefs and traditions we need to respect. If you know, okay. If you don't know what to do, you ask the family. When this happens, what do you want to do? Who do I need to call and when? And those moments, what do you want things to happen? What do you don't want to happen? What do you want to take home to be able to remember your baby? We have a small box where we put the pictures of the baby, sometimes a little bit of hair, the clothing of the babies. Families need some things, but part of our communication is to ask the families how they feel when they want to really hug their baby. They want to take a picture, they want to have some keepsakes. If we don't do that in advance, it's going to be much more difficult. When we cry, the family is crying as well. So without pressure, but without any omissions. We need to have an objective plan, part of the communication, and enable natural death. It's not the fact that we cannot tolerate that as a problem. No, we need to maintain dignity of the baby and the family, and to have a higher interest for the baby and the family regarding comfort, the needs of the family, expanded family. And so many times in my unit, the norm is that there can only be two people side by side in the incubator. When the baby dies, there can be 15 people. I don't care. That's the good thing of being a boss. This is the hardest moment for this family. If they want to baptize the baby before the baby dies, bring all the family. And we will give you the privacy, and we tell those families, this is a very tough moment, and you can really give them this time. This is our responsibility. Empathy and support is very important. We need that parents feel welcome, and they never going to be a nuisance for us. Just think about your daily life. How many times you said you put that face because the mother or father is right in the middle with a chair, and you want to be next to the incubator, but the mother cannot move because she has been going through a C-section. So you ask yourself, is she going to stay in that chair? Sometimes we do not see that, but as an observer, sometimes I see that, and it's very difficult that people really get that awareness. And we don't even need to say any words, but we put this, okay, this lady in the middle sitting down in this chair, this is not okay. Not okay. And we need to be very careful, treat them better. There cannot be communication gaps. Lydia already said that her baby is wonderful. And again, okay, I said yes, but maybe it has this other condition. How come? Who is at night and night shift, day shift is going to say something completely different. And the weekend, they say, why they're not being treated with 14 days of antibiotics, only 5 days. This cannot happen. This is a communication gap in the ethics also of the team who's managing the baby. There cannot be any conflicts among the members of the healthcare team, and we to explain the possible events to ensure that the baby is never going to be alone during the day and is always going to be monitored, accompanied by somebody. To remember, give them time, understanding that the grief requires time, enable identification, expressing their feelings like they're angry, hostility, sadness. Many times parents get mad because they're completely stressed. You, doctor, said yesterday that my baby was going to be okay. Look what's happening. Okay? Yes, that happens. Yesterday was okay. And now he is okay. But it's important to promote verbalizations of feelings, remembering that every baby has a name, has weight. And why? Because I want to talk, I don't want to talk about the baby in the bed number 5. I want to talk about Jorge or Matias, I think it's his name. This is custom made, the care, custom made care for the families, for them to feel important as families and also as the babies, as our patient. We need to identify the normal behaviors of grief. We cannot interrupt the tears and repeated stories of the parents. This is unhuman, it's inappropriate. If they are crying, I let them cry. I'll hand them some tissues so that they can feel much comfortable. It's not okay to interrupt them. Think about what you would do in that case, what you would feel in that case. We need to identify and solve any secondary losses because we always have dreams and hopes of what we're going to have with this baby. And it seems that dream is broken. And help to find resources of continuous care. It doesn't end in the NICU. Always the follow-up, not only in the ICU, with all the psychological disaster that the NICU implies. And some parents need much more help. And this is our responsibility as healthcare team, not to solve it, but to seek somebody that can help them. Maybe need psychotherapy, medication. This is part of our work, at least I believe so, to identify and to refer the pathology in the necessary case. You see, for example, a woman that really that you don't see her the same way, something is happening. I don't have the capacity nor the education to give her psychotherapy, but I can refer that person. I can ask her, what happened? You were wonderful last week, and something happening? Just to listen to these families have also problems among the couples, they divorce, that's why they're fighting at home. And maybe the father is saying to the woman she is guilty, that it's your fault that this baby's in the NICU. I told you this and that, and this is your fault. This is tough to handle. Why do we talk about this? Because we all have dreams. Some dreams are fulfilled, others not, and sometimes the dream is broken. Sometimes we see a picture like the one in the left, where the parents have a baby in their arms that has recently dead. It's very sad that this mother was waiting to play with his baby, but she's now alone. Maybe the father's over there drinking some beer, but the mother is alone. And this is something that we need to think many times when we are in the NICU. Juan Eduardo Tesone is a psychoanalyst, and he wrote a book about the importance of the name. And among what he writes down is the words are not enough. Many words are not enough. To accompany with empathy, to listen, and to try to satisfy what the parents is not enough. So the words can injure somebody and can help others. But think what you're doing, because many times you're talking with a mother or father that will go outside alone and have nobody to play with. Maya Angelou is an American poet, and I would like to say that one of her quotes is people will forget what you said. People will forget what you did, but people will never forget how you made them feel. So this is our position. If we're crossed hands, how can we make them feel the empathy that we have for these parents, family members? How are we making them feel? Will change their life, are going to remember in a different way. Thank you very much.
pertenezco y trato de ayudar lo más posible. Esto me va a servir mucho, pues. Se llama Lazos de Amor y nuestro lema es transformando el dolor en amor. Ese es es terrible, realmente. Es muy duro, tenemos una montaña rusa tremenda, pero específicamente las madres que han perdido bebecitos, porque encima de todo he estado en la UCI, pues, o sea, estoy en los dos lados. Y yo a veces tengo que apoyarlas y decirles, por favor, no se sientan así cuando algún médico no los trató bien, previo a su muerte. Y es exactamente lo que usted habló hace un momento, que un médico les dice una cosa, cambian de guardia y otro les dice otra cosa y le critica al otro. Entonces, tiene que haber una sincronía en el equipo, porque a mí me ha tocado defender a los médicos de algo que es indefendible, pero tengo que hacerlo dentro del grupo de apoyo. Y respetamos a todas las mamis, porque hay bebés de 25 semanas que han pasado un mes en la UCI. Finalmente han fallecido, pero tienen su nombre. Y están las fotos y el día
Then
de
you can
duelo todos
see
los
the
apoyamos.
pictures and we all
Tenemos una
support each other.
psicoterapeuta,
There's a
tenemos tanatóloga que
psychotherapist,
con el grupo.
neonatologist.
Pues, y yo, a pesar del
¿Apenas ahora? ¿En este momento? Yes, we need a support group. So the mother and the father who has decided when they need that support, we need to respect that. To collect everything you're saying, but there are parents who don't want anything at all. They don't want to know anything at all. They just want to forget this situation. And we need to respect that as well. Yes, I do agree with you. I went through that. If they don't need it, okay, we stay silent. And I said, if you need something, we're going to be here. So these babies must be treated like mine, who died at 26-year-old. We need to treat the mothers like that because it's a terrible loss, terrible loss. So congratulations. And I'd like to say that in my country, in Guatemala, we have support groups, and we will receive you and receive them whenever the mothers want to go. Doctora Lidia? Okay, coming from Carmen. Thank you very much. Sergio, you've talked about communication in an excellent way, to include the families, to consider the emotions, not only mother and father, but the extended family, to have a wonderful space to talk to the parents. This is really something that can help us all, those who are starting and those who continue to work. And also, I would like to ask you, how do you manage the impact of the bad news and bad evolution of the babies, not only of the families, but also the healthcare team of the unit? When a baby dies, or when we have a series of resuscitation in the delivery room, or that day or next day, we have a meeting with the whole team involved in the case to talk what was done, what wasn't done, what can be improved. Always, there's something that can be improved. It can be communication, who did intubation, or who assessed the baby, and this and that. And the same thing, we do that with the healthcare team, because even though we want to be very stoic, we continue being human beings, and we are hurt, and it's not healthy to keep quiet. So I insist that with the residents and the nurses who are part of the case, whatever case is, there's a nurse who took care of that baby and she wasn't there, so we would do that meeting afterwards to talk about the feelings of each one. This is not an official support group. Sometimes I ask for the social worker to come and visit us, so that people can feel comfortable. But I do believe that it's important to know how to intubate and use ventilator. It's even much more important to know that the people are leaving empty-handed. And the same thing for the healthcare group. I really celebrated the first year of many babies because they arrived, and after 12 months they're still with a ventilator, or maybe they don't want to do a tracheostomy. So they spend a lot of time with us and their families. So we belong to their life. In Christmas, I receive letters, postcards. Some are, can I say, it's not curious. Letters of children saying, I don't think you remember me, but I just ended college. And I said, okay, wonderful. I was young at the time. But the most important thing is when we support some families and afterwards life improves. A family that I really love had a girl with severe ischemia, hypoxic ischemia, and for the first time I was able to convince a professional to refer to that girl, and I waited for the other family members to arrive. And in the morning, all together, we disconnected her from the ventilator. I'm still connected with them. They had 2 more babies after that. And they invited me to the birthdays. So next year, I'm going to the bar mitzvah of one baby who had hypoischemia, and okay. I didn't really guarantee anything to this family, but he's already 13 years old. So these are the stories. The families are very thankful with us. I'm pretty sure that many other families may judge, but this family specifically, we have very good communication. And we met again after a lot of years because grandmother once said to me, you are Dr. Bolombeki. You treated my grandson in Westchester. He's okay. He's doing fine. That's part of communication. Any more questions?
Thank you so much, Dr. Lydia. This is it's a two-part question because on the one hand, we always talk about the baby that it's born sick with an issue. And do you have some kind of protocol that varies when a baby was born or they gave it to the mother, they went home, and then this baby gets sick later? Maybe because of congenital pathology that hadn't been detected, or because they got sick or they contracted a severe infection. This is a part of the question. And the other part, it's that, as Sergio well said yesterday, we talked with some of the students of Universidad Bolivariana, and there were some questions that later on I thought about, and I say, if the nursing, if the in the NICU health team, it will never say the neonatologist never gonna be in the NICU, and the truth is, let's talk about. We're going to shut down the budget, and we're not going to add nurses. Wouldn't it be the moment to start thinking that the expert in perinatal psychology should be part of the staff of the NICU, and not as someone that you're going to go to the psychologist, no, but as someone that it's there, as well as the nurse or the neonatologist is controlling the saturation of the baby. We can see the expert in prenatal mental health checking out what you say. Okay, the mother, the mother has taken a shower in 3 days. Okay, it is something new. and therefore how in the American system that the patients always go to the same hospital. It's easy to know when many of these babies come back to the hospital because they're septic or they have a congenital cardiopathy that had been diagnosed, because they go to the same hospital they go to, and then the therapist comes and thanks us with our patients. This is part from a medical perspective. It's not unusual that the families communicate with the nurses to their personal phones. And therefore, we can see that the nurse says, hey, did you know that Peter is in the floor? No, I don't know. Apparently, and didn't. He started seizures. He's having seizures, because what I do, it's the idea. It's that because the baby came back, and I'm saying, not okay. Well, I go to visit him and say, hey, what happened? And so that it doesn't happen again with another boy. The possibility of having psychologists in the U.S. it's almost null, and sadly, many of the therapists and then many of us, it's done by staff that it's not ideal. They are social visitors that have some kind of training, and that they like to talk, but they don't like to listen, and they don't have good promotions. And that's why to be able to get a prenatal psychologist, it's almost impossible in the U.S. where I move around. And although in some places they at least, therefore, and therefore I can see that maybe they were not done, and that it's sad. It's sad if I offer this type of talks in the U.S., many people are admired because one, as a doctor, is paying attention to the family, which is strange, but it's hard for them to move a step forward, and there and therefore I wouldn't reject anyone if it's, but until then, there's not the ideal person to do this. Thank you so much, Dr. Mónica, and then Marta. Dr. Mónica, and then Marta.
Bueno, tal vez créenos, nos queremos. Nosotros somos afortunados.
We are fortunate in my unit in Chile, in Santiago. We are very fortunate because we have a team. We have a psychiatrist, we have 3 psychologists, two social care assistants, and a social worker. And it's a wonderful experience. It's a wonderful experience. We can see that each of the psychologists takes a patient, and that the one does this, the other one, and the new patient. And we have 70 beds, and they have a lot of work. And they start filtering who requires more therapy, who requires more support, etc. That was not my question. In the Western world, from a cultural perspective, it's difficult to look at pain. We don't want to look at pain. It's hard. It's hard to consider that there is death. It's like if we were all immortal, and the only thing true in life is that we're gonna die. But we have this thing. That's why when the doctor from his Western subculture needs to face the pain and death situation, they don't want to see it. And that's why many times, or most of the times, especially in younger people, it's difficult. It's difficult that empathy flows, because they don't want to see it, because it's hard of them to see it. That's why in this context, and they, especially if they are working in a NICU, because people die at birth, or they die when they have to die, and especially the ones that are going to work in a neonatal critical care unit or a pediatric care unit, they need to have preparation, and then you have to do training to give bad news, to provide support in the moment of significant loss, and also to support in when enabling communication between the ones that suffered the most, which is mom and dad. It can't be one or the other, and no. And that's why the question is, what what do you know that we have in different units in the U.S. or somewhere? I think that we all run away from pain until it touches us personally. That changes us. I don't know if Dr. Duarte was the same after her loss, and maybe internally is, but acknowledging that one needs to change the way in which one communicates with people, it's not that easy. And I think that within the educational curriculum of the fellows, one part it's palliative care, ethics, and also pain management. And within the nurses, I can't tell you the amount of months that it took me to pass the protocol for pain management in the NICU. For nurses that have been for 20 years in the unit. No, it doesn't happen. Doesn't happen. I mean, you need to be careful, but I sometimes told them, yeah, it's painful. You do it yourself. I mean, it's painful for the baby, and it took me a long time. But I think as an experience, no, that happens to other people. It won't happen to me. And the patient says, hey, it's not my fault. I did what I had to do. It's like talking to a wall, and they don't want to face what anguish and pain means in accompanying another human being in moments of crisis. It's not that easy. We only have a couple of minutes, but we do need the participation of the psychologist and of the family representatives. Yes, we're always the last ones. Oh, okay. Okay, doctor, I wanted to congratulate you for bringing to the table two very important topics, which is communication and empathy. But I wanted to highlight the two other topics that you mentioned and that I think that are critical and that unfortunately we forget about, which is respecting the patient's rhythm, the family's rhythms when they are living a grief or when they wanted to assimilate the bad news that has been given to them. And number two, we need to respect the way in which they wanted to handle this, because they want a lot of information on if they want to do a ritual or not, if they wanted to take the herbal tea, whatever. And I think that this is something that we need to take into account to respect the rhythms and the way the grief is developed. I want to add something else. And thank you so much. For thanking me for these talks, but also thank the organizers that are sitting here in the front row, because this was the negotiation. Because when they invited me, I said okay, but I do ICU. Basically, I mean, no. Don't talk about a pulmonary hypertension. No. This is. But please tell me what happens later. And part of what concerns me in my professional, it's how do we do to improve other things, not only the science, not only science and math. And I think that everybody that's here in the audience that are not falling asleep need to thank the organizers for this talk, that they have been able to gather such a diverse group of professionals that come from other countries, from other cultures, with other accents, to be able to see something that covers us all. Because in all the conferences, most of the comments are, wow, how interesting, I've never thought about this. Or based on as of now, I'm going to check out the creatinine, I'm going to see what happens with the mother, what happens with the father, or with the grandfather. And this is thanks to to see what's interesting today in 2026 for a couple of people. And that's why a big round of applause it's for me, yes, but also a round of applause for everybody that's here on the front row, because they are the ones that organize this type of meetings, so that you can all listen to a diversity of topics that are interesting for us. It's not just what ventilator we use. Why do we use the ventilator, and how do we explain this to the families? And yesterday, sorry. Dr. Telombeki, yesterday we had the opportunity to talk for a long time, and I wanted to say the human being, and therefore that the families, and then therefore more than intervention to ASEPNEO, because it opened up a space that we are going to have in a couple of minutes once we have the room available, that it's called the Voice of the Families, and it's going to be a meeting with professionals that are the people, and that's professionals. But we are going to have a family representative. So we're here because my family tells me I can't speak. They are mothers of premature babies in Ecuador and in Costa Rica, and I work and follow up, but I'm very close. For 6 years I've been in contact with them. I know what they've endured, and that's why we would like to thank you for opening up this space and to keep on listening to this that the families have to tell us. And that's why we need to continue this conversation somewhere else, okay? And please, okay, okay, a message for the babies. Oh, okay, I would like to thank you. Please leave, because we need to do the divisions for the next part, and we leave, and we wanted to thank you so much, everybody. As Flor Angel says, we're going to leave. They're going to separate the rooms. And okay, this is the end of the session.
recién nacido de alto riesgo, que hoy se desarrollará el segundo encuentro. El doctor César Sánchez los espera en el aula 608. A continuación se desarrollarán dos actividades en simultáneo. Los invitamos a elegir la propuesta de su interés y a dirigirse a la sala correspondiente. En esta sala daremos comienzo al taller de sueño, polisomnografía, oxígeno y seguimiento, con la participación de la doctora Andrea Parra y la doctora Ana Carolina Sierra. Este taller cuenta con el aval de la Asociación Colombiana de Neumología Pediátrica y es auspiciado por Boutique Respiratoria, a quienes agradecemos por su acompañamiento en este espacio. En paralelo se llevará a cabo el Encuentro Latinoamericano de Familias y Profesionales, Fortalezas de Latinoamérica en el Cuidado y Seguimiento de los Niños Prematuros y de Alto Riesgo, en donde participan la doctora Natalia Figueroa, Catalina Lince, el señor Juan Pablo Bernal y la doctora Lidia Gudici, la señora Luciana Pareto, Gabriela Pose, Nelly Vergara, la doctora Mónica Morgues y la señora Viviana Fernández. Los invitamos a acercarse a las salas correspondientes para dar inicio a las actividades.
Bueno, bienvenidos todos. Muchas gracias por este espacio donde queremos realmente compartir lo que llevamos trabajando en medicina del sueño desde el punto de vista neonatal, los pacientes de alto riesgo y de seguimiento. Y siéntanse muy en confianza para compartir sus experiencias, sus dudas, para cuando analicemos los casos clínicos, aprovechando que somos poquitos, de que puedan realmente llevarse como la mejor información para sus pacientes. Les cuento que vamos a desarrollar esta actividad hablando temas, digamos, básicos, pero que hay veces cuando leemos los polisomnogramas nos cuesta entender qué nos están describiendo, sobre todo, por ejemplo, en patrones continuos, discontinuos, ondas, correlación con la edad gestacional o no. Entonces, entender un poquito la importancia del sueño, la fisiología de ese sueño desde la etapa neonatal hasta su periodo de maduración y cuando empiezan a considerarse los niños ya como una interpretación muy parecida a los adultos. ¿Qué pasa con las apneas centrales, que es inicialmente a lo que más nos enfrentamos en la población de alto riesgo neonatal y prematurez? Pero de ahí también entender cómo esa apnea central puede ser el marcador inicial de apneas obstructivas o de compromisos ventilatorios de los pacientes. Y después vamos a enfrentarnos prácticamente como un polisomnograma que deberíamos siempre chequear y que tener como nuestra lista de revisión de ese polisomnograma para que sin tener que mirar la conclusión, ustedes puedan sacar sus propias conclusiones del manejo. Y en eso vamos a participar en diferentes casos clínicos para que podamos construir la mejor información. Le doy paso a la doctora Ana Carolina Sierra, neuróloga, pediatra del Hospital Pablo Tobón Uribe y quien también trabaja en CEMPI y que lleva mucho tiempo en somnología, en medicina del sueño como somnóloga 1 y lee ampliamente polisomnogramas en esta ciudad en CEMPI y nos va a compartir un poquito inicial la parte neurológica y después yo la parte neumológica. Bienvenida.
Muy buenas tardes para todos. Teniendo en cuenta pues que este público es muy diverso, voy a tratar de muchas veces de basarme en la parte neurológica como en los temas más básicos, ¿sí? Teniendo en cuenta que el sueño es una variante fisiológica. Yo digo que el sueño y la alimentación o el hambre también son variantes fisiológicas y que en el neonato ellos tienen más de un tercio de sus vidas que están durmiendo, entonces es una parte muy fundamental, ¿sí? No solamente es porque decimos que sí, tienen que dormir para que puedan descansar, para que puedan tener la maduración, pero ¿qué es la maduración en ellos? O sea, la maduración es la que podemos mirar los cambios de la plasticidad cerebral, ¿sí? ¿Cómo lograr que en los niños prematuros y neonatos van en la parte de neurodesarrollo, hasta que ya en niños más grandes decimos que es necesario la parte de sueño para poder tener la parte de la memoria. ¿Sí? Nosotros consolidamos lo que aprendemos, incluyendo todo lo que aprendemos del neurodesarrollo en el sueño, que es el REM, que viene a ser en la parte de neonatos el sueño activo. También la regulación inmunológica. El sueño tiene un gran papel como linfangístico, que eso es una parte fundamental porque no es solamente que se limpian, también es antioxidante, sino también por producción de citoquinas. El equilibrio metabólico, lo que nos decían las abuelas, eso es verdad, que se secretan muchas hormonas y que el sueño ayuda a que crezcamos. Y esto, yo creo que es lo más importante, el impacto familiar. Ustedes van a ver en la consulta cuántas mamás de niños grandes me dicen, doctora, es que el niño nunca duerme bien. ¿Cómo es no dormir bien? Desde que nace. O sea, desde el primer día de vida no duerme bien. Uno dice, son exagerados, pero vemos realmente que hay algunas patologías que si nosotros no detectamos a tiempo se cronifican y llegan niños de 5, 6, 12, 14 años que desde la época neonatal nunca han dormido bien. Y vemos que la parte fisiológica y la parte anatómica se entremezclan y eso es lo que hablamos de maduración y lo que podemos interpretar cuando vemos las onditas, ¿sí? Desde que en la semana 24 vemos que esto es casi que sin giros, ¿sí? Vemos que esto está muy lisito, la parte de la corteza cerebral, hasta cuando vemos al niño ya de un mes de nacido, en que vemos que están bien formados los lóbulos, están bien formadas las circunvoluciones y por ende las uniones o las sinapsis están muy bien desarrolladas y esto también nos hacen ver que en las ondas o en lo que vemos en las rayitas, realmente eso es lo que nosotros interpretamos. Entonces nosotros cuando les decimos a ustedes, es que este niño está inmaduro, es porque podemos ver realmente eléctricamente qué está pasando en la parte fisiológica y cómo se puede correlacionar con la parte estructural. Y acá que vemos, en las 24 semanas de edad gestacional, es desde ahí, es que nosotros podemos interpretar eléctricamente, o sea, nosotros hacemos un electroencefalograma a esta edad y podemos empezar a tener algún tipo de actividad cortical. Antes de estas semanas, eléctricamente no es posible realmente que haya alguna actividad cortical en el neonato, ¿sí? Pero donde vemos realmente que se empiezan a consolidar los patrones es cuando ya son niños llegando a lo que nos llama los pretérminos límites y ya después a los 3 o 4 meses en que empezamos a ver ya lo que se llaman los ritmos circadianos, o sea, cuando empezamos a ver que los niños duermen de noche y ya hacen menos siestas en el día. Y ya entre los 4 y 11 meses, casi al año, es que empecemos a ver más un sueño muy parecido ya a lo de los niños más grandes. ¿Y por qué estamos hablando de esto de continuidad y discontinuidad? Porque muchas veces, no sé si ustedes, no solamente la conclusión, sino si se han visto reportes de electroencefalogramas o reportes de polisomnografías en la parte eléctrica cerebral. Entonces les dicen actividad interbrote o intervalo interbrote. ¿Qué es intervalo interbrote? Es el intervalo entre una actividad y la otra. Y el silencio, o sea, la parte en que está plana, eso es lo que llama intervalo interbus o intervalo interbrote. Entre más largo, es más inmaduro. ¿Y eso porque es importante? Nosotros tenemos un intervalo interbrote en un niño de 37 semanas y decimos pilas, o es inmaduro o es que ahí está pasando algo. Un intervalo interbrote más de 10 segundos lo vemos mucho, por ejemplo, en niños con hiperglicemia no cetósica. ¿Sí? Y en nosotros es muy importante porque es uno de los principales marcadores de esa enfermedad. Vemos también que en el prematuro extremo, vemos que al principio el trazado es discontinuo, o sea, tenemos muchos periodos de atenuación del trazado, que vemos que son trazados que son ondas grandes, de gran amplitud, que se llaman las ondas delta, lo que se llama los patrones delta brush o delta en cepillo, que ya empezamos a mirar que el niño ya va cogiendo señal, o sea, que ya empieza a haber más actividad cortical que está empezando a hacer más sincronismos entre tálamo y hipotálamo y empezamos a ver esto y ya empezamos, ¿eso qué quiere decir? Que ya empieza a haber más formación a nivel de los giros temporales y frontales. Ya cuando empezamos a la semana 34, empezamos a decir, a poder diferenciar cuando este sueño es un sueño activo o un sueño calmo o pasivo. El sueño activo es lo que viene de ser después sueño MOR o sueño REM. Y el sueño pasivo es el sueño no REM. ¿Sí? Y el sueño indeterminado, que muchas veces ustedes van a decir, ¿y esto qué es? ¿Esto con qué se come? Resulta que el sueño indeterminado es que usted no sabe realmente catalogar por variantes de polisomnografía qué es, si es un sueño activo o es un sueño pasivo. Y puede haber realmente, esto también tiene un número, digamos, de normalidad. Cuando vemos un sueño indeterminado en pacientes que tienen 40 semanas, uno dice, esto es anormal, aunque no es epiléptico. Pero sí se nos habla de que hay algo de inmadurez, hay algo que nos está realmente haciendo buena sincronización. Y después, cuando ya es un niño que está a término, ¿sí? Vemos que ya sí hay una buena diferenciación entre sueño activo y sueño pasivo y también que es la continuidad, o sea, no debemos ver eso que habíamos visto que son el silencio, ¿sí? Y ya empezamos a ver nuevos marcadores, entonces empiezan a decir, esto es mucha terminología de la escuela francesa, que es encrochet frontal, delta frontal, que eso nos dice, vea, este niño, cuando lo vemos, nos ponen un trazado, decimos, este niño está maduro, este niño está a término. Y ya después, cuando empezamos ya niños ya que tienen ya más de 40 semanas, vemos que se consolidan ya y que el sueño activo es más del 50% del tiempo total de sueño. O sea, cuando nosotros vemos en polisomnografías niños que tienen muy pocos ciclos de sueño activo, también nos prenden las alarmas de que hay alguna irregulación a nivel o alguna inmadurez a nivel del sistema nervioso autónomo que hace que este sueño no está presente, ¿sí? O está muy disminuido. Y también generalmente los niños se duermen en sueño REM. Entonces cuando decimos, es que la latencia del REM es de 3 o 4 minutos, es normal para ellos, ¿sí? A diferencia de los adultos que el sueño REM aparece más o menos a los 90 minutos. Y también ya después vemos que los niños más o menos a la semana 44 ya cambian nuevamente la parte de los patrones, ¿sí? Ya empezamos a ver preusos de sueño y los usos de sueño cada vez están haciendo más bonitos, más largos, pueden ser síncronos o asíncronos, o sea que se vean en un solo hemisferio o en ambos hemisferios, y ya después del mes 3 se debe ver absolutamente obligatorio. ¿Por qué es tan importante ver usos de sueño y decir, este niño está bien? Sobre todo cuando hacemos polisomnografías de seguimiento, o sea, ya cuando estamos en plan canguro y los vemos después, porque esto nos marca realmente que está sincronizado, que hay una sincronización tálamo cortical y que realmente estamos teniendo fisiológicamente un sueño consolidado. Estos marcadores son solamente pues como información, esto es más como para los que leemos, realmente que son los usos de sueño, complejos K y ondas agudas de Vertes, se deben ver después de la semana 44, ¿sí? De vida gestacional. Nosotros para las variantes respiratorias y las variantes de electroencefalograma en niños siempre tenemos que hacer la edad gestacional corregida, ¿sí? Aunque sea hasta los 24 meses. ¿Y por qué les pongo esto? He tenido reportes de X o Y persona, de neonatos, en que me hablan de usos de sueño. Entonces, saber también ustedes, mirar si realmente lo están diciendo o es una plantilla. Y esto es lo que en todos los libros está, cómo empezamos de que son unas ondas irregulares, que son ondas de gran amplitud, y empezamos a ver, estos son los famosos delta brush, los transitorios temporales, ya lo que empezamos a ver, cuando empezamos a ver la parte del encroche frontal y los usos de sueño. Entonces, de acuerdo a eso, cuando nosotros leemos la parte eléctrica en una polisomnografía, nosotros miramos, vea, este niño muy probablemente sí tiene 30 semanas, tiene 32, 33, es un niño muy pretérmino, inclusive sin tener toda la información, porque estos grafoelementos nos ayudan a clasificarlo. ¿Cuáles son las reglas de oro? Siempre, precisión. El electrodicto le da concepcional con un margen de 2 semanas. Me explico, cuando uno le dicen, o en el conclusión dicen, es que tiene un disincronismo externo mayor de 2 semanas, es que realmente, como cada 2 semanas cambian los patrones eléctricos a nivel de polisomnografía en época neonatal, digamos que eso quiere decir que, por ejemplo, es un neonato que tiene 40 semanas de edad gestacional, pero que nosotros estamos viendo grafoelementos de sueño que están menor. Entonces uno dice, pilas, ahí puede haber algo de inmadurez. ¿Listo? La ley de la continuidad. Entre más continuo está un niño más maduro. ¿Listo? Y el imperativo tan contextual. Nunca leer solo el cerebro. Para poder mirar, siempre debemos tener un ciclo completo poligráfico usando también la parte respiratoria, ojos y tono muscular. Por eso lo ideal, no solamente para mirar la parte de apnea, sino para mirar todo el contexto de maduración y cuando tenemos patologías neurológicas en la época neonatal, es la polisomnografía, que la preferimos con respecto al electroencefalograma. Y también porque muchas de las crisis en época neonatal son muy sutiles y solamente podemos ver algunos cambios que nos ayudan mucho la parte respiratoria o la parte poligráfica. Esto es solamente para recordarles que los neonatos tienen un ritmo que es ultradiano, ¿sí? Los adultos tenemos un ciclo de 90 minutos, ¿sí? O sea, de 120 minutos, entre 90 y 120 minutos, o sea, cada 120 minutos cambiamos de fase, o sea, hacemos N1, N2, N3 y REM. En cambio, los niños cambian cada 90 minutos, ¿sí? Entonces, ellos por eso es que duermen y comen, hasta más o menos que empezamos a ver el ciclo circadiano, que es entre más o menos entre los 2 meses y medio y 3, que empezamos a ver esa variación. Cuando vamos a hacer polisomnografías, que muchas veces las personas pues, que no están pues, como muy familiarizadas dicen, pero ¿y por qué le van a poner a eso al niño? Eso estorba. O sea, lo que le hacemos en la polisomnografía es, tenemos las variantes de la cabeza, que son la parte de los electrodos encefálicos, ahorita les digo cuáles son los más importantes, la parte de las correas o bandas en el tórax y en el abdomen, que miran no solamente posición, sino también la parte pues, para mirar la parte de excursión torácica y abdominal, el flujo aéreo que es con el termistor, y muchas veces cuando tenemos CO2 en tidal también se lo ponemos ahí. En la parte de electromiografía se lo colocamos en los electrodos submentonianos para mirar la parte de, eso es lo ideal, no en todas partes se lo ponen, no es para ronquido, nosotros se lo ponemos más es para mirar la parte de musculatura, porque a veces también tenemos fenómenos de que ellos pueden hacer la parte de posturas o algo tónico que nos ayudarían, sobre todo en la parte eléctrica, y los movimientos de extremidades. Acá, como la cabecita y el perímetro cefálico de los pretérminos es tan pequeñito, ¿sí? No podemos poner todo el sistema 10-20, que es el sistema que ponemos de electrodos en los pacientes en general, ¿sí? Que es todas las que ponemos, sino que ponemos lo que son azulitos que están oscuros, ¿sí? Que esos son como los principales. Y siempre debemos tener que siempre ese electrodo debe tener CZ, que es en toda la mitad. ¿Por qué? Porque en esta parte, en esta región, es donde está la mayoría de la actividad eléctrica normal, o sea, la mayoría de crisis se ve mucho en CZ, y cuando uno le colocan todos esos electrodos, uno se queda muchas veces sin poder realmente mirar si tuvo crisis o no el neonato, ¿sí? Esto realmente es un resumen de lo que les estaba diciendo. Yo me voy a detener un poquito en este acrónimo que se llama T solar, que es nosotros tener en cuenta cuando vamos a hacer un reporte y para mirar si hay un reporte de calidad en la parte eléctrica, en el electroencefalograma, en la polisomnografía, topografía, o sea, que nos describan los grafoelementos de acuerdo a la edad, organización, si uno dice si está organizado, si son síncronos, si son asíncronos, amplitud, o sea, si el trazado está gran amplitud, si está hipovoltado, la reactividad, o sea, describir si es reactivo o no con los estímulos que hacemos, y si tiene la habilidad también no solo en el trazado, y síncronos, que quiere decir que se vea en ambos hemisferios. Ya voy a pasar un poquito más a las apneas centrales, pero desde la parte neurológica. Ya la parte de neumología, ya mi compañera las va pues, a desarrollar más, ¿sí? Realmente los pacientes que tenemos en las unidades de cuidados intensivos neonatales es muy frecuente. Pues en el Palotón, como no es un centro donde nazcan tantos niños, no vemos tantos pretérminos, pero sí nos remiten muchos niños pues, que son de complejidad, sobre todo pues, para el tratamiento multidisciplinario, y vemos mucho apneas centrales. O sea, y yo creo que en los centros, pues en SOMER y en UPB, eso es pan de cada día. ¿Sí? Hasta un 30% en los estudios internacionales hablan de apneas centrales con repercusión clínica, o sea, que generan desaturación y bradicardia, y pueden tener anormalidades subyacentes en sistema nervioso central. Ojo, un 30%, pero el otro 70%, ¿qué es? Muchas veces nos quedamos con el 30% y dice que apneas centrales es igual a neurólogo, y nos quedamos sin averiguar el resto del 70% de las apneas centrales, que es lo más común, y realmente el manejo de lo que le genera la apnea central es el tratamiento que debemos tener más que el oxígeno, ¿sí? Y el 80% de los pacientes entre centros de referencia pueden tener ya un factor de riesgo anatómico funcional conocido para identificar, y muchas veces no es solamente a nivel del sistema nervioso central. Y pero porque es importante saber o detectar las apneas, ¿sí? Porque puede tener consecuencias, ¿sí? Estas consecuencias son potenciales, no quiere decir que siempre las va a desarrollar, ¿sí? Que tenemos que tener en cuenta si puede haber desarrollo de epilepsia, si puede haber compromiso cognitivo y motor, déficit sensorial y muerte. Esto es cuando es algo pues, muy exagerado, cuando estamos viendo, por ejemplo, pacientes que tienen malformaciones del sistema nervioso central, sobre todo a nivel de tronco encefálico, que pueden desarrollar pues, como todo esto. ¿Listo? Y la triada clásica: apnea, desaturación y bradicardia. Eso es lo que en los dos monitores y nos van a llamar a decir, es que el paciente hizo apneas. ¿Por qué? Porque mira el monitor y está desaturado, está haciendo la bradicardia y muy probablemente está haciendo la apnea. Pero ¿qué pasa? Muchas veces la desaturación puede darse de forma tardía, y muchas veces hay taquicardia antes que bradicardia. Entonces, a veces las apneas también se detectan de forma tardía. ¿Y esto por qué pasa? ¿O cuál es la relación? Los sistemas a nivel de tronco encefálicos, que es el centro regulador respiratorio a nivel central, que es el tronco encefálico en las áreas pre-Boxiner y la zona parafacial, ¿sí? Recibe todos estos circuitos, tanto de quimiorreceptores, de neuronas aferentes, y también esto también a su vez da el impulso ventilatorio hacia las motoneuronas respiratorias, ¿sí? Y esto también depende si está en vigilia o está en sueño, porque de acuerdo al sueño, también esos quimiorreceptores hacen que pueda ser más susceptible a que haya el fenómeno de apneas por la desregulación que puede haber de quimiorreceptores durante el sueño, sobre todo en la inmadurez. ¿Sí? ¿Por qué? Porque en la inmadurez hace que los pacientes no tengan muy buenas conexiones todavía, no tengan muy buenas sinapsis, y esto que haya un desequilibrio por exceso de neurotransmisores depresores, o sea, el exceso de adenosina. También hay una respuesta paradójica a la hipoxemia, y hay una alteración de respuesta también al CO2 y también los patrones de sueño, ¿sí? Porque cuando hay pacientes que nosotros estamos viendo que en el REM o en el sueño activo están teniendo muchas alteraciones respiratorias, uno dice, pilas, ahí está pasando algo, ahí muy probablemente hay algún daño a nivel funcional o anatómico del sistema nervioso central. Vemos muchas veces que no es durante todo el sueño, pero que solamente vemos alteraciones en el sueño activo, es muy de alteraciones a ese nivel o a nivel medular. ¿Y cuál es la tormenta perfecta? Cuando se ve tanto la inmadurez pulmonar como la inmadurez a nivel del sistema nervioso central. ¿sí? La inmadurez, estas dos vías, esto más la inmadurez del desarrollo pulmonar que genera baja capacidad residual, menores reservas de oxígeno, y la inmadurez del control respiratorio hace que haya una vía superior que está inestable y que pueda prolongar la apnea. ¿Y esto qué puede hacer? Que haya una hipoxemia intermitente que sea crónica, ¿sí? Y las apneas centrales, uno dice, bueno, ¿cuándo? Realmente cuando hay que, a nivel neurológico, hablo, es que uno dice pilas, aquí tenemos las alarmas. Son mucho más comunes entre más prematuro sea el paciente, ¿sí? Es alta prevalencia, más o menos a la semana 34, aunque puede ser frecuente, digamos, disminuyen drásticamente en la parte de los porcentajes, cerca más o menos de un 30, un 20, un 30% a la literatura de persistencia a la semana 34 que sean debidas por prematurez. Y si a las 37 semanas un paciente que nunca ha tenido apneas y que no tiene otras cosas y que de un momento a otro empieza a verse con apnea, uno dice pilas, hay que buscar algo. No siempre es algo neurológico, pero siempre hay que buscar algo. Y realmente vemos que a la semana 40-52 hay un deceso abrupto si es solamente por inmadurez. Entonces, por eso hay algunas guías que uno dice, bueno, entonces cuando les ponemos metilsantinas, cafeína, se las ponemos entonces hasta la semana 34, hasta la semana 50, hasta la semana 52. Eso, digamos que todavía en la literatura no está bien definido. Y otra cosa que nos llaman mucho, es decir, es que hizo apneas, ¿esto es una apnea o es una convulsión? ¿Sí? Porque muchas veces encontramos que ya los pacientes están con fenobarbital, levetiracetam, porque hace apneas, y uno dice, bueno, ¿y si son crisis? Sí es verdad que muchas de las crisis en época neonatal son sutiles, o sea, no tienen mucho componente motor, y nosotros no vamos a ver un paciente en época neonatal con crisis tónico-clónicas generalizadas porque no tenemos la suficiente mielinización de la parte del cuerpo calloso, que es lo que hace que nosotros podamos tener esa semiología. Y podemos tener también apneas como primera manifestación de crisis o acompañadas de crisis, pero tiene algunas consideraciones, como que es el patrón de frecuencia cardíaca, o sea, usted puede tener taquicardia o bradicardia en medio de la apnea, y también la relación temporoespacial, porque también no solamente nos sigue pues como el ciclo respiratorio, y también que pueden también estar en vigilia. Y eléctricamente usted ve la apnea, pero también ve el cambio en el electroencefalograma. También cuando hablamos de las apneas, y que yo les decía que no todas son por alteraciones estructurales en el sistema nervioso central, vemos que lo que tenemos que buscar en apneas centrales es afectaciones sistémicas, como enfermedad de Hirschsprung o muchas veces el síndrome de Undine, anomalías cardíacas, reflujo gastroesofágico. Esa es una causa muy común en nuestras unidades y muchas veces no la preguntamos ni tampoco la tratamos, ¿sí? Cuando hablan de kerníteros, aunque siempre en la literatura hablan de kerníteros, pues en mi experiencia he visto que inclusive pacientes con ictericia que no llegan pues al kerníteros porque se han tenido ictericia inclusive por infecciones urinarias o algo, desarrollan apneas, ¿sí? Pregúntenle siempre a sus pacientes, bueno, ¿qué tuvo la apnea, pero qué más pasó? ¿Qué más tuvo? ¿Sí? Porque muchas veces están relacionadas el reflujo y la ictericia, son unas causas muy frecuentes de apneas, ¿sí? También vemos algunas alteraciones metabólicas como la deficiencia de acil-CoA deshidrogenasa, y cuando son apneas persistentes acompañadas también de hipoventilación y de otras hipotonía, o sea, otras alteraciones a nivel del examen neurológico, podemos empezar a ver que no tengan enfermedades neuromusculares como la miotónica, como el AME, como la miastenia y las miopatías. Y también la parte del sistema nervioso central, sobre todo las malformaciones a nivel del tronco encefálico. Entonces, como hablábamos de cuando las apneas centrales en prematuros, que había una alteración en los quimiorreceptores, sobre todo en la adenosina, por eso una de las, digamos, en prematuros que se utiliza estrategias es el uso de metilsantinas o de la cafeína, porque ejercen un bloqueo directo y competitivo de los receptores de adenosina, ¿sí? Pero ya digamos que hay varios estudios en que, aunque la primera línea está la cafeína y el soporte no invasivo, también están otros medicamentos que se han usado en otras partes, como el toxopram y el sunifiram. En nuestro medio, cafeína, Doxopram y Sunifiram no los he usado. Y también cuando ya el paciente tiene una apnea y vamos a darle de alta, tener en cuenta, bueno, el paciente requiere CPAP para la casa, requiere oxígeno, requiere BNI, que requiere cánula de alto flujo. Y ojo, si por ejemplo, que es lo más común que requieran oxígeno mientras encontramos los factores o tratamos, por ejemplo, el reflujo o tratamos, si es por inmadurez, mirar entonces un tiempo para que ese cerebro inmaduro mejore, pilas con cuánto tiempo le vamos a dejar de oxígeno y cuánto le vamos a hacer el destete. Eso va a hablar un poquito más mi compañera. En algunos estudios la estimulación somatosensorial en algunas unidades las hacen y ayuda, dicen que esa vibración ayuda a estimular esos quimiorreceptores y por eso mejora la apnea, y el monitoreo domiciliario que en muchas partes y acá en Colombia ya lo están ofreciendo para, muchas veces es más para los papás, como para esa angustia que ellos tienen en que ellos pueden realmente monitorizar cuando realmente son monitores que sí son bien calibrados, no los que venden en Temo. Listo, muchas gracias.
Súper, Ana, y yo creo que me encanta la parte de apnea central porque a todos nos pasa mucho que sistema nervioso central, pero también hay reflujo, también hay ictericia, también hay condición cardíaca, también hay trastornos electrolíticos que tenemos que estudiar. Y viene una parte muy importante y es como la apnea central es el real predictor de que hayan como tal apneas obstructivas a posterior. Y estamos acostumbrados y decimos, pues un recién nacido, ¿qué apnea obstructiva va a tener? Pues porque qué amígdalas y adenoides tiene. Pues resulta que los estudios y los trabajos, incluso ligados del estudio CAP de cafeína de hace mucho tiempo del New England, estudiaron esa cohorte de pacientes y empezaron a darse cuenta que el 10 al 15% de esos pacientes prematuros sí tenían apneas obstructivas. Y resulta que lo que pasaba es que ese subgrupo de pacientes tiene un volumen nasofaríngeo y orofaríngeo mayor. Entonces, medidos por resonancia, se empezaron a dar cuenta que habían zonas o de mayor tejido o zonas más débiles que predisponían al colapso de la vía aérea superior durante el sueño, y empezamos a ver que era habitual que encontráramos apneas obstructivas en este grupo de pacientes. ¿Y cuál fue lo otro que empezamos a estudiar en el tiempo? Cómo nuestros niños con virus respiratorio sincitial quedaban con un riesgo aumentado de 2 a 5 veces el riesgo de presentar apneas obstructivas ya en el periodo de preescolares. Entonces, en definitiva, ¿quiénes se van con polisomnograma? ¿Quiénes hacemos polisomnograma en las unidades neonatales y quiénes hacemos polisomnograma en el seguimiento? Y indicaciones hay muchas como causas. ¿Por qué? Porque hay causas centrales, hay causas periféricas y hay otras causas que incluso la enfermedad pulmonar crónica o haber estado intubado y tener alteraciones aerodigestivas o tener asimetrías faciales o tener algún cambio en el tono del llanto o la voz podría ser un marcador de que busquemos a nivel polisomnográfico qué está pasando con la vía aérea de esos pacientes. Entonces, las indicaciones iniciales están muy ligadas a lo que todos sabemos y es a la necesidad de oxígeno. Pero más que ligada a la necesidad de oxígeno, vamos a empezar a ver que no es para todos, porque el común denominador es que todos tengan, la gran mayoría, oxígeno al alta. Lo que queremos ver es quiénes persisten con oxígeno, dependiendo de un límite que les voy a compartir, y ahí ver si necesitamos estudio de sueño o no. ¿Cuáles son los otros pacientes? Quienes ya tienen un componente de apnea central determinado en las unidades neonatales y queremos hacer ese seguimiento a posterior. Aquellos que tenemos la sospecha como tal de eventos obstructivos, aquellos que muchas veces descontinuamos cafeína y vuelven y empiezan los eventos, podría ser uno de los marcadores que dicen los estudios. Como les decía Ana, esa diferencia entre el paciente que tenemos duda en que convulsiona o tiene una apnea del sueño y aquellos que están con reflujo asociado a la apnea. ¿Qué hemos dejado nosotros para nuestro medio como consenso? Porque muchas veces también sobreabusamos del polisomnograma. Entonces, ¿qué hemos dejado realmente como consenso? Un grupo de niños que en la unidad neonatal, por alguna causa, ya se había hecho un estudio polisomnográfico y dieron apneas centrales importantes, hay que hacerle control en los programas de seguimiento. Niños que antes del alta para el programa de seguimiento siguen presentando desaturaciones o hipoxemia crónica intermitente. Hay que chequearlos antes de que se vayan de esa unidad neonatal. Niños que empiezan a hacer sonidos anormales, ronquidos, respiración ruidosa, llanto disfónico, que no es normal en el periodo de neonatal y que haya que chequear con polisomnograma. Y acá viene en el requerimiento de oxígeno. Quienes hemos visto de acuerdo a las cohortes que necesitan polisomnograma, y es aquel que fracasa en el retiro de oxígeno que está contemplado para el mayor de 32 semanas si lleva más de 3 meses con oxígeno. Para el menor de 32 si cumple 6 meses con oxígeno. Esos idealmente vuelven y se chequean con polisomnograma. Y también nos pasa que no tenemos solo prematuros y displásicos, también tenemos un grupo de niños de las 34 semanas, 35, 36, incluso llegando a las 37, que en nuestra unidad neonatal reciben oxígeno y que se tuvieron que ir con oxígeno para la casa. Y que muchas veces pensamos, ¿será que fue solo la ictericia? ¿Será que tengo que hacer un seguimiento adicional? O hay veces ni siquiera encontramos la causa y nos toca egresarlos con oxígeno. Ese subgrupo de pacientes que no les cumpla definición de displasia broncopulmonar es un paciente que se llama enfermedad pulmonar crónica posprematuridad, hasta las 37 semanas. ¿Qué se dice en la literatura con este grupo? Si esos niños alcanzan a llegar a las 40 semanas con oxígeno todavía, ahí deberían tener un control polisomnográfico. Y si ese grupo de niños, peor aún, en los primeros 2 años todavía tiene oxígeno, piensen si hay ronquido, falla en el medro o no han podido retirar el oxígeno, porque ese niño ahí también necesita un control de polisomnograma para entender qué está pasando con el requerimiento prolongado de oxígeno. Y aquí empieza a aparecer por la Sociedad Americana del Tórax, y que pasa mucho en Europa, los estudios simplificados, porque muchos centros no tienen disponibilidad de polisomnograma. El polisomnograma es un estudio costoso. De hecho, cuando compartimos estas experiencias desde los grupos de somnología, por ejemplo con Argentina y con Chile, apuestan más a estudios simplificados, porque digamos que el polisomnograma, como les digo, es un estudio que adquiere más costo. Entonces ahí empieza a aparecer qué pasa con los monitoreos de oximetrías domiciliarios y chequear la oximetría de los pacientes 12 o 24 horas. Estos software son especializados, o sea, este no es el marcador que les decía Ana, que el papá puede conseguir en una venta de Mercado Libre. Realmente hay que conseguir un equipo adecuado que tiene un software de precisión que sensa cambios de menos de 3 segundos y que les entrega un reporte de un software donde ustedes puedan ver cómo se comporta la estabilidad de la oximetría por gráficos que ya se los vamos a mostrar. Y tienen, entonces digamos que solo son de marcas especiales, NONI, Nelcor, que hacen parte de los estudios simplificados de monitoreo oximétrico de los pacientes, que también los pudiéramos usar. ¿Qué les digo yo mucho en el control oximétrico? Si lo que queremos ver es hipoxemia, persistencia de oxígeno, muy bien. Pero si lo que tenemos duda todavía es sonidos anormales o pausas, necesitan el estudio completo, porque necesitamos evaluar la parte neurológica y la parte respiratoria en su globalidad. Entonces, esto era lo que les decía, tenemos para diagnosticar varios, ¿sí? Generalmente, ¿qué usamos a nivel neonatal? Un estudio polisomnográfico vigilado, ¿cierto? Que es llevar a un niño a estudio, los que hacemos en las unidades neonatales o los que ya llevamos a un centro de medicina del sueño. Nosotros no usamos casi estudios tipo 2 en niños, que son las polisomnografías no vigiladas. Ese es un estudio que utilizamos mucho en los adultos. Va, lo monta una enfermera y el adulto lo dejan durmiendo y al otro día recogen los equipos, ¿cierto? ¿Por qué no lo hemos hecho mucho en niños y no lo piden mucho los papás que quisieran por la comodidad, por el hogar? Porque si un niño se nos desconecta, se cae el oxímetro, se cae la banda, ya perdimos esa noche de examen, ¿cierto? A no ser que esa enfermera pueda estar 12 horas allá en esa, pero entonces ya no sería pues realmente ideal para los centros de sueño, pues más fácil se traslada al centro de sueño. Hay un subgrupo en donde solo montamos cables para la parte respiratoria y hacemos estudios tipo 3, que son poligrafías respiratorias. ¿Quiénes son un paciente muy bueno para nosotros poligrafía respiratoria? Por ejemplo, el pie robano. Nosotros casi no le buscamos alteraciones centrales, queremos ver qué compromiso respiratorio tiene o no para las distracciones mandibulares y para las tracciones, entonces pudiéramos solo chequear la parte respiratoria. O como les digo, los estudios simplificados de oximetría, que estos que les mostré sí se puede ir para el domicilio del papá y después es una aplicación del celular y después bajamos el registro con los software que tiene especializados y nos sirven más para el monitoreo de oximetría. Entonces, esos son los estudios que pudiéramos hacer. Ahora, cuando tenemos un polisomnograma, ¿qué queremos nosotros que revisen en ese polisomnograma? Claramente, pues siempre habrá que chequear, como en las radiografías, que sea el paciente y la edad del paciente, ¿cierto? Y vamos a evaluar, fuera de esos datos generales, arquitectura de sueño, eventos respiratorios y ya qué pasa con el oxígeno y con el CO2. Entonces, ¿qué es importante y por qué es tan importante la edad? Porque cada edad se analiza diferente. Los niños hay que analizarlos con criterios específicos. O sea, nosotros tenemos criterios para menores de 2 años que generalmente lo hacemos hasta los 18 meses. Y hasta los 18 meses el grupo de medicina del sueño trabaja con tablas de lo que hay escrito en el mundo, de cómo se comporta un prematuro o un no prematuro a los 45 días, al mes, a los 3 meses, a los 6 meses, ¿sí? De los 2 a los 12 años trabajamos ya con reglas pediátricas. Y para esas reglas pediátricas ya hay unos valores estándar, ya no miramos tablas. Ya decimos, de 2 a 12 años, ¿tiene apneas centrales? Si tiene más de 5. Y tiene apneas obstructivas, leves, moderadas o severas, de 1 a 5, de 5 a 10 y más de 10. Cuando ya analizamos polisomnogramas mayores de 13 años, ahí sí utilizamos patrones dependiendo claramente, hay veces de síndromes genéticos, de contexturas, de fallas en el medio y todo, pero ya después de los 13 años, ese estudio polisomnográfico que les llega, nosotros generalmente se los interpretamos ya como adulto. Porque la Academia Americana de Medicina del Sueño dice que después de los 13 años un polisomnograma ya puede ser interpretado con los parámetros del adulto. Y lo otro muy importante que nos pasa es que hay que evaluarlo de acuerdo a la altura. ¿Qué nos pasa a nosotros? ¿Qué países tenemos, por ejemplo, aquí? Chile, Argentina, más o menos. Ahí están trabajando con 580 metros sobre el nivel del mar, 600 metros sobre el nivel del mar. Todo lo que se interpreta en Estados Unidos más o menos está a 0 metros sobre el nivel del mar. Pero, por ejemplo, para nosotros Colombia e incluso simplemente Medellín, Antioquia, es un gran lío. Porque nosotros tenemos 1425 acá, pero subimos a Río Negro y ya van 1800 y se van para La Unión y ya están en 2400, ¿sí? Entonces, esos cambios de altura también hacen que la interpretación del polisomnograma posiblemente sea diferente, sobre todo en nuestros niños del oriente antioqueño. tenemos claramente sexo, antropometría, antecedentes, indicación del estudio. ¿Por qué es tan importante? Y les digo esto porque siempre quisiéramos que cuando ustedes nos entreguen una orden de polisomnograma y nosotros nos sentamos a leer ese polisomnograma, quisiéramos leer de ustedes los antecedentes y la indicación, porque eso nos ayuda mucho también a buscar qué es lo que ustedes quieren encontrar. Porque hay veces yo lo leo y lo entrego. Y cuando llego a mi hospital, mi otro compañero neumólogo me dice, "Ay, es que yo estoy sospechando una enfermedad neuromuscular". Y yo digo, Dios mío, yo no le hice, o sea, no le entregué como una hojita aparte del CO2, de la capnografía, ¿cierto? Porque ya esa patología me indica a mí que tengo que buscarle otras cosas que posiblemente eran las que él quería chequear, más que si estaba desaturado o no, tenía eventos centrales o no. Después, entonces listo, ya vimos esos datos iniciales. Después van a pasar a arquitectura. En arquitectura del sueño, claramente hay muchas cosas, ¿cierto? Nosotros ponemos cuando se apaga la luz, cuando se queda dormido, cuál es la eficiencia, cuánto tiempo total lleva en la cama, cuánto tiempo total lleva dormido, ¿sí? Pero a grandes rasgos, lo que nosotros queremos más o menos que ustedes revisen rápidamente es, uno, el ítem que dice tiempo total de sueño. El tiempo total de sueño es muy importante para niños más grandes, idealmente mayor de 180 minutos. Y ahí un estudio puede ser interpretable. Si no, posiblemente nosotros les tenemos que reportar insuficiente tiempo, se sobrevaloran las apneas, se necesita repetir el estudio. Como les decía Ana, la población neonatal tiene ciclos de sueño muy diferentes y puede que incluso no alcancemos a monitorizar todas esas horas de sueño, sobre todo en las unidades neonatales, y tengamos mediciones de 60, 90 minutos, porque a la hora o a la hora y media ya el niño quiso comer, se despertó y se acabó el estudio, ¿cierto? ¿Qué es importante con el periodo neonatal? Simplemente que ahí sí no importan esos 180 minutos, sino que tenga porcentaje de sueño REM. Si no tuvo porcentaje de sueño REM, posiblemente no puede ser interpretado, pero claramente siempre lo va a tener, porque los niños generalmente cuando empiezan el sueño, empiezan es en fase REM. Entonces, generalmente podemos hacer estudios que son confiables y de medición adecuada. Y lo otro que queremos que se fijen es en la eficiencia de sueño. Esa eficiencia que para el niño grande es mayor de 85%, pero para el neonato podemos permitir eficiencias del 71, del 72, del 75 todavía como normales. Los porcentajes de sueño, ¿cuánto hay en sueño REM? En los neonatos nosotros simplemente les reportamos cuánto hay en REM y en no REM. Y en los más grandecitos ya empezamos a desglosarles todo, el N1, el N2, el N3, que es el sueño profundo. Entonces, y una parte muy importante acá es este índice de despertares. El índice de microalertamientos es cuánto se fragmenta un sueño y empieza a despertarse por hora. En teoría, un sueño es fragmentado mayor de 15 por hora. O sea, la mayoría tendríamos permiso de microalertarnos, moverse una piernita, cambiar de posición, hacer algún jadeo y volver a empezar, y eso considerarse como microalertamientos que están permitidos. Vamos posteriormente a los eventos respiratorios. Y como les decía Ana, pues claramente, cuando ya les reportamos eventos respiratorios de oxígeno, empiezan a aparecer los índices de apnea. Y cuando empiezan a aparecer las apneas, empezamos a saber que claramente es un común denominador más de la prematurez, sobre todo las de tipo central, y fuera de que evalúen las apneas centrales, las obstructivas, hay que evaluar un ítem que se llama hipopneas. Y hay que evaluar en la población neonatal y prematura este índice de respiración periódica, que también nosotros se lo reportamos en las polisomnografías, que está más o menos permitido por la literatura, que un niño en los primeros 3 meses de vida, sobre todo los más prematuritos, tengan esa respiración periódica que la mamá es capaz de definir, respira, pausa, sí, y que pueda estar más o menos entre el 5, algunos reportes hablan de máximo el 10%, pero de ahí para allá no deberían haber porcentajes de respiración periódica, ni después de los 3 meses, ni más altos de ese 5 a 10%, porque ahí hay que pensar en que empezar a evaluar diferente desde el punto de vista neurológico. Entonces, lo que les decía, vienen entonces los índices y cómo analizamos. Nosotros les entregamos un índice global, pero lo que quisiéramos siempre es que se fijaran en la tabla y pudieran ver cuáles son centrales, cuáles son obstructivas, cuáles son mixtas y cuáles son hipoapneas. Esto era lo que les decía, claro. Después de los 2 años, para nosotros es mucho más fácil hacer estudios, porque después de los 2 años, un niño en obstrucción, esta sería la clasificación, y después de los 13 años sería esta. Y ahí todo estaría bien y estaríamos hablando del porcentaje de apneas obstructivas que tiene permitido un niño. El problema es el día a día de nosotros, porque el día a día de nosotros no es después de los 2 años, el día a día de nosotros es antes de esos 24 meses. Entonces ahí empezamos a trabajar con tablas asociadas a la edad. Y empiezan a aparecer los diferentes reportes en el mundo, pero claro, la gran mayoría son de Estados Unidos, o sea, a nivel del mar. Pero ese a nivel del mar, miren lo que les decía, habla de eficiencias que la media puede hacer 71% como permiso. Pero empieza a hablar de eventos centrales, obstructivos y mixtos para esa población recién nacida, permitidos centrales hasta 27 y miren, permitidos obstructivos hasta 12,5. Entonces, cuando recibíamos polisomnogramas y decíamos 27, todo el mundo se alarma y dice, Dios mío, este necesita oxígeno para el resto de la vida. O obstructivos de 9, de 8, no necesita una nasofibro, hay que llevarlo urgente, hay que llamar al neumólogo, al otorrino, tiene una obstrucción severa de la vía aérea y no, está dentro del rango por lo que vimos, por volumen de la nasofaringe, de la orofaringe, por la debilidad de los tejidos, en que tengan un rango de obstrucción diferente. Pero entonces ha sido mucho más difícil porque empezamos a ver que cada uno va cambiando en el tiempo y esto era mucho lo que les decía con la altura, aunque este es un estudio de mi grupo en Bogotá, me ha servido mucho para esos pacientes del oriente antioqueño que medimos y que viven a gran altura para entender que los índices también son mayores y entonces miren cómo empieza a aparecer eventos centrales a los 3 o 4 meses todavía de 40 para los pretérminos y de obstructivos de 15 para los pretérminos. Y como también me permitió entender que las polisomnogramas no cambian tan rápido como quisiéramos. Entonces los patrones polisomnográficos de un niño cambian cada 4 meses, ¿sí? Entonces cuando hacemos chequeo que aquí y queremos que se lo hagan en 2 meses, en 15 días, en un mes, ahí no vamos a ver ningún cambio con los pacientes. Y si quisiéramos ver el real cambio que le pasa a un prematuro con el sueño para que se normalicen, entre comillas, esos polisomnogramas, tendría que llegar a cumplir 18 meses ya de edad. Entonces, más o menos lo que tratamos de hacer para nosotros leer y darles un reporte adecuado es extrapolar estas alturas sobre el nivel del mar y trabajar más o menos con esos valores. O sea, entendiendo que el primer mes podrían ser más permisivos en los índices que les reporten y después de ese primer mes, miren que todavía tienen permiso hasta los 3 meses, incluso por la cohorte chilena del doctor Pablo Brockman, de trabajar con apneas centrales de hasta 24 pero miren que las apneas obstructivas tienen que empezar a normalizarse y a estar cada vez más cercano de 1 o 2, dependiendo de la altura sobre el nivel del mar. Este es uno que nosotros usamos mucho en la unidad neonatal, que es, digamos, la investigación de diferentes centros en los primeros 45 días para no alarmarnos tanto en las unidades neonatales y saber a quién terminamos estudiando o no con estudios adicionales. Entonces, en esos primeros 45 días, dependiendo de la literatura, podríamos ser tan permisivos como tener eventos centrales de hasta 45 y como tener eventos obstructivos de hasta 19 por hora, sin que eso represente que necesitan un estudio adicional, pero esto es en los primeros 45 días. Entonces, esta es una tablita que nosotros cargamos como en los primeros 45 días, después cargamos más o menos esta, que ya da el reflejo del primer mes, los 3 meses y los 12 meses, o esta que hicimos de construcción en nuestro centro, donde claro, van a ver que tiene reporte de los estudios que hicimos en Bogotá, pero también de los estudios de Denver, que podrían estar más o menos a una altura similar a la de Medellín, de estudios de Alemania, y donde empieza a cambiar por la edad cómo deberían ser los índices. Posteriormente de evaluar los índices, evaluamos oximetría como claramente uno de los patrones más importantes para nosotros. ¿Hay desaturaciones mínimas? Sí, pero casi no nos fijamos en esas desaturaciones mínimas porque hay veces reportan mucho cómo se desconectó un oxímetro. Entonces ustedes dicen saturación mínima 37, Dios mío, lo peor. Y cuando se dan cuenta en el gráfico, pues posiblemente ahí hubo un bajonazo muy grande y se desconectó como el equipo. ¿Qué sí miramos mucho? El T90 y el ODI. El T90 es el porcentaje de tiempo que pasa un niño saturando menos de 90%. Y más o menos también, aunque quisiéramos que todo estuviera más estandarizado, trabajamos con rangos, tenemos un 10 a 12% de permiso. Cuando le reportemos T90 mayores de 25%, ese paciente tiene una hipoxemia crónica sostenida. Y con el ODI, o sea, el índice de saturación, trabajamos con límites de 3 o 4%. Si les reportamos ODIs más altos, significa que ese niño sí tiene una hipoxemia importante y hay que seguir prolongándoles el oxígeno. ¿Cómo hacemos el T90? Generalmente nosotros les entregamos una tabla así, donde dice cuánto tiempo saturan menos de 90, de 85, de 80, de 75, y les entregamos esta gráfica. Ahí, ¿qué queremos? Uno, que con la gráfica ustedes se den cuenta, esto que yo les decía, que esto sí sea estable, que esto no tenga un bajonazo grande por una desconexión, por ejemplo. Y que acá, en este T90, aunque nosotros se lo calculamos, si no, tendrían que sumar los minutos que pasa saturando menos de 90 y ustedes sacarle el porcentaje dependiendo del tiempo total de sueño que tuvo ese niño. ¿Por qué les digo que es importante? Y esto lo entregamos en el polisomnograma, pero esto es también lo que entregan los reportes de NONI, no de MELCOR, de oxímetros domiciliarios. ¿Por qué? Porque lo que nosotros queremos es trabajar realmente con estos gráficos. Y estos gráficos nos permiten ver, por ejemplo, incluso si esto les podría dar la alarma de cuando les entreguen el reporte, decir, ¿será que este paciente sí tiene un patrón de apnea obstructiva y yo lo tengo que pasar a un estudio más especializado? Porque cuando vean el reporte, tiene estos clústeres de desaturación, que generalmente son así como en 3. o cuando les entregue este reporte tiene unas agujitas finas. Esas agujitas finas dicen que posiblemente ese paciente tenga apneas centrales o respiración periódica, o sea, agujitas más desaturaciones. O simplemente tienen bajito el nivel de oximetría, o fuera de bajito el nivel de oximetría también tiene los clúster y uno dice también tiene apneas. Entonces, cuando ese patrón que ustedes vean en el registro les salga con alteración, ese paciente tiene que ir a polisomnograma, porque hay que entender si tiene una apnea o no, o una respiración periódica o no diferente. Hipoventilación. Hipoventilación también les entregamos nosotros en los reportes y ahí les aparece generalmente si nosotros tenemos CO2 más de 50 en el 25% del tiempo total de sueño, ese paciente hipoventila. Mis residentes trajeron un trabajo de cómo, por ejemplo, en la clínica bolivariana, 3 neonatos con apneas centrales todo el tiempo, fallo en la respiración, pues realmente lo que había no era apneas, era una hipoventilación. Claro, por un trastorno genético como mutación del FOXP2B y era un síndrome de Ondina, pero la hipoventilación para nosotros es muy importante porque la hipoventilación realmente solo corrige con ventilación no invasiva. Paciente que no tolere va a traqueostomía, pero paciente que tolere, hemos tenido niños que hemos adaptado. El problema es que estas máscaras para adaptación de CPAP en las unidades neonatales y en el seguimiento más o menos son aptas para mayores de 5 kilos. O sea que los que tengamos muy chiquitos, todavía 2, 3 kilos, 4 kilos, o hay que soportarlos en la unidad neonatal y nosotros tuvimos uno de nuestros niños que duró 7 meses en la unidad neonatal, ya ni cama teníamos, hubo que pasar una cama de pediatría para la unidad neonatal porque era un síndrome de Ondina y hoy ese hombrecito está divino, perfecto, tiene 8 años y el proceso lo hicimos solo con ventilación no invasiva, pero los otros 2 tuvieron que ser traqueostomizados porque era más severa la hipoventilación. Y capnografía, aunque todos quisiéramos tener capnografía en la etapa neonatal sobre todo y en los niños incluso, piense que hay una población que siempre tiene que tener capnógrafo porque el capnógrafo es difícil y se nos daña mucho en los centros. Hay veces ustedes nos piden con capnografía y nos toca reportarles que está dañados los sensores, que no hemos podido conseguir las herramientas. ¿Quiénes hay que pedirles sí o sí capnografía? Si no, ese estudio realmente no les está aportando nada. 1, malformaciones craneofaciales. 2, alteraciones que creemos que en su mayoría son neuromusculares. Todo lo que tenga que ver con malformación congénita, como Down, como mucopolisacaridosis, tiene que ir con capnografía. Los hipotiroideos también son muy hipoventiladores, las anomalías de la vía aérea superior y los prematuros con displasia broncopulmonar generalmente. Este es el grupo que la literatura puede que sí, puede que no, pero los otros grupos de malformaciones craneofaciales, neuromusculares y síndromes genéticos tienen que ir con medición de capnografía. Entonces, vamos a ver ahora qué hacemos con la realidad. Anita, te invito, y acá también tenemos a la doctora Carolina Serrano, una gran experta en medicina del sueño y sobre todo en este periodo neonatal, porque este ya es el día a día, ¿cierto? Entonces el día a día de nosotros es, por ejemplo, este paciente de 4 meses, que lo que yo les decía, listo, no es tan, fue prematuro, se fue por la casa, pero resulta que no han podido quitar el oxígeno nunca. Y hace todavía unos eventos como de cianosis. Y hacemos el estudio y decimos, pues lo que queremos evaluar con ese niño es si podemos retirar ese oxígeno o no, que son la mayoría de indicaciones del polisomnograma. De pronto. Entonces, sentémonos. Entonces, mire, 4 meses. Prematuro corregido, que realmente son 2 meses. Entonces, tenemos eficiencia de sueño de 92, ¿sí? Y estamos en esos primeros 2 meses de vida corregidos. Bien, ¿no? Porque claro, lo que nosotros quisiéramos a futuro es que ustedes no se tuvieran que leer nuestro reporte, sino que igual que aprendieron a buscar en el ecocardiograma la presión de la pulmonar, también en este ustedes buscaran 3 cositas que les sirvieran para decir esto sí, esto no.
Y sobre todo porque muchas veces uno tiene que fijarse primero si es interpretable o no el estudio, ¿sí? Entonces es importante la eficiencia. Si el paciente durmió menos del 50%, es un estudio no interpretable. O sea, lo que les están diciendo realmente no está porque el paciente no durmió. Entonces uno tiene que fijarse, no, tiene un montón de apneas. Y uno dice, ay, qué montón de apneas, pero uno se pone a ver y el paciente durmió un 30, un 40%. No en todos los centros reportan realmente en las conclusiones cuánto es la eficiencia de sueño. También mirar que es importante la calidad, o sea, que hayan tenido, o sea, que te reportan el estándar, o sea, si utilizaron, que utilizaron el termistro, o sea, utilizaron y que si fueran, y cómo lo leen, si lo leen como neonatos, o sea, para menores de 1 mes o para menores de 1 año o en niños, porque también eso afecta.
Ahí es muy importante, por ejemplo, cuando generalmente el reporte sale sueño REM, no REM, ahí estamos interpretando mucho en periodo neonatal y lo leemos con ondas para esa población específica. Cuando ya les desglosan N1, N2, N3, REM, le están desglosando un poquito para niño ya más grande después de los 2 meses. Eficiencias globales más o menos dijimos, sí, el más grandecito puede ser 85%, pero recuerden que ese periodo neonatal tendría 71%, pero este decimos que tiene 92%, o sea, por ahora estamos normal, ¿cierto? Empiezan a aparecer de eso que les decía Ana, de esa arquitectura, cómo es la eficiencia y qué tanto se fragmenta o no ese sueño. Entonces, este en microalertamientos tiene 9.9 por hora. Bien, permitido, no, normal, ¿cierto? Y acuérdense que, aunque eso también debería ser por tablas, hay veces nosotros hemos intentado simplificar en el camino para todos porque nos ha tocado así, pero cada cerebro y cada niño tiene sus particularidades claramente, pero digamos que globalmente trabajamos como en ese 15, ¿sí? Y más de 15 por hora si es un sueño fragmentado que hay que empezar a ver que lo fragmenta. Entonces, por ahora, digamos que vamos bien. Y empezamos a ver la parte respiratoria. La parte respiratoria siempre les va a alarmar mucho si lo miran en número absoluto. Porque si lo leen, este niño tiene 154 apneas. Ya, la muerte. O sea, chao. Entonces hay que mirarlo realmente por índice, ¿sí? No pueden mirar el valor absoluto. Entonces aquí empieza a aparecer donde si no queremos mirar el carretazo, lo que queremos es que miren la tabla, busquen la tabla. Y cuando busquen la tabla, ahí empiezan a pensar qué pasa con los eventos centrales, obstructivos, mixtos e hipopneas. Claro, acá hay un truco difícil porque hay algunos estudios, por ejemplo, el software donde lee la doctora Serrano es súper bueno porque saca hipopneas centrales, hipopneas obstructivas. El mío no, el mío saca hipopneas globales. Entonces usted no sabe si esas hipopneas se las va a sumar a lo central o a lo obstructivo. Truquito, si hay ronquido, respiración paradójica o ondas de resistencia, se lo suman al obstructivo. Claramente, yo les tengo que poner en el informe que hubo ronquido, ondas de resistencia o respiración paradójica para que ustedes sepan a dónde suman esas hipopneas, ¿cierto? Por ejemplo, este no tuvo ni ronquido, ni ondas de resistencia, ni respiración paradójica, o sea que estas hipopneas se las sumo ¿a cuál? Al central. O sea que este central, que es de 11,5 5 el índice, le sumo 10,2 también de las hipopneas. O sea que este niño en eventos centrales, digamos que grandes, tendría 22. Entonces aquí empieza el lío, listo, 22. Entonces cuando uno no saca la tabla, uno dice, ay, 22 me parece como altico, ¿sí? Uno dice, bueno, 2 meses, 22, ¿será que sí, será que no? Mira la tabla de saturación, ¿qué tanto lo compromete eso o no? Entonces miran en la tabla y uno a grandes rasgos dice, gracias a Dios no hay nada debajo del 80, 85, 75, por allá ese niño no llega a desaturaciones. Y pueden hacer, digamos, lo que yo les decía de cómo sacar ese T90, cómo sumar el tiempo que pasa saturando menos de 90% y en relación al tiempo total de sueño, aunque se los deberíamos entregar nosotros en el polisomnograma, digamos que este niño tiene un T90 del 6%. O sea que por ahora, digamos que pudiera estar dentro del límite normal. Todos hay veces tenemos permiso de saturarnos en el sueño, de hecho los adultos hay veces podemos pasar en 86% un largo periodo. Claramente estos son cerebros con una plasticidad y con un desarrollo diferente que no quisiéramos dejarlos en riesgo, ¿cierto? Pero entonces, o si no analizamos las tablas, lo que pasa es que estos himnogramas son muy traicioneros porque hay que ver, porque si yo miro solo el himnograma, yo digo, uy no, qué montón de eventos centrales y qué montón de hipopnea. Este niño que se quede con oxígeno mucho rato, ¿sí? Porque veo pura rayita, que es esta de eventos centrales, rayita, rayita de evento, o esta de hipopnea, rayita, rayita, rayita.
Si ustedes se fijan en el himnograma, ¿sí? Podemos mirar, esta es como la parte de la arquitectura del sueño, entonces podemos mirar en rojo, es el sueño REM, ¿sí? O el sueño activo, y entre más abajo es más dormido el niño, o sea, lo que uno llama pues el sueño N3, que es el verdecito, lo que son los negros son los despertares o microdespertares, y ahí vamos mirando N1, N2. Miramos que con respecto a las apneas tenemos que mirar la relación cuando se dan más, si en sueño REM o en sueño no REM, porque como les había dicho antes, la mayor inestabilidad en respiratoria se da en sueño REM. Si nosotros vemos apneas, aunque sea un valor no tan alto, pero que sean dependientes del REM exclusivamente, nos prenden las alarmas de que realmente no es solamente, eso no es normal. Una de las cosas es neuromuscular, pudiera ser, y otra cosa es a nivel también medular. Hemos tenido pacientes con alteraciones, inclusive alguna vez con la doctora con algunas fracturas o algo en el canal del parto, y era por eso.
Mirar los himnogramas también es muy importante. Pero entonces digamos que en conclusión, si a mí me llega este paciente del plan canguro, prematuro, ya tiene 2 meses de edad corregida, tiene una eficiencia del 92%, unos microalertamientos de 9 por hora, un índice que es de 22 y una saturación que realmente en términos generales 90, 91 y el tiempo que pasa menor de 90 es 6%, pero nunca menor de 85. Yo que le respondo a ustedes con tranquilidad, pueden ir siguiendo el patrón normal del retiro gradual de oxígeno que les tolere en su plan canguro. Que no les toleró, que sigue muy bajito, no importa, pero ya a un ritmo normal, sin el miedo de polisomnograma de control, no, resonancia magnética o no, estudio adicional o no, porque está dentro de su evolución normal permitida de la prematurez. ¿Claros ahí? Yo sé que el 22 alarma mucho, pero ahí es donde yo les digo, esto hace parte, claro, de un trabajo en equipo. ¿Qué es lo que yo les digo? Tampoco, digamos que si quisiéramos que todos los programas de seguimiento, pues claramente tuvieran mucho entrenamiento en esto, además porque las conclusiones también son muy raras, porque hay veces muchos de los estudios, nosotros somos somnólogos, pero somos otorrinos, neumólogos, neurólogos, somos de niños y de adultos. Nosotros leemos adultos también. El entrenamiento de somnología es global, no es solo para el periodo neonatal. Entonces puede que un día el polisomnograma esté reportado, o sea, por un compañero mío neumólogo de adultos. Y si no se lee bajo los parámetros de niño o bajo las tablas, por eso es que no queremos que se fijen en la conclusión, sino que ustedes más o menos puedan hacer el rastreo y el sondeo del examen. Dime. Sí. Súper lindo.
Habíamos hablado también eso y también cuándo se debe pedir una polisomnografía de control. Muchas veces al alta vemos mucho, porque yo los veo más es cuando me los mandan para refrendar pues la orden y me los mandan a los 15 días. Yo veo la polisomnografía, hace 15 días tiene oxígeno, hace 15 días se la hicieron y están pidiendo y son los papás ya con la angustia, es que necesito la poli porque si no, no me retiran el oxígeno. Y me dijeron en plan canguro que no me retiraban el oxígeno con esa poli y son papás que viven en vereda, que para un oxígeno, un transporte de oxígeno, son papás que se trasnochan, o sea, se ponen turnos porque no pueden, porque son con el miedo a que si el niño se les cae el oxígeno se les va a morir. O sea, literalmente es eso, son mamás que de entrada pues una maternidad deprime, tiene más riesgo pues de depresión, también la parte de que no duermen, y ya con esto es peor. Entonces, mirar cuando realmente que no puede haber cambios son 12 semanas, ¿sí? Una polisomnografía antes de eso, sobre todo para la parte respiratoria, no nos va a cambiar mucho. Y no por eso tenemos que dejar 12 semanas un niño sin mover. Hemos tenido niños con oxígenos altísimos, oxígenos permanentes, y porque a veces no funcionan bien los plan canguro. Eso ya depende, ¿sí? Porque digamos que cuando eso ya hablamos, pues es un paciente que es neuromuscular, entonces digamos que depende de las guías, ¿sí? Generalmente cuando diagnosticamos los neuromusculares debe tener una polisomnografía, aunque sean asintomáticos, como un basal. Y de acuerdo a las guías, si está asintomático, depende, hay unas que hablan de cada año, cada 2 años, y si están sintomáticos se hacen antes, hablando pues de los MP, pues los mucopolisacaridosis o los neuromusculares, incluyendo los AME.
Igual que para el Down, en los primeros 2 años debe tener una normal, así ese papá diga que duerme perfecto. Y de ahí, dependiendo de los hallazgos, ya se programa el seguimiento. Súper buena pregunta. Bueno, miren este que también nos pasa un montón en el plan canguro. Y tenía antecedente de apnea, pero le retiraron, quiero hacer una precisión en lo que decía la doctora Serrano, que es súper importante, porque claro, lo que nosotros queremos es saber qué hacer con ese oxígeno. Entonces sí es muy importante que en la orden vaya por lo menos sin oxígeno o iniciar el examen sin oxígeno, que ya en medio de la terapeuta o quien lo está montando diga no toleró, estaba muy desaturado, tuve que iniciar oxígeno. Ya nosotros cuando lo leemos les ponemos ahí a la 1 de la mañana por desaturación sostenida se inicia oxígeno y ustedes pueden ver el comparativo de con o sin. Pero si se inicia globalmente con oxígeno, pues ya la terapeuta monta y así quedó el estudio y no nos sirvió para saber qué hacer con ese oxígeno o no. Entonces miren, por ejemplo, era una apnea central, pero ya le retiraron el oxígeno, estaba súper bien. Y en la consulta de la nada dijimos, ay no, bueno, no, como con tanto antecedente, que le hagan un examencito a ver cómo le va en su vida sin oxígeno. Pues cómo le va en su vida sin oxígeno, resulta que este pobre, que ya tenía 8 meses, nos dio unos microalertamientos de 27 por hora, un índice central de 35,3, desaturaciones asociadas e hipoventilación. ¿Qué hacemos? Que recibimos, que Uno ahí en la consulta, 8 meses, y ve este desastre de polisomnograma. Señora, tranquila, no pasa nada, es la prematurez. Digamos que estos sí nos alarman, ¿cierto? Porque entonces, claro, yo ya reviso, o sea, así no revise las tablas, yo ya sé que en 8 meses esto en teoría tiene que estar bajando. O sea, 35 no podía haber, ¿cierto? Y hipoventilación también me prende la alerta, ¿cierto? Entonces empieza uno ya a buscar qué le pasa al corazón, qué le pasa al diafragma, qué le está pasando a los músculos, qué pasa desde el punto de vista neurológico, qué pasa incluso desde el punto de vista genético, para ver qué hacemos con estos pacientes. Buena pregunta.
A ver, sí, como terapia puente estoy de acuerdo. Lo que pasa es que a veces, muchas veces en la asociación que el oxígeno, digamos que quita las apneas, a veces es más, yo le he dicho a André, a veces es más cosmético, porque realmente tú la causa es la que realmente pues la que tenemos que identificar, cuál es la causa para poder mejorar las apneas. Por ejemplo, tú tienes un neuromuscular y el oxígeno no le va a quitar las apneas, o sea, muchas veces va a necesitar el soporte, ¿sí? Pero mientras tanto podemos mirar, y muchas veces es también porque no hay interfaces tan pequeñitas, o a veces no tenemos pacientes que puedan estar domiciliarios con interfaces, sino que tendríamos que ponerlos en un remeo, por ejemplo, en una terapia de crónicos. Entonces por eso es que a veces ponemos ese oxígeno puente. No es permanente porque ellos realmente no es por hipoxemias, es más por la parte ventilatoria.
Sí, la respuesta es sí. Igual que a todos nos pasa, nos llega esto, qué susto. ¿Qué pasó en el tiempo? Señora, usted lo ve bien y todo, pero hay un reporte normal que nos obliga a buscar otras causas. Cerebro en desarrollo, plasticidad y todo, no lo sacrificamos a hipoxemia crónica, sobre todo porque hay muchas desaturaciones asociadas. No sería el ideal en hipoventilación, es real, y por eso ampliamos tanto los estudios, pero inicialmente sí lo reiniciamos. Titulado también dependiendo ya de la oximetría, porque tampoco justifica que este se vaya con 1 litro para la casa, no. Si en el plan canguro ese niño te sostiene una saturación basal de acuerdo a tu altura y todo, con un 64avo, con un 32, porque esté este grado de severidad no indica que tenga que tener altos flujos de oxígeno, que eso también es muy importante y hay veces les causamos más daño en esa hiperoxia. ¿Tenían otra pregunta? No. Y este va muy en relación a eso que hablamos, pero por ejemplo miren que independiente de que tiene 8 meses y que creemos que los índices son más altos y que le dio 141 y que no está corrigiendo con oxígeno y que también se desatura, el CO2 normal me da un parte de tranquilidad en cuanto a ahondar más en estudios adicionales. Entonces, en por ejemplo, otra de las cosas que nosotros aprendimos en medicina del sueño era que, claro, uno cree que mientras más alto, si es 180 es peor, no, o sea, en el rango más de 30 para un subgrupo de pacientes es severo, o sea, es severo igual 31, 50 o 150, ¿sí? Está dentro del rango de severidad. Entonces, no quiere decir lo que les decía, que por más índices que les den alterados necesita más oxígeno, no, necesita estudio. Posiblemente sí, empezamos y sí queremos mucho a terapeutas pilosas que dicen esto no corrige, voy a subir un poquito más, voy a subir un poquito más y que nosotros les podamos entregar, no corrigió a un 64, pero sí les corrigió a 0.5, ¿sí? Y pudiéramos entregarles a qué rango corrigió. Pero por ejemplo, que no tiene hipoventilación, que hace parte del antecedente de prematurez, yo lo esperaría en el tiempo, que simplemente me indicó polisomnograma, que todavía necesita más tiempo de maduración. Sí, exacto. Perfecto. Le podríamos seguir disminuyendo en el canguro, que es lo que me dice, porque claro, es un reporte muy ligado a prematurez, ¿cierto? Empieza uno a pensar un poquito porque claro, nos dio un porcentaje de respiración periódica muy aumentado, que inicialmente uno dice, voy a hacerlo como por prematurez, pero puede que a futuro necesite otros estudios, que ahí empieza, ¿qué pasa si se me está prolongando mucho el oxígeno? Entonces, si yo ya tiene 8 meses, pero tengo 6 meses adicional, ya digo, no, esto hay que estudiarlo diferente. Pero si no, sí puedo ser permisiva en el canguro de volver a retomar sin que haya un polisomnograma de control. Diferente a si hay cosas, digamos, que me alarmen. Y nuestro último caso clínico.
Acá les quería ver un poquito más la parte de cómo reportamos nosotros la parte eléctrica, ¿sí? Con un poquito, entonces es un paciente que podemos ver que tiene un intervalo interbrote, que es si el intervalo interbrote es entre si hay discontinuidad o no, de 0 segundos, y un porcentaje de sincronía interhemisférica de 100%, o sea, está igual la parte derecha de la parte izquierda, y tiene encroche frontal y presencia de un delta occipital, que son las mismas gráficas que vemos acá. ¿Ustedes consideran que es un niño pretérmino o es un niño a término? Con lo que hablamos. ¿Quién dice que es un niño pretérmino? Solamente con esto. ¿O que es un niño a término? ¿Sí? Esto nos habla de que es un niño a término, o sea, que es solamente con esto, estos grafoelementos de maduración que les estamos diciendo y que los vemos acá, es que nos dicen que es un niño a término, ¿sí? Y esto es lo que podemos ver cuando vemos, entonces ustedes pueden ver que a 30, que es la velocidad en que reportamos la parte eléctrica, ¿sí? Vemos acá la parte de los canales eléctricos. Para los que no hayan visto las gráficas de Poli, está también la parte pues, de mentón, la parte de ocular, la parte de los pies y la parte ya respiratoria, ¿sí? Y la parte de saturación y de movimientos. Y así es como marcamos como si fuera despierto, el sueño REM y el sueño N1, que sería el sueño no REM. Y en la parte respiratoria, esto es lo que nosotros miramos, o como si ustedes quieren mirar no solamente la gráfica, sino que quieren ver nosotros qué es lo que vemos en el estudio. Estas son las famosas apneas centrales por respiración periódica. Así es que las vemos. Listo. Y mira que cuando estamos mirando la parte respiratoria es a 120, o sea, mucho más rápida. Y nosotros también miramos que para poder reportar tenemos que mirar que realmente si esté en la curva, que esa curva no esté plana, porque eso nos habla, será que es que se movió el sensor, ¿sí? Y acá vemos que es un paciente que ya sabemos que es a término y que nos reportaron 31 pausas respiratorias. Esas 31 pausas respiratorias fueron menos de 20 segundos, pero que generaron disminución de alertamientos, ¿sí? O que generaron desaturación, porque nosotros también marcamos las pausas respiratorias centrales que causan baja la frecuencia cardíaca, y entonces así es como la reportamos. También miramos si tenemos respiración periódica, ¿sí? Y el AI nos dio 31. Así con este paciente, entonces, ¿ustedes qué harían? ¿Le pondrían oxígeno? ¿No? ¿Normal? ¿Anormal?
Se vale la llamada a un amigo. Se vale la llamada a un amigo y yo voy a llamar a mi amiga Ana Carolina Sierra.
Exacto. ¿Qué les gustaría saber? O sea, ¿qué antecedentes tenía el paciente? Es un paciente a término, fue parto por cesárea, cesárea por decisión materna, ¿sí? Un embarazo normal, no tenía ningún riesgo, un Apgar normal, ¿sí? Y el paciente en las primeras 24 horas estaba normal, pero ya cuando le iban a dar de alta empezó con desaturaciones, dormido. ¿Qué más quieren saber? tenía 39, nació con 39 más 5 y tenía en ese momento, cuando se hizo la polisomnografía, 2 días de vida. ¿Algo más? No, era un paciente con buen peso, buena talla, no tenía nada, un perímetro cefálico normal, no tenía ni dismorfias, ni tampoco tenía pues soplos, ni tenía nada, el ecocardio le salió normal. Gases normales, no tenía movimientos anormales, se los pidieron pues porque cuando se iban a ir le hicieron el monitoreo y le salió eso. Hizo la apnea. Ahí sí, ahí empezó la mamá. Es que está como un pollito. Es que está como, no, eso es normal, mamá, con solecito, ¿sí? Y se le cae, ¿sí? Era un paciente que tenía una ictericia por hipoalimentación, ni siquiera pues por incompatibilidad de grupo, ni nada, y estaba deshidratado, porque los gases al principio fueron normales. Al principio fueron un poquito como una acidosis metabólica pero leve y ya después normal, era más por hipoalimentación, ¿sí? Y entonces eso no, pero el niño se ganó casi, o sea, nos llamaron porque entonces necesitaba resonancia, ¿sí? Con todo lo que implica de sedación, una resonancia. Entonces también la invitación es no solamente sí, puede que ese niño tendremos que mirar si necesita oxígeno o no para la casa, pero es también ahondar en la etiología, o sea, buscar cuál es la causa de la apnea, no solamente quedarnos que necesita oxígeno. Ese es como... No. No, no tenía kerníteros, tenía una ictericia por hipoalimentación, no tenía niveles de kerníteros. No, no. Normales.
Sí, mucho. Acabamos de diagnosticar 2 la semana pasada en Bolivia. Hay un término que se llama kernicterus de baja bilirrubina, que está dentro del espectro de la encefalopatía por bilirrubina. Entonces hay unos pacientes, los prematuros, que es el típico prematuro con la famosa ictericia multifactorial, que es de la que estamos acostumbrados a ver al prematuro, que además tiene NPT y que viene de no tener vía oral muy prolongada y que tiene un poquito de hilio. Bueno, entonces lo que se ha descrito es, el caso típico es el prematuro que nunca hizo niveles de exsanguino, que nunca hizo niveles para fototerapia intensiva, que le pusiste una foto 4x4 2-3 días, y el niño tuvo 8 miligramos por ciento de bilirrubina, al otro día 8.5, al otro día 7, al otro día 9, al otro día 8, y empezó a bajar, a bajar, a bajar, a bajar. Ese niño no tuvo niveles de exsanguino, pero tuvo niveles anormales más de 3 días seguidos. Entonces lo que se ha descrito es que hay una susceptibilidad genética en las bombas que expulsan la bilirrubina en la barrera hematoencefálica, que hace que con muy bajos niveles de bilirrubina no tienes niveles de exsanguino, no haces encefalopatía aguda, pero haces apnea. Y es una de las causas de apnea persistente del prematuro que no cumple con lo que decía la doctora Andrea. No es un displásico broncopulmonar, no está anémico, no tiene nada que tú digas, esto me lo explica, y llegan a las 40, 41, 42 semanas y siguen haciendo apneas centrales. Claro, entonces ese es el caso que está diciendo la doctora Ana. Nosotros acabamos de tener 2 casos, yo no sé si por aquí está Andrea, la residente. Bueno, acabamos de tener 2 casos, son niños que se ven muy bien, los niveles no son lo suficientemente altos y la única manifestación es apnea. Una de las cosas que les están diciendo ellas es que la apnea no es igual a oxígeno, la apnea es ¿por qué hace apnea? Y luego yo le pongo el oxígeno. Entonces una de las cosas que sucede con estos pacientes muchas veces es que llegan con el famoso BRUE, les hacen la poli, en la poli están llenos de apnea, se pone oxígeno y se va para la casa. ¿Y cuál fue la causa? Entonces, yo creo que este caso que las doctoras les están poniendo es un caso muy representativo, así como la doctora Andrea lo decía, el kernicterus de baja bilirrubina es frecuente, se nos pasa y sí hay que hacer la imagen. Lo que pasa es que la imagen no lo va a sanar. Aquí lo importante es determinar el factor de riesgo que esto le genera a muy largo plazo. pero en teoría no lo puedo llamar encefalopatía aguda por bilirrubina porque no tienen marcadores de la escala Wnt, ¿cierto? Sino que esto es como una patología aparte y es una susceptibilidad muy particular.
Y los reportes, lo que les decía la doctora Carolina, están en la literatura con valores de bilirrubinas menores de 10 generalmente y hacen parte de una susceptibilidad. ¿Cuál es mucho la invitación de esto? Que claro, los vemos con polis muy alterados y siempre queremos buscar la normalización de la poli, ¿no? Hay veces no hay necesidad de encontrar esa normalización de la poli si el paciente va evolucionando bien. Muchas gracias por este espacio.
Bueno, damos por concluido el día de hoy. Los esperamos mañana. Recuerden que a las 6 de la mañana tenemos presentación de trabajos libres y a partir de las 8 ya empezamos con las conferencias. Así bueno, traten de descansar. Hasta luego.